1 2. You might want to bring that down just a hair, dude. Check 1 2. 1 2. Check check. Testing 1. Checking 2. Check 1 2. 1 2. Check 1 2. 1 2. Check check. Testing 1. Checking 2. 2. Check check check. 1 2. Testing. Testing 1. Checking 2. 2. Check 1 2. Too hot. Check 1 2. 1 2. Check check. Testing 1. Checking 2. 2. Check check check. 1 2. Testing. Testing 1. Checking 1. Testing 2. Just hitting my zipper. Good. Check 1 2. 1 2. Too hot. Too hot. Checking 1. Testing 2. 2. Check check check. 1 2. Testing. You can bring it up just a little bit. Checking 1. Testing 2. 2. Check 1 2. 1 2. Too hot. Too hot. Checking 1. Testing 2. 2. Too hot. Bring it down. Checking 1. Testing 2. 2. Check check check. 1 2. Testing. Testing 1, that's good. Check, check, check. Too hot, too hot. Checking 1, testing 2, 2. Check, check, check. 1, 2, testing. Testing 1, checking 2, 2. Too hot. Checking 1, testing 2, 2. Check, check, check. 1, 2, testing. Testing 1, checking 2. Six, too hot. Checking 1, testing 2. Bring it up, just check 1, 2. 1, 2. Check, check. Testing 1, checking 2, 2.
Good morning, everybody. How's everybody feeling? Everybody wide awake, had their breakfast, got their liquid inspiration, aka coffee, in their system. Very good. That was more for me. Hope everybody had a wonderful evening last night. Welcome back, day 3 of the Health 2.0 conference. Our final day, and of course, big shout out to our gold sponsors, Inlytic and Outcome MD, for helping make this possible. After 2 days of learning and networking, we are going to take it up a notch starting now. We have one more day today filled with you with just amazing panel, keynotes, and everything in between as we have been. So thank you for being here and sticking it out for the remainder. And of course, we will have a couple of our award sessions and recognition programs coming up today as well. So, friendly reminder before we get started, please don't forget to share in your tagging of all your photos. We want to be right there with you. We want to look through all of your photos and remember everything with you. So anything that you're posting, whether it's, you know, an award or maybe meeting a new connection, taking a picture, please be sure to tag us. Hashtag health, the number 2 CONF. On that note, let's get our first panel kicked off. This morning panel features a group of CEOs and founders coming from different verticals of healthcare and wellness sectors. During this discussion, they'll discuss the need to move away from relying on outdated methods of patient care and instead focus on utilizing innovative strategies that will allow us to get ahead of these problems before they even occur. Please put your hands together for the session's moderator, Dr. Jessica Grundler, CEO and founder of Clinical Project Resource LLC. Come on up, Jessica.
Thank you guys for joining us this morning. So why don't you go down the line and introduce yourself and tell us a little bit about your business?
Yeah, I'm Tanvir Hassan. I'm the CEO and founder of Icon. We have been working in New York for our last almost 5 years, and we are working with the primary care physicians, the specialists, and also behavioral health counselors. So also we are trying to make a system where the system can go towards patient-centered value-based care model. So that's why we are consulting for patient-centered medical home, all the primary care physicians, but now also for the specialists, they are doing the PCSP, that's similar to PCMH. And also we help the doctors with the right coding, billing, their administrative complexity. So that's what we are doing now.
Very nice. My name's Lance Wright. I work in the addictions field. As I met another friend earlier this morning, I have almost 30 years of sobriety myself, so there's a passion in the field to help people because someone did it for me many, many years ago. And every day I get to see clients in the field where there's a huge gap between treatment and success, and the success rates are not very nice, for lack of a better word, and we'll get more into that. But I have a company called Life Over Addiction, which basically is treatment doesn't end when treatment ends. It needs to continue, and people need that support on the other side. And there's a discussion that needs to be had, and I'm grateful to be at the forefront of that.
Thank you. Las Vegas is a perfect place to appreciate why you're sober as you walk around.
I remember it, yeah.
Michelle, would you like to introduce yourself?
Yes. Good morning, everybody. My name is Michelle Shaw, founder and CEO of Compassionate Solutions. We are a healthcare staffing company, and we recruit the best nursing healthcare staff in the world. So if you ever have a nurse or a healthcare worker from our company, you'll probably want to keep them. But my passion and our passion is healthcare providers and taking care of them. That is a huge gap, as you can imagine right now, especially in the healthcare field pre, post, now during the pandemic. So we are focused on securing those nurses, going international, and making sure we can have a great succession plan.
Thank you very much. And my name is Dr. Jessica Gunner. I have my PhD in nursing. I've been a nurse for 35 years, focused on surgical services and nursing informatics, quality risk management. One of the opportunities I saw out in the workforce was bringing vendors and healthcare organizations together so they understand how each other work. So I developed a company called Clinical Project Management, and I work with vendors to understand how to align and speak to and educate to the healthcare and hospitals that they need to communicate with. I provide education to their sales team. I work with hospitals on quality risk management and surgical services projects, and I'm branching out into legal nurse consulting. So Health 2.0 was a perfect way for me to incorporate clinical project resource into two areas, and some of us all have snuck in the marketing sessions, and they've been great. So thank you for taking the time today to be here. So what we're going to talk about, when I looked at this subject, because I still work as a senior director of nursing, my focus was very small, and I was thinking about all of the technology that's available to help hospitalize patients and the reason that it's not being implemented. But as I've been here this week and I've read the profiles of our esteemed panel, we've branched that out to more of a global look at clinical problems and a global look at solutions. So the world's top healthcare concerns are that the healthcare system is overstretched. And to restore the services to some pre-pandemic levels, how do we invest in our workforce to assure that we have the infrastructure to support that? So Michelle, why don't you start, and I'd like everybody's input on that.
Sure. So just let's start out from the student nurse. A lot of programs, and actually Lance and I were just talking about this, they bridge them in high school, and they have those bridge programs where you can go, you can become a CNA, you can become an MA, you can just kind of pick up whatever trade that you want to pick up. But going there and getting that low-hanging fruit from those students, talking to them, bringing them in as volunteers into the hospital so they can see, they can develop a passion for being at the bedside. It starts from there. Then let's go into our new grad nurses and those programs. So a lot of people are not entering nursing programs right now. So what do we do about that? We have to go internationally, seek out those nurses that already have the experience, help them get over here so that we can support our nation really and truly. And some nurses that are already experienced, they want to go overseas too. So create that bridge program, develop the succession plan, support your middle managers in the field that are working right now. And if your nurses are burnt out, give them the time, give them the PTO, hire more per diem staff so you can support your staff. Right now, during the pandemic, a lot of nurses have left the bedside, and you're not going to get them back. So what are you going to do about that? You have to work with what you have, really and truly.
Well, I'm not in the nursing field, but I work with a lot of doctors and
There's a
nurses
very high volume of nurses
in treatment.
different sources.
Exactly.
Well, yes. For me in the industry I'm in, I know the company I work for, one of them specifically, and I won't mention the name because I don't know that that's appropriate, but they annually they provide a platform for all the staff to participate and do polls and have conversations with middle and upper management on how to improve services, how to meet their needs, where they feel things are lagging. So there's a conversation with management that in many places I don't know that exists. And I was just talking to Tamara, I'm going to mispronounce it, and we were talking about this week, there's been a lot of talk about AI and automation and all these wonderful gifts that we're being given, but what happened to the human connection? What happened to, I'm an employee and I don't want to just get an email, I want to be like seen and heard, I want to participate in these things. And I think a big part of it is people. And I don't want us to lose people in this conversation because we're the most important commodity in this. And so.
So from my workplace, when I work with the primary care physicians and they have the medical assistants, and now they're also bringing the nurse practitioners and physician assistants on board because so that they can take care of their patients. So from my understanding, when we work as a PCMH consultant, I think the components NCQA build is very important. One of the component is a team-based care, right? And then the quality improvement. So all those practices, right now for certifications, the practices are trying to do, but it's very important that the staff to be involved. And even with the minimum number of staff, if you can do the efficient use of time and the efficient use of your resources, that will significantly help, because definitely right now in the market, we are in a short of staff, right? But even with those staff, how we can make it more efficient. I think there are guidelines from NCQA, and even the involvement. I think it's if the guideline is coming from the top down with the primary care physician to all the staff, it will help them to synchronize their work and work efficiently.
I'd like to introduce Dr. Edward Williams to our panel. And Dr. Williams, why don't you introduce yourself and what your company does, and then let's hear what you think about the healthcare system being overstretched and what solutions you might have to that.
Right. I'm a dentist, and I've also done quite a bit of research on concussion. Concussion happens to be the world crisis in terms of what we have allowed to occur on the field, and not only on the field, but in car accidents. No one has ever considered how does a concussive injury get into the base of the brain. Boxers know, I think two components of force. Can you hear me now?
Yes.
Wow, so can I. But we've never considered how the component of force gets into the brain. We've talked about years how the brain has to rotate in the skull for a concussion. How ridiculous is that? We know that the brain is attached to the skull by membranes. If I rotate, what do? I tear membranes. Everyone knows how difficult it is to attach a membrane to a bone. So what does a person do that has a concussion? Walk around with his brain doing like that all day? No. We have lost the concept because of that particular concussion explanation that they've taken at the end of the 70s, beginning of the 80s, and we follow that. We've now designed helmets that we want the people to believe helmets do what? Prevent concussions. Absolutely not. I maintain a helmet on the head by doing what? Putting on the chin strap. I pull that chin strap tight to hold that helmet so it doesn't rotate off the athlete's head. But at the same time, what have I done? I've pulled that jaw joint into the base of the skull. So any component of the helmet that I hit, where's that energy going? Into the base of the temporal lobe of the brain. Now, we have found that bone in this area fractures. And once that bone fractures, you can go through stress and start clenching. And what do? Agitate that bone. You agitate that bone and you bring about all the cognitive symptoms of concussions. We have to change our thinking in looking at concussions. We need nurses. We need people there that begin to understand a new methodology of concussions. How does it happen? We talk about G-forces. Like G-force is not an impact. It certainly is an impact to the base of the skull. So what we have to do is change our thinking and look at how do we prevent concussions? How do we save the brain? We're talking about the brain of children. They start football and all these sports. Soccer, the same thing. I hit any part of the head. This lower jaw is not attached. What happens? This lower jaw slams into the base of the skull. You have hacker people that think the headache is a red badge of courage. It's wrong. We need to stop that, prevent these kind of concussive injuries to the brain, and look forward to a better solution, which we have in terms of preventing concussions.
Thank you.
Nice.
One of the topics that we'll discuss this morning is long-term therapy based on evidence-based practice versus the society's need for instant gratification, especially with youth. So one of the the panel made me think about when we're talking about staffing and the need for that human connection. I do a series of presentations called Back to the Bedside, where as a leader in healthcare, I was so burnt out one day and so abused or depressed and traumatized from the constant day-to-day push to meet my productivity numbers, meet my budget, asked to do things that I didn't feel safe, that I just walked out of the door without any notice. I was put in a position where I felt the safety of the next patient who opened my doors would be compromised. I couldn't do it anymore. I've now learned that it's called, I just heard of it this year.
Compassion fatigue.
No,
Burnout. Oh, moral injury. Okay.
That over time, that the things that were asked of me that compromised my moral ethics, I couldn't do, and I walked out of the job as a senior leader in a hospital without any, and I thought my career was over. So I went back to the bedside, and I went back to the bedside as a surgical nurse, and no one knew who I was. I sat in the lounge for weeks. And I sat in the lounge for weeks and listened to what the staff were complaining about. And it was little changes that just aided them and aided them and aided them. And the staffing shortages and the requirements to meet productivity numbers. Team nursing is a fabulous concept with physicians and nurses and techs and healthcare workers waiting at the bedside and even vendors participating in that to improve the care of a patient. But I can't do that as a nursing leader because I have 1 RN to 6 patients, and they're lucky if they have someone answering the phone and someone to help ambulate their patients, bathe their patients, feed their patients. So healthcare organizations are making it very hard to keep that personal approach and to re-implement team nursing, which was very popular when I started.
Yeah. One
of the next discussions we want to talk about when it comes to the world's health concerns is mental health concerns have risen above cancer as the top concern. So, let's start with you and then go through the panel on how do you envision closing the gap between mental health needs, which include addiction, and the lack of services and long-term care to address that?
Well, one thing's for sure, a lot of the clients that come into addiction treatment or need addiction care have a mental health component.
Yes.
The comorbidity is evident, and you see it every day. And one of the things is, having had ADHD myself, I'm a pretty open book in working with clients, and a lot of times they don't want to talk about mental health. It's taboo. Something's wrong with me. Something's broken. And I think inviting them into a conversation and normalizing mental health is just as big a part of this as anything else. And removing the stigma so that they can get the help they need. Also, we know that medication can help with depression, anxiety, and other mental health disorders. And once a client gets on those medications, is under the care of a doctor and a counselor and a treatment team, their success grows exponentially. So, I mean, for me, working in the field, I think the care that they get starts with a welcoming conversation and normalizing mental health. As a society, it's still in many ways stigmatized, like addiction. And when we can talk about it with guilt, without guilt or shame, good or bad, wrong or right, and just say it's a thing that we need to come together as a family to work on and accept and love, that change can happen.
And I think earlier this week, there was a discussion about the institutionalizing of people in mental health during, I think it was the first panel.
I wrote a note on that.
Psychiatry.
Yep.
And I think that's what created that stigma. And even, 70, 85 years later, we're still getting over that stigma.
Yeah.
Michelle, what are your thoughts on closing that gap?
That's a good question. I think that a lot of times we have to remember what is bringing our healthcare workers back? Why are they staying at the bedside? What is intrinsically motivating them to stay here and to be here? And how can we support that? How can we garner their interest? How can we make sure that we are engaging our team? And like Lance was saying, like, you have to get down to the person. So you have to give them the empathy, give them the space to be visionaries. Committees are a great thing to do, and I think just during the pandemic, all of that kind of went to the wayside, and we're just like, okay, we have to take care of our patient. Our focus is our patient. Our focus is our patient. But now, like, the nurses are burnt out, the doctors are burnt out, even the support staff are burnt out. Are we utilizing those float pool? Are we hiring more CNAs for float pool? Are we hiring more nurses for float pool? What are other things that we can do to support our staff? And sometimes, unfortunately, the manager, it's left up to the manager. I could see how you will walk out of that situation, honestly, because it's overwhelming. Like, what are you supposed to do? So how are we supporting our middle managers? Because sometimes they're having to be pulled into the staffing numbers too, so they can't meet their marks and make their numbers. So for me, again, I think that we have to focus on supporting our nurses by hiring extra support staff for them so that they're not feeling like everything is on them to do it. And there's more support, there's more teamwork. Team nurses is actually great at one of my hospitals that I am a house supervisor at. We put together maybe 4 PCU nurses and a critical care nurse, and they take care of a team together. And it works for them. It really works for them. Nobody feels burnt out. Nobody feels overwhelmed. It definitely works for them. And of course, I'm gonna harp on international nursing and bringing those nurses here, because what is our succession plan? There's not enough people entering nursing school. And quite frankly, when I entered nursing school, I've been a nurse now for 12 years. At that point, before that, it was really hard to get into nursing school. So how can we support that? Kind of bending I don't want to say bending the rules, but associate nurses, bring them back into the fold, bring LPNs back into the hospitals, because you need them. They're getting tired at the nursing homes. We have to find a way to be creative.
So, Tenor, how do you think technology will support nurses in this environment to help decrease the burden and physicians?
So definitely, as Lance just mentioned, that we need people behind technology. The technology is very helpful, but when we are talking about health, when it's so personalized, it's so emotional, that it cannot be done totally with technology, right? Technology has to be assisted by the people. So when we are involving the doctors, nurses, other healthcare providers, technology definitely can automate. And what you just mentioned before, that we cannot automate a bad process, right? I love that. And that's very important, that we definitely need automation. We need the help of technology. And from ICON, when we are working, we feel that importance. And what we did, that everywhere we see that the nurses, the doctors are burned out, right? So our first product we build, we call it Save It, right? So save your time and money. So at the end of the day, if you can save your time, you can use that time for patient engagement. Or we are talking all those buzzwords that patient engagement, then enhanced care coordination, lack of care delivery. So all those things we can do, but definitely we need a ground preparation before that, right? So for the ground preparing, I think we need to help our healthcare providers, the nurses, as just you mentioned, that you feel the overwhelm. You feel like it's not all on me, right? So it's the same thing when we are bringing the technology. We have to understand that whether the platform or the users are ready to get the best out of the technology or not, right? So that's what I feel like. Technology can definitely help, and even they can automate that data. Especially data takes a lot of time, and the doctors are spending a lot of time completing their charts. And I know the doctors that they are working like up to 12 o'clock after finishing their office just to completing the charts. And when we talked to the doctors, they told me that it's not helping the patients, because I'm writing and completing all these charts, and this is actually more for the payers report, right? Reporting to the payers. It's not for the patients. So from there, we felt like then we need to have something for the patients. And That's where we brought our second product is tape. So it's a very simple term. Save is actually to save time and money, and tape is the tool to accelerate patient engagement, right? So it's very simple. The patients, when they will come to the primary care physician, they get connected with the PCPs, they get the subjective care plans, because right now all the care plans are in the EMR. That's not to the patients, right? So maybe you can remember only 20% of the material the doctors are saying. But if you have it, if you have the your goals, your self-management, you understand the potential barrier of why you cannot achieve your goals. So all those things, when the patients are having in their hand, that will actually activate self-care. And self-care is healthcare. That's what we are saying.
Yeah.
So yeah, that's I think.
That'll be our motto of the day, self-care is healthcare. So you brought up payers. So Dr. Williams, let's have you weigh in on cost is a big gap in what may be a problem and a solution. And we'll start with you and then go down the line. So as a vendor or an entrepreneur, how do you close that gap by having a discussion about the cost of a product that may not be reimbursable? What is the ROI? How do you address solutions that purchasers feel are expensive or will cost them money, even with a huge benefit to the population? How do you address closing that gap?
I think we as healthcare providers collectively should begin to look at fee for services. You're burning out physicians, nurses, and everyone. Not only are you they're dropping our fee for services, but they're creating more need that we've got to process. That is the killer to healthcare. My concept is pay Caesar for what Caesar has done. They have taken the payments out of our whole. When I first came into dentistry, they paid me by way of $1 or a chicken. I didn't have to write out anything, but it was a wonderful way to practice. Yeah. Today, that has been impaired because nobody is saying, what are these insurance doing besides making money? Making all of our profit right off the top. We have never got together to collectively even talk about that. Why? Are we scared of insurance payment, insurance plans, or are we, or we don't like to be paid? We have to understand it has to start from the top and trickle down. Yeah. Let's look at what we do in terms of drug abuse. We have seen an escalation in opioid addiction. I guess I could use the term addiction? Okay.
Yes, you may.
Thank you. What we have not understood, I treat a lot of athletes who are, I wouldn't call them addicted, dependent. Okay, so that's a kind of word. And what happens when we scan with technology today, we find fractures here in the base of that bone. When that fracture is healed, the addiction goes away. If you look at the symptoms of concussions, all of those symptoms, we talk about the rotation, all of the symptoms point to the temporal lobe. No symptom points to the frontal lobe or the occipital parietal lobe. All of them point to the temporal lobe. Where does the lower jaw slam? The base of the temporal lobe. So we have a multiple of problems. And not only, as you said, you got to do all this reporting and not get paid. It just takes a whole lot of integrity out of healthcare. We cannot let that happen and let it go forward. So looking at the conversation here, there are ways that we need to do and what we need to do in terms of collectively looking at what is the downfall of healthcare. Why are we not seeing the pipeline filled with more children, more students in healthcare? Well, it's not attractive. Those are in healthcare are not saying things positively. Why? Because the insurance carriers have destroyed us, have destroyed a part of our brain that we can't get back. And to try, you can't fight, you can't take an insurance company to court. You don't have that much time or money left. So what we need to do is look at the problem from the top down. I think a lot of our points that we've talked about here will accelerate to do so much better. Pay Caesar for what Caesar's done.
I think this venue, Health 2.0, the distinguished panel discussions that all of us have heard this week. Thank you so much for allowing us this venue. what I hear from you is you have a product, then this is just an example of why I think this is brilliant. You have a product that after how long can help that heal to make someone less dependent compared to the lifetime of an addiction because they've been dependent on something to heal their pain when their pain could have been healed in what time?
We take a patient on with a fracture. Use a product that takes that lower jaw out of the impact site. And in 4 months, all of that's gone. The bone begins to heal. You can heal bone with tension. So we put them in a tension phase with a unit that we replace. And in 4 months, the symptoms are gone and they're off that drug.
So paying for a product for 4 months can essentially keep someone out of the mental health addiction dependency cycle for a lifetime, but we don't look at that as healthcare. So let's talk about ROI for IT. How do you work with your physicians and the healthcare organizations that you work with to close the gap between what they see as a cost and how do you prove your benefit to them?
So when we talk about the ROI, so the product we build safe, what we are seeing that there are multiple variables here. It's starting from the number of physicians, number of patient panel, what % of the patients are actually suffering from chronic disease, and what % of the chronic disease patients have uncontrolled vitals or the uncontrolled situation. And when we look at those patients with non-compliance, we want to see that what % of those patients has the intention to improve, right? So they can move from the left side of the graph to the right side. So based on all those numbers, when we have a realistic assumption, it's showing that the ROI would be for a 500 patient panel doctor's office with 20% of chronic diseases, it's showing that it will save at least $30,000 for the practice. And when we talk to the physicians, they appreciated that because when we are saying that it will save your $30,000, there is 2 components of that. One is direct revenue and another is indirect revenue. When you are saying direct revenue, it's like with the right coding and with tracking the patient's physiologic data, with the right billing, you can generate that amount of money. And at the same time, how much time your practice is saving. So your time is money, right? So how much, if you evaluate your time into money, that comes to a valuation of $10,000, $15,000. So altogether, we are saying that within 6 months, this is with a 500 patient panel, it's over $30,000.
That's incredible. And you're not only focused on the ROI, the patient outcomes have improved. So Lance, we were talking earlier in your practice how a patient can enter treatment for 30 days, and there's a big gap in 30 days and 30 years. And that treating someone for 30 years who hasn't gone through a process to help handle their addiction costs the economy a fortune. So how do you bridge the gap between your 30-day inpatient or even outpatient service to battle an addiction and having an outcome such as yours?
Well, a couple things. I know I really appreciated the doctor down here when you mentioned addiction and the numbers. Right now in America, the cost for alcohol and substance abuse is over $300 billion a year. That's like, I got emotional just saying that word. You know, give us $1 billion, we'll make changes. I mean, I'm just saying insurance companies, but I hear words like evidence-based practices and ROIs, and I don't hear the human being in there. And I work in a place that's went from a private facility to a corporate facility, and the ROI has began to eat at it. And I see it every day, and I hear staff talk about it. And it's impacting the work and the caseloads and all the other things that go with the company and creating stress. But for me, how do I help a client have a fulfilling life? Really, I think that's all of our jobs at the end of the day. And to take somebody that's been using a substance or alcohol or other behavioral addiction, whether it's a narrative or other, and give them 30 or 60 days to kind of regain their homeostasis or balance in their life, and then say, good luck. Here's a therapist and here's an AA meeting. I'm not saying I believe AA can help people. I'm strongly for therapy for clients when they leave treatment. But it's one part. There's a big part and a big gap missing is counseling and coaching and mentoring with somebody with a background and a specialty to help that person move from, I'll use Michelle. Michelle comes, I hear Michelle's leaving treatment. She's never really lived a healthy life in 10 years. Mm-hmm. I come on board with Michelle, meet with her, set a plan for her life so when she leaves treatment, I'm the training wheels for her on the other end. Mm-hmm. Right now in this treatment world, we hear buzzwords like, well, when my clients leave treatment, we have an 80% success rate. Well, yeah, while they're in treatment, let's talk about recidivism. Right now in the best treatment centers, and I'm probably giving an extreme number, success rate is maybe 15%. And I mean 3 to 5 years is long-term sobriety in my consideration. That's not ethical. Mm. And so how can we improve that gap? That's what Life Over Addiction, the company that I'm founding and growing, is about. We need to help those people build a life beyond treatment. Treatment doesn't end when treatment ends. And so for me, I don't know the costs, but I know the lives. And it's not just the life of the person that's healing from active alcohol or substance abuse or other behavioral addictions. It's the cost to the communities. It's the cost to the family. It's the cost to the spirit of their community. And that cost goes way beyond money. And the insurance companies it's like people are numbers. Mm. And when we're in that kind of space, who are we as a people? And I see people dying every day, fentanyl rates, deaths, you mentioned opiates. Mm-hmm. In 2013 and 2014, the average annual rate of death for opiate overdoses was around 2,000. Currently, that stands at about 95,000 annually and going up. I see that in families, the impact on families and other people every day. So it's again, it's not a fancy slogan, it's people. And so if we can help them, just in helping people, we save money. Yeah. So that's my part and my passion, and being honest, and I appreciate everybody sharing what they've shared.
And that's an extremely important purpose and path in life. One of the hospitals that I work at in San Francisco is in the Tenderloin of San Francisco. And if you have seen it on TV, you can't even imagine the trauma that you see when you drive down the street in the Tenderloin in San Francisco. There are hundreds of mental health patients or drug and alcohol addicted patients who are sleeping on the streets, defecating on the streets, using on the streets. And what concerns me is not how it has defaced San Francisco. It's why can't we help these people? Why couldn't we help these people after they got out of treatment? How did they get here? And I know a lot of them are veterans, and I know a lot of them are people who, when the pandemic started, couldn't get the mental health treatment that they needed or don't know where to go. So thank you very much for that being your passion. I see it every single day. I will tell you though, if somebody comes in the ER with an opioid overdose and you shoot them in the chest with epi, they will wake up and say, you ruined my high. Yeah. Not yes. Thank you for saving my life. That is how important that high is for them. Yeah. Michelle, let's go to you and have you talk to us about how international nursing might bridge the gap in the healthcare crisis.
Sure. So I'm glad that you mentioned that, but first I want to start off by saying a new grad nurse to train and orient them costs about $60,000 to $80,000. You can lock them in maybe for a year with the sign-on bonus, but after that year, they're gone to the staffing world to go and travel and live their best life, and that is a trend right now. So for international nurses, giving them the opportunity just to be here in the US and learn a new skill set, learn some new technology, garner themselves, and even maybe stay here to take their talents back to their country so they can improve on their country. You can lock an international nurse in for at least 3 years. So at least you have the right succession plan there in place, and then market them from there. You can give them classes so they can get an advanced practice degree. You have to build them up. You have to put the work in and support them. Like that's really it. And it's really simple. We don't have to reinvent the wheel for this. But again, new grad nurses and all these nurses that are entering, they want their hand held, and we have to give them that support. We have to give them that attention, and we have to garner them and make sure that we're supporting them and knowing what their intrinsic motivation is, because everybody's just not here for $1. And I really do want to debunk that, because nurses are here to care. And for us, our company, Compassionate Solutions, healers need help too at the end of the day. And that's what we're here for. That's why we're here to support them. We are clinical professionals. We still are working in the field right now, in jobs right now. I'm in a leadership management job right now. So again, like, we're still here at the front lines being there with them. But they have a voice, and we have to advocate for them and be that voice for them. But definitely bringing international nurses here, that is a great succession plan for any healthcare facility or hospital, because at least you can lock them in for 3 years. You can build them up so that they can really stay with you. And you have to be strategic about that. You have to talk to them. You have to get to know them. You have to build a community for them. That is how you support that, and that's how you close that gap.
Absolutely. And one of the things that I want to address, because I think all of you have drifted into the marketing room to learn something about marketing. And one of the things I learned yesterday in marketing to the Generation Z, and I sometimes feel like as a nursing leader, I'm marketing to my staff. I'm spending time with them as people to understand what I can do for them to keep them in their role as a staff nurse. And something that you said really reminded me of something that I heard in Marketing 2.0 yesterday that I wasn't aware of, because I'm way above the average age of a nurse. But the new grads coming in, Generation Z, thinks we live in a perfect world.
Yes. Because
they were born in a perfect world. They haven't seen anything else except the pandemic of a perfect world. So as an employee, as a client in marketing, as an employee, they want to know how they can become a part of that perfect world and help that perfect world from a social, like you guys are saying, from a people and a society perspective. And I think those of us that are older in healthcare don't understand that concept, because we know it is not a perfect world. So in order to retain the younger people coming into healthcare, we have to understand what motivates them. And it's not what motivates me. What motivates them is how can they improve on their perfect world, and how can they shine a light in that world, which is a totally different way of looking at things. We have 7 minutes left. So I want to go to questions, and then I'm going to have each one of you wrap up the conversation. Do we have any questions from the audience about any of the gaps we've discussed, or other gaps you'd like to hear from our panelists?
Seems to be my role to ask a question or make a comment. First of all, it's interesting in the development of the shortages and that you've talked about, that none of you mentioned the federal program, the National Health Service Corps, which I'm very proud to have invented the idea in 1968, but it places nurses, physicians, and other people in medically underserved areas. They offer loan repayment for people who are members of minorities. They offer scholarships. This program's been around for 50 years. It serves 27 million Americans a year. And yet, you sit in a center like this and you're all here talking about basically wringing your hands, and nobody mentions that this program exists.
So could you state the name of the program so everyone in the audience can hear it? Because I'm not aware of it.
National Health Service Corps.
National Health Service Corps.
Yeah, Health Service Corps. It's administered by HRSA and as part of the Bureau of Health Professions. And then the other thing that, we talked about, bringing nurses from other countries, which may, or health personnel, which may be desirable, but we have a tremendous pool of unused talent in our inner cities that we're not taking advantage of because we've not built the career ladders to move people through. There are programs, again, like this, which serve as models. The Skill Quest program organized by the Texas Industrial Areas Foundation, which takes people out who want to become nurses, as an example, or computer technicians, offers them the wraparound services so that they get the daycare for their families, so they can go, and they have partnerships with the community colleges. You talk about the turnover. At 1 year, they have a 95% retention rate.
Wow.
This is a program that keeps people. The model functions in San Antonio, Dallas, and Austin now. It ought to be a national model. Thanks.
Thank you very much. I appreciate that information, and I think all the healthcare organizations in the world need that information. And I have someone's going to hit on that website in a minute.
Yeah, definitely. And I'd never heard of the first program that you mentioned, but yes, I did actually mention that we need more of those bridge programs to go into high schools, because we have the cosmetology, we have the wood making class, we have a lot of those programs, but a lot of them we don't have like CNA or MA programs that can bridge them in. Another thing that myself and Dr. Jackie talked about, we talked about the magnet program. Magnet programs for hospitals, you cannot have associate nurses. Why can't we change that? Why can't we bring associate nurses back, help them get their bachelor's degree, or at least in their studies when they're working, we can give them the classes. Our educators, a lot of our educators are masters in doctor prepared nurses. Look at you, so they can give them that education. They can give them that talent so that we're not just poaching or whatever, or bringing our international nurses, but we also have to make sure that we are going into the communities and helping them develop that passion, because it doesn't really look very nice right now to be a nurse. So, we have to make sure that we're being intentional going into those communities. So yes, I agree.
Thank you, Michelle. Next question.
Yeah, this is more of a comment, I think, than a question. I think one of the things I think people need to be careful of is everybody sort of has a tendency to demonize, if you will, the managed care companies that are paying for and then X, Y, and Z. And it's very easy to demonize them, but if you ask employers, do you think that health insurance cost is pretty good, pretty reasonable? And they would say, no, it's out the roof. Why is that? Because there's mandated benefits, and there's that benefit and this benefit. And every time you keep adding more and more benefits and you want the third-party payers to pay for that, that makes the cost go up. So you can't just isolate it and just demonize them and say, those mean bad insurance companies, why aren't they paying for my new XYZ therapeutic intervention? Well, if you ever ran an HMO, and I take it none of you guys have, I have, when you run an HMO, the number of people that come to you that say, hey, I have a new intervention, and it's the best thing since sliced bread, and if you just cover it at this amount, it'd be great. And it's a little bit more complicated than just saying, why don't they adopt this, that, or the other thing? And I think the gentleman over here mentioned that, you talked about the 15% efficacy in terms of the recidivism, in terms of these things. It's okay to look at things short term, but you're right on the money that sometimes the studies aren't fully developed or only half baked. And as a data scientist, I can assure you, I've looked at lots of studies that if you would have been my student and you brought me the study, you would have gotten an F+, because at least you made a little effort. But they're not worth the paper that they were quote unquote written on. So my only advice and counsel is that if you really do have something good, the managed care companies are interested and they would be happy to hear you, but you have to have more than just an anecdotal evidence. You need to have studies. You need to maybe even take a look at it long term. And there is a process, and they're happy to look at things that improve the health and the cost of their membership, as well as the cost of the membership, if it truly does what it says it does. So just FYI.
Thank you. We have a minute and a half left, and Dr. Williams, I'm going to let you address his statement and question.
Well, therein is a loss in communication. We've never had that kind of gap closed in terms of what they look at and what we look at. What we look at is what we do. You don't have too much time to look beyond that, unfortunately. So when we move forward, we have to move forward in the best interest, primarily I speak of our children. Start from the bottom and work up. I see a lot of brain injury based on the impact forces that they've sustained. We also have a product that they wear during their activities that prevent that lower jaw from slamming. It minimizes the possibility of brain injury and the future of damage, which you see a lot of, and you probably never even thought about, how did this guy get on this opiate? Okay, now we've got to go back and look at the groundswell of what it really means to our future. Concussions happens to be the crisis of the world. It's just not a US problem, it's a crisis of the world. And we have to address it as such. So, those folks that want to know how to prevent it and how to heal it, I'm here for them.
Thank you.
You're welcome.
Tinwer, how do you think is one of the best ways we can address and close this gap in the future?
So I just want to say two things. One is our doctors are suffering from decision fatigue because they have to take colossal, critical, clinical decisions every single day. So we need to take off the administrative burden out of them. And on top of that, if we can implement CDSS, the Clinical Decision Support System, I think that will significantly help them to reduce the human errors.
Thank you. Lance?
The gentleman, he made a comment, and one of the main things in my company is let's start a new conversation. You know, I mean, I don't know insurance. I'm not an insurance salesman or an insurance company. Really don't want to be. That's a job that's better suited for them. But for me, I'm on the ground and I've read studies and I did a lot of research and I see the impact on the ground in person. And I don't care who I have to talk to, but let's at least start a new conversation as a community of how to do better work. If we do better work, we're going to lower costs and everybody wins, including the client. But if it's about costs and about that kind of a dialogue, the client will always lose.
Thank you. Michelle, any last comments?
I think my last comment is basically like just to continue to have these type of conversations. I think they open up your mind. That insurance thing, that comment that he just made, never even thought about that, but definitely I think that's a conversation to be had. And I think that, of course, succession planning and supporting the varying generations that are in healthcare right now, because it's multiple generations. I mean, our baby boomers are leaving, but it's still multiple generations within healthcare right now. So we have to find a way to support them all. A lot of our baby boomers, they kind of want to work per diem life. Let them work per diem life. They want to be in control of their schedules. Give them a scheduling committee so they can control it. So we're having and we're holding accountability at its best. So I think that having the conversation, supporting our staff, and hearing and listening will definitely close the gap.
Thank you very much. And thank you guys for listening to our very esteemed and distinguished team of panelists up here. I know all of them are on LinkedIn because that's how I found them, to reach out to them to talk about our conversation today. Jessica Grunler and Clinical Project Resource is also on LinkedIn. And I would encourage you to reach out to these people to keep this conversation going. And I really encourage everybody to come back next year so we can continue these conversations and change the world. Thank you very much.
Thank you.
Can you hear me now? Fantastic job, guys. Another round of applause for our panel, our moderator. Thank you to all of you for your unique perspectives. Really a great conversation. And I love what she just said. These are such impactful and amazing conversations that you guys are all having, as you are just such huge parts of the healthcare industry. So we'd love to have you back to continue with these conversations. We are coming back. Health 2.0 conference will be in Dubai, May 1st to the 3rd, 2023. We'd love to have you there, whether it's as an attendee, delegate, sponsor. You can come see me during the break or right after, and I give you information on that. We are also going to be back in Las Vegas in July at Caesar's Palace. So a couple of different options for you to continue, growing your network and just continue the education and with the trends of everything going on in the health industry. So our next keynote speaker, Lexis, she's not able to be here. She had to fly back for a mini emergency, so wishing her well on her travels back home. However, she did make a video for us, so I'm going to ask you to please lift your eyes to the screens above and give a warm applause for Lexis Surratt, founder and CEO of LittleWins.com.
Top or the
you did this and celebrating that. I didn't even and I'm such a big team worker. Exciting time in medicine. I keep saying this, and then some people come back and they're a little bit Debbie Downers because there's like things that are not working very well, in other and there's so much freedom in that. Where you can access exclusive edition. I don't know about y'all, but my kids, they grow like weeds. I'm pretty sure yours are probably the same.
Check 1, 2.
people in the world have done that? Is there like a?
I don't know. I'm not quite sure.
Doing it? Like I'm.
All right. Thank you so much for that video, Alexis. Just to kind of help fill in the gaps there, of course, technology was glitching all over the place. Technology, we can't throw it out the window. We can't live without it, can we? One of those things. So help fill in the gaps there. So littlewins.com is actually a place where you can buy, sell, or donate medical equipment and supplies. I was just on the website. Really, really amazing concept. There's also a blog, podcast, some really great medical stats on there. So if you get a chance, definitely check them out. That's littlewins.com. And thank you, Lexus. Hopefully you'll get to watch this on the live stream back. Moving right along, we have our next panel coming up, how to make sure your healthcare facility is fully prepared for downtime, where the experts will discuss how healthcare providers can be prepared to support maximally safe and efficient clinical processes when their IT systems go down or are under maintenance. Please join me in welcoming the session's moderator, Charles Wayne Hale, president and founder of Hale Consulting Solutions, LLC, and our esteemed panelists, David Rauschendorfer, CEO of Cybersecurity Resource, and Carly Applegate, founder of Evelyn Elaine. Warm round of applause for them.
All right, good morning, everyone. Made it to day 3, the few, the proud, the survivors. I appreciate seeing you out there. The sober. We're not betting on that. Before we get started, I wanted to give acknowledgement to our MC, Melissa. She's been doing a fantastic job all this whole time and filling in the gaps as she just did. I applaud you. Thank you so much. So the title of our this particular panel is how to make sure your facility is fully prepared for downtime. So this is something that's near and dear to my heart as a technology professional and as a cybersecurity specialist. We've seen throughout all 3 days how much technology has become ingrained into our healthcare system. Just about everything we do involves a computer or a mobile device or some type of device. So what do you do when it's not available? How do you prepare for that? So we'll start off with some introductions. As she said, my name is Charles Hale. I'm the president and founder of Hale Consulting Solutions, LLC, and we are a boutique cybersecurity firm focused on the healthcare industry. And really our mission is to reach out and help healthcare providers, healthcare organizations do what they do best, provide healthcare. So we can help them not have to worry so much about cybersecurity and access and all of the other things that are really ancillary to what your job should and what you want it to be. David, you want to go ahead and introduce yourself?
Yeah, definitely. Thank you. So my name is David Rauschendorfer. I'm the founder and CEO of Cybersecurity Resource. And much like Charles, we specialize in the healthcare sector, doing a lot of the HIPAA security risk analysis for organizations. And then our main mission today is to focus on those small and mid-sized organizations that are actually providing services and solutions to healthcare providers as well. So ensuring that when they bring solutions to the market and to your organizations, that they're actually secure upfront. So that's kind of our main focus, providing greater access to cybersecurity solutions and assessment services across the healthcare industry.
Thank you, David. And Carly.
Carly Applegate. I am a recovering nursing home LTAC and home health and hospice administrator. And I'm the founder of Evelyn Elaine, and it's the first standardized training for non-professional caregivers. We train clinically based modalities for those family members who are in that caregiving space, never intended to be. So I'm excited to be here.
Thank you. Thank you very much. Well, let's get things started off here. David, let's talk a little bit about downtime. When we hear the word downtime, we think something's gone wrong, that something's broken. But there's also, planned and unplanned downtime. Can you talk a little bit about the difference, and is there good downtime?
Yeah, definitely. So, many people in organizations don't always realize that there's planned downtime because it's usually done outside of kind of standard business hours. But it's pretty common for organizations to go through that, to just get through their patching that may need to be done, updating infrastructure, and things of that nature. So it's very common to have kind of that planned downtime and that your kind of IT teams are managing for you in most cases. You know, the unplanned downtime can be things where it's kind of a denial of service. You're in there trying to do your job, trying to work through your operations, and you all of a sudden can't do what you're supposed to be doing. That's when it gets a little scary, right? And so those unplanned downtimes become, you know, a lot more catastrophic at times, and there's different levels of that, but usually, you know, they can be managed and mitigated and be able to kind of make sure that you can continue operations, and that's kind of a part of what we're talking about here. So when you do have unplanned downtime, you can still continue those operations, provide services and care to your patients, and kind of maintain your daily workflows. So that's kind of what we want to help organizations focus on in this panel, is making sure that you're able to maintain those operations in any of the kind of scary downtime procedures.
And Carly, from your perspective, from more of a business and healthcare provider perspective, what does downtime mean to you? How does it impact the work that you guys do?
I actually love downtime. Honestly, I know that sounds weird, but it really, I think downtime is a great time to really measure your clinicians and see, are they clinical? Are they doing assessments? Are they clicking buttons, right? You can really sift the wheat pretty quickly during downtime. And so I love it. It's always work on the back end, especially if it's, you know, not planned. But I think it gives everybody an opportunity to stop clicking buttons and actually, you know, practice hands-on care, which, you know, gosh, we've gotten so far away from it. I think the panel discussed it earlier, you know, just all you're doing is treating the EMR and not the patient. And so I love it. But it does interrupt business. So you always have to have kind of a coup afterwards. Like, you know, how are you going to get whatever data back into the system? And who's going to do that too? And that's kind of, you know, that's always been a challenge too, because it is disruptive. So in my current organization and then other organizations that we've always, you know, had some type of coup to, you know, kind of assign, you know, who's gonna put the stuff in the medical record, who's going to send the reports, who's going to clean everything up. But like I said, you really get to see who are your hands-on clinicians, whether that's nurses or therapy or even your aides, you know, just the whole gamut of things. You really get to see who's actually doing the care. So I love it.
That's a great answer. Yeah, how it goes, smooth seas don't make for skilled sailors, something like that.
Yeah, absolutely.
Right?
Yeah.
Yeah. And just to add to it, you know, more and more we're getting into this integrated age. There's solutions for every part of the business, and we're leveraging and leaning on those solutions very heavily. And so, you know, not all of those are in-house. A lot of times we're using third parties for those, and right, there's a lot of breaches and data loss where it's has something to do with a vendor's solutions going down, not always internally. And being able to have downtime procedures, figuring out how you're going to continue operations, and then also how you're going to bring that back up to speed when you know, get that solution operating again, inputting the data back in there so you have that continuity to maintain business, you know, long term is always key. And so it's, you know, we're becoming a integrated state where it's crucial that we kind of have these plans to know not only what we're going to do when it happens, but how we're going to bring it back after the fact.
And I think you have to test the plan, you know, whether it's just part of an IT plan or a disaster plan, because, you know, I love my nurses. I love you guys. I really do. but the printer breaks down and it's like World War III is happening. And so like, you have to train them. They have to be prepared for when this happens. And it can't just be in a manual somewhere, because that's when, that's when panic really starts to set in. The internet's down for 30 minutes. People are freaking out. The printer's not printing. The poor printer is sacrificed. So having a plan for these things is huge, and testing it on a regular basis.
Well, and that's an interesting point you make, that you love downtime as long as you have a plan. So what are some of your top considerations when considering and planning for downtime?
Well, first and foremost, it just goes down to the basics, right? Are you doing rounds on your humans? If you're in a facility, do you have notebooks and pens available so vitals can be written down? Do you have a format in which the nurses need to remember how to document their notes if we're doing it on paper so we can easily move it back over to the computer? How are you actually going to communicate if you don't have IM? Are you going to actually have to go to the next floor and interact with a human being? And then in the home health space, granted, it is a little bit easier because we don't have as many integrations like you were talking about. We have web-based vendors, so if the internet's down. But again, can you document without the computer? Do you have that skill set anymore? Or have you lost it? And so, again, we train on downtime, at least once a year. But living in middle of nowhere, Wyoming, it happens on a regular basis just because, we either lose the internet or storm or, some type of data disruption. And like I said, it really just does help thin out the herd on who's able to adapt quickly.
And I think that brings up a really good point, right? Many organizations are really good at testing their downtime procedures from an IT perspective, how to bring data back. But it's really at the operational level that, many organizations struggle. What do we do in that downtime? How do we maintain those operational workflows to continue servicing and serving patients and doing all of that? And it's often never tested at that kind of departmental level or kind of operational workflow level. And that's, oftentimes either overlooked or not considered as a requirement. And so, when it does happen, that's when organizations really start to struggle and scramble and try and kind of maintain,
And we focus a lot on the clinical end, but, we all know that there are so many people in any facility. You've got housekeeping and laundry and dietary, and again, are they able to operate without, pulling up those menus? Are they able to operate without, logging in those loads of laundry? So again, we focus on the clinical so much, but we all know that there are, for every nurse, there's 10 or 15 people who aren't clinical making that clinical operation happen. So, don't exclude your ancillary teams by any means when you're testing these plans.
And you talk a little bit about testing the plans, and of course that's very, very important. But how do you go about testing a plan other than just going down and flipping off the power switch?
I've done that.
You've done that.
Yeah, from the plan testing, a lot of times what I notice in organizations is there's a disaster recovery testing, right? And so that's kind of back to, we have backups and how are we going to retain that data and put it back into the system. But for the instances where it's oh no, everything is down in the middle of the day, that's really something's wrong, there's a security incident or something of that nature. And most organizations don't really look at kind of an incident response plan. and what are the most common incidents that happen in the healthcare sector, and for those type of security incidences or breaches, how are we going to react as an organization to those? And that's where it really gets into a team across the different levels of the organization, from management, departments, or clinical staff, to be able to have the right steps and test and then know what they're going to do in those scenarios.
Well, and I'm thinking as we're going through this, there's different types of downtime, different levels of downtime, from the printer is out of ink, what do we do, to we've been hit with a ransomware attack and it's going to take us 6 weeks to restore our systems. Kind of talk a little bit about how you prepare and address based upon the scale of the downtime.
Yeah, so there's definitely different levels of backups, right? So there's kind of your standard backup where you're going to want to have your RPO, like recovery point objective and time objective, how long it's going to take to recover, what's okay for the business, and what point in time are we going to be able to back up to from when that data was input, all the way to kind of your resiliency. So how are we going to do business continuity? How are we going to maintain operations? And that may be a little bit different, right? From moving to manual paper processes, or being, it depends on those operational workflows at that department level, what they need to do to kind of maintain business, where it can be, a extended period of time for a ransomware attack, to be able to get systems back up and all of that data working as operational as possible. So there's definitely different levels of that, and I usually attest that to, again, kind of an incident response plan, where it's going to go through a lot of that, and then you'll talk about all of those things, both disaster recovery as well as kind of business continuity.
Carly, we talked a little bit about communication and the need to have backup communication, things like that. But there's different communication stakeholders. You, of course, have your staff, your ancillary staff, but then there's the patients, there's the media, there's all these other things. How far do you need to go with this when you're planning for downtime, as far as how extensive is your communication plan?
Well, I think that you almost have to have a tiered plan, right? You're not going to alert the media when the printer's out, right? You're not going to be calling the governor. You're not going to be calling emergency management for the county that you live in. So you have to have you have to have an appropriate tiered response for the length of time you think you're going to be out. The first is the staff. Right? You've got to start with the staff. Either you send your managers out with one defined statement. This is what's happened. This is what's going on. Have your staff start communicating with the patients and just building a really solid tree. But it's that defined statement, I think, that sometimes gets lost. Right? Like we're only going to say this at this time, right? And then, again, it really depends on what your tiered plan is, are you looking at 72 hours? Are you looking at a couple hours? Are you looking at, like you said, 6 weeks? Anything greater than 24 hours, definitely local vendors, start reaching out to your local vendors, probably emergency management just in your local county, and then work your way up the tier. But it really does start with the staff. Again, that they know what's going on. They don't have to think about what's going on, and then the message doesn't get lost. And if you can get that down, that's going to cover probably about 80% of your miscommunications, right? And that's something that's really easy to test. It's almost like the telephone game. Send out a message to everybody and see what the end message was, and start practicing that with your staff. It also depends on the size of your facility. too. I know that there's some people here from enormous hospitals, and then there's some here from small, critical access hospitals with 25 beds. Those smaller communities, the newspaper's gonna know what's happening long before you do. you know, so you need to have it scaled appropriately to your size.
Cool. And I would encourage you also to consider your fellow healthcare providers and your communication plan, because we've seen instances just recently of hospitals, a large hospital on the East Coast got hit with a denial of service attack. They weren't able to serve the patients, so they sent them to another hospital without telling the other hospital they were sending them their patients. So you got to consider that as part of, they had a backup plan. We will send our critical patients somewhere else, but they hadn't thought it out completely. On the topic of communication, the content of your communication, as we've seen fairly recently, is very important too. Exactly, that everybody's saying the same thing and that they know what to say, because there are certain key terms, we will use breach as an example, that have legal ramifications. David, you talk a little bit about the carefully crafting your message when communicating downtime?
Yeah, definitely. So I feel like we're getting better and better about our communication strategy and plan in the healthcare sector. I think many organizations realize that you need to have one, especially as you see other healthcare organizations go through breaches or incidents, and having that tiered structure like you're talking about for different levels, so that you don't immediately take a downtime incident and start communicating out to the newspapers that, hey, we had a breach, and you haven't had the time to even do any type of root cause analysis or understand if you had any actual data loss in that incident or anything like that. So, I think the larger organizations definitely have, teams to manage that. They go through their legal counsel, so nothing comes out of the organization before it is reviewed and looked through by management, gone through by the legal team, and then communicated out. But at smaller organizations, you're not going to have that depth and that bench to leverage. And so I think it's just a point of actually having a communication plan, something that's documented. For this level of incident, we need to make sure we're communicating to all of our internal staff. We're going to go through, see what happened, do root cause analysis, identify if an actual breach occurred. If so, we're going to formulate this type of message. It's going to go through these people for checks and balances before we ever communicate that out to the public, so that we're all on the standard message. It's all kind of streamlined, and we just don't have, nurses out saying, hey, we had this big data breach, and posting that on Facebook and letting that kind of go viral, right? And so you don't want those things to happen. You want to have a controlled message that you can kind of put out there, because you don't want somebody saying, oh, we had a breach. And then it's like, well, how big a breach did you have? Did you lose everything? Was it, 5 patients, 1 million patients? How many records were lost or affected in this kind of incident? And so having those checks and balances, having a standard plan in place, and being able to walk through that kind of, so again, in a kind of incident response testing, saying, well, if this incident kind of happened, what are our timelines to identify what actually happened there, to do our root cause analysis, and then what are the steps and who needs to be involved in that team to have that communication strategy out to the public.
Yeah, and on the topic of breach, and bring that one up, because there's specific legal requirements about once you've identified there's a breach, you've got, I think it's 48 hours to notify the people that their data's been lost. So saying that it's happened before you know whether it's really happened or not can be really impactful to your organization. Let's see, let's talk a little bit about, well, Carly, you talked about recoup and the importance of getting back together after you have a downtime. So this can actually be very challenging in an organization, is actually resuming services after a downtime, especially an unplanned downtime. So can you talk a little bit more about the recoup and how you guys start doing business as usual again after recovering from a downtime?
Well, again, your recoup plan is different than, it's different based on how much time that, has been lost and what areas that are affected. I think it comes down to your actual, your policies, right? we tend to make these really good, long, super complicated policies. And so, you know, after downtime, you know, or any type of data, not quite a breach situation, if you have these, you know, really complicated policies, then that's what your oversight is going to look for, right? So I think it's really important to, before you even create a plan, to go back through your policies, and are they as clean? Are they as neat? And are they as simple as possible while still holding the regulation? For example, at our, you know, post-acute care, you know, there's no regulation that says that the data has to be documented in the EMR, right, during a downtime. It just has to be documented, right? Time, signatures, all of the things. So if your policy says that you guys are going to implement it in the EMR, you've just created so much more work for yourself, right? Versus just taking the paper, you know, the couple hours of, you know, paper documentation and scanning those into the chart. If, you know, if you're going to do a root cause analysis for all of the departments, you know, your root cause analysis for all of the departments should not be the same for IT as it is for maybe your med surg staff, right? Like, because there's just, one, there's different levels of understanding, and there's different levels of approach too. And I've walked into facilities where it's a one size fits all, everybody's gonna do the same thing, and that just doesn't make any sense, because you're going to have, again, departments that won't need to recoup. They might have to reboot, they might have to update drivers, they might have to work with IT on passwords, but they don't need to recoup. And so I really think that that's where it starts, is making sure that, again, any area that needs to follow a process, that it, one, is tailored to that department, that expertise, and it is as simple as possible, because you want to limit that recoupment time so you can just get back to business. Business is already hard enough as it is. But if you create highly complex recoup plans, then it may look glorious on paper. You may get an A+ from Joint, but you're gonna have to follow that at the end of the day. And so, you know, when you go to actually implement one, if you have to implement one, God forbid, it's just really important to try to keep it as simple as possible. And again, I think we get away from that sometimes.
I think you made a really good point about the policies and the documentation. I've seen that a lot when working with several organizations, you know, especially, you know, small, mid-sized organizations. Policies are seen a lot of times as a check in the box. So they'll have a policy set, but it doesn't really do anything for them per se, right? And so I've done a lot of kind of training and consulting where we'll develop a high-level set of policies to meet all of the regulatory requirements. But the point is to define and document procedures at the department level so it makes sense for each department within their operational workflows. So we drive security through those operational workflows while kind of documenting the solutions they're using, the backup procedures they will utilize if needed with those solutions, and how they'll maintain business in the event of a disaster. And that really gets specific down to the individual departments. And you'll be surprised that not only the type of efficiencies you can find in going through that exercise, but in large health systems, you'll find that they're using very similar solutions across many departments that maybe they can centralize and, you know, and do a lot of cost savings and things of that nature as well. But it really can streamline your operations, and that's something I always enjoy, being able to integrate both the cybersecurity aspect and the business operations aspect and make it make sense for the business to take on those activities. And then, you know, you highlight a lot of things in going through that as well.
No, and something I drew out of that I think is an important point to make, you mentioned, is, you know, compliance. You know, HIPAA says you have to have policies and procedures. are they useful policies and procedures? Are you going to be able to implement them? Will they really help you? And that's the division between, are you compliant or are you secure? Are you prepared? So I think that's a great call out as part of that illustration. So we talked a little bit earlier about downtime and planned downtime. Now we operate in a global world now. So what are some of the challenges around downtime and when you've got maybe your CRM is operating on the other side of the world in completely different time zones?
It's always interesting, again, when you're working with a lot of vendor solutions, I've worked with integration teams as they bring on these solutions. A lot of time that isn't even a conversation. How is this going to be managed if that solution goes down? Who's going to be responsible, and at what level of kind of role and responsibilities does the healthcare facility have compared to the vendor, and what is the vendor agreeing to in that process as well. So most vendors are really good about planned downtime, making sure that it doesn't affect any of the kind of client operations at the healthcare facility. And they'll usually work with the IT teams if something comes up, and kind of work through that. But when it's not planned and it does go down, that's when a lot of times people are kind of scrambling. And if you don't have a plan in place that says, this is how we're going to maintain operations without this solution, and then this is how we're going to bring it back so that we can get back to full business as usual, it's a struggle for many departments, right? And sometimes they're just like, well, I guess we're done for the day, and we'll just kind of go home and wait for IT to figure it out. So having those procedures at that departmental level that kind of walk through those operational workflows so everybody is aware, testing them so that the management at that department knows this is what we're going to do, this is how we're going to maintain. It becomes a lot less stressful, ease of use throughout all of those operations, and just kind of provides a peace of mind, really. So I think it's pretty effective when you're able to kind of go through all those necessary steps.
I always, when I'm looking for a new vendor, especially for like EMRs, do they have an offline option? Somebody was dogging Meditech yesterday, but man, no one broke into Meditech because there was always that offline option, right? Looking at those vendors, do they have an offline option? What are their backdoors, right? Does your central supply have a relationship with your Medline rep where they can call in and say, hey, we're down, I can't order, but this is what I need? Again, like it's the shifting of the wheat. You really get to see who shines in these areas. So many vendors, they have those options, just no one asks about them. They may be relics from the 90s, but they're like, yeah, we still got it up and running. It's, 4 people are using it across the globe, but yeah, we've got it if you need it, and I think that's, we tend to get away from that, like when we're looking at vendor negotiations and development and stuff like that, like what is your basic option available? What is your backup? What is your offline version? Can we fax payroll? Is it going to be smoke signals? Is it going to be carrier pigeon? Whatever. But most vendors have it. We just don't ask about it. Especially, in the more management, we kind of assume somebody has asked those questions already for us, and that's almost a derelict of management, I think, overall, is not knowing your vendor's processes.
It's easy to leverage, like when you're doing vendor security assessments and you want to make sure that they have a secure solution for the data you're going to be sharing with them. A lot of times that's just on IT or the security team to go through those processes, and management or that department manager that's going to be using the solution may not even be on that phone call And so they may not have any idea of what that would look like. And it's not really something that they're thinking about, right? They're thinking about, oh man, I got this shiny new toy that I get to go, use and utilize, and it's going to make my life easier. Not so much about, well, what happens after I'm using it and it no longer works, right? And so, I think it's definitely important to have everybody involved to kind of walk through all of those steps, because vendors do have that, right? It's a requirement. Everybody's asking them what it is, but it's not that it's communicated or documented in many cases, and so people are just unaware of what that process is going to look like when it does occur.
Because it's not the shiny new product that they're trying to sell, but they still have it on the back shelf somewhere.
Yeah.
But I think that's like you're saying, the managers have to. They got the shiny new toy, but you need to know if you've still got that backup in place.
Well, and I would encourage people on top of that a lot of us go through that process when we're contracting for a new product, but then it's just on auto renewal. And it may be 5, 10, 20, 25, 30 years before anybody takes a look at it again. So, include that when you're going back through your reassessments too. Is go back and say, okay, they had a product that worked fine 5 years ago. What's the options now? How is it looking now? And that's not just for disaster recovery, but for security in general. I see we've got about 15 minutes left. Does anyone in the audience I would invite people from the audience to come up, any questions they have about the process or disaster recovery, backups, business remediation? No?
No questions?
Oh, I take back that sober comment. All right. Well, let's see. We've got some time. Is there anything else top of mind that you guys would like to talk about? Anything we may have missed?
Well, I think downtime is also a good opportunity to review who has access to what, too, and then have that part of your coop, because there's a lot of people who think that they need a lot of access. And sometimes it's absolutely legitimate, and sometimes I think we just get, it's what some other manager allowed, so we allow it, and we keep on going. Does every clinician need a work email, right? Does every dietary need access to a database? I think that at times, we just kind of allow some old ghosts to just kind of roam the halls and facilities especially, and we don't cleanse we don't cleanse the palate, and we don't say, okay, we're reviewing the standard of who has access to outside email versus internal email versus no email at all. Are we reviewing who actually, who needs a computer? We all think we need it, but I'm not that old. And when I started in healthcare 20 years ago, there was one computer on the med-surg floor, one. And that was to put in labs and orders, right? And to admit somebody. Everybody else didn't have it, and so it wasn't that long ago. And now we're to the point where, I walk through my local hospital and, volunteers are like, oh, here's my business card, you can email me. And I'm like, why? Why do you have that? Why? And so I think that, again, having part of your coop at least is just to review who has what. And you could probably go on for hours about who has what, because you actually have to deal with it.
Yeah, there's definitely a lot of times, and again, we run into it all the time, where it's like a new manager takes over a department and they just continue on with what has been done. And then, other times where people come in and they're like, well, you don't really even need access to the EMR, like you're not doing anything there. Why do we need to grant you that access? And so, it's just a part of kind of the risk exposure that you're allowing to have that happen, right? And I think from a kind of disaster recovery and being able to manage that. You know, it's not a sexy answer that anybody really wants to hear. A lot of it is documenting and testing, and nobody wants to go through those documenting procedures, right? It's not always the funnest. But again, you'll be surprised on the benefits that come out of it when you really do, because it highlights a lot of things. You know, I've done it with many departments where the management was like, I didn't even know we were doing that, or I didn't even know we were using this solution. Or they're like, we're paying for this software and we haven't used it in 5 years. Or, you know, there's a lot that comes out of just kind of documenting those operational workflows to the point of understanding how you're going to recoup and manage any, you know, disasters that will happen, or, you know, denial of service or lapse in having access to that data or solution that you're leveraging every day.
Yeah, that's a very good point, in having all levels of staff involved in those evaluations, because yeah, that makes perfect sense to me as the president, but I really don't know what she does. So.
Yeah, and once you go through the exercise once, it's way easier to maintain, right? It's just getting through that first exercise that's a little bit of a hurdle if you have nothing documented today. But again, you'll be surprised at all of the benefits that you'll reap from that, really.
And turnover too. You know, having a plan to train the turnover, especially managers, just because when something does hit the fan, you know, the employees are going to look to that manager for leadership. And if they haven't done a drill or at least a tabletop, or, you know, you're really setting up your managers for a potential failure just by not, you know, setting aside or scheduling that time to say, you know, to do like either a mini drill or a tabletop, and, you know, not something on Health Streams, not something on Silverchair, but an actual, you know, review of the plan. Because if it does happen, you're going to have a lot of trust loss between your managers, your new managers, and those employees that they supervise. Because, you know, a lot of employees think we learn this stuff through osmosis. You know, a lot of managers think that people learn things through osmosis as well, and we all know that's not the case. But, you know, when you have those key turnovers, you should plan on having a drill, really.
I think that's a great point, because in reality, from the end user's perspective or from the management perspective, when I've walked through those, that's really the benefit that they see right up front, is in the event of turnover, not only just management, which is key, but other key resources in the departments. I think if you have a documented plan, this is kind of our daily operational workflows, these are the solutions we use and what we're responsible for. If you can hand that to somebody to go over and kind of review, they'll learn so much from that information just walking into it. Not only you won't lose that continuity between management and that turnover, but they'll be able to get up to speed way faster than just trying to follow somebody around all day seeing what they're doing, right? And so having that is key for that turnover, especially at the management level. Yeah.
And the more simple it is,
right,
the easier it will be to navigate too.
Yeah, definitely at those procedure levels, you know, making sure that a fifth grader can understand it is key, so that it's easy to pick up, be like, oh, I get this, I understand what we're doing, you know, I've heard of these solutions. And, you know, there's always some time to get comfortable within any new workflows as turnover happens, but, you know, having something documented, this is how we manage it here, this is the expectation as well, is vital to kind of maintaining those operations through that turnover.
And something you brought up that triggered previous experience and stuff, maintaining documentation, we all agree that it's important, we all think it should be due, nobody wants to do it. How do you go about assigning a responsibility? How do you, at what level do you say, this is who is responsible for making sure that we have accurate and complete documentation of our workflows and our recovery procedures?
So when I worked with different health systems, I usually put it on the security team. And so what we do is we walk through kind of a process mapping, kind of a RACI chart that says, here's all of our policies, all of our security controls that we have implemented across the organization, and who's responsible for those controls. So when you really get down to the departmental procedures, it's not that they're responsible for everything, that IT does, that everybody does. It's really focused on what they're doing in their, day-to-day operations. And so you can get more people involved and get to that level. But I tend to put it on somebody on the security team to walk through initially saying, here's what we're saying you're responsible for. The management is involved when that process happens so that they have input to say, no, I don't think I'm responsible. I'm not doing access control for this or whatever it may be. And so they can help define that level of responsibility for their department. And then being able to say, okay, well, now you've agreed that you are responsible for these controls or, security practices across your operations. So let's document now what you're doing to manage those controls. And so, again, a lot of time it's the security team, but it's really the management at all levels that are walking through that to then say, what does this mean to me? What is my role and my responsibility in security? Because everybody at every level across the organization has a role in security, but we're not very good at defining what that role is a lot of times. And so I think it's important to make people understand that they do play a role, they do have a level of responsibility, and what that actually is, not just saying, in your annual training, like you are responsible for making sure that, you're not handing out patient data, and that there is a deeper level of kind of responsibility for security and where they fall in there.
And if you're wondering why this falls on security, our three tenets for security are confidentiality, integrity, and availability. We have a running joke that the only true way to secure a system is to disconnect it from the network and turn it off. But that violates the very principle of availability. So that's kind of why it often falls on your security team or your chief information security officer to make sure that we've got a plan to how to address making sure systems are available.
Definitely.
All right, still no questions. I think we can adjourn a little bit early and let people have some time back. Thank you all very much, and hope everyone's having a wonderful conference. And thank you guys for the engaging conversation.
Thank you.
Thanks so much.
Round of applause. Thank you so much, guys. And as we take just a couple of minutes for our next panel to get mic'd up, this is going to be your 3-minute time to stand up, stretch. If you have not taken the time to introduce yourself to whoever's next to you, now is the time. Continue to expand and grow your network. Go say hello. And if you want to also go and grab a very quick drink, you can. But we are starting in 3 minutes. So, oh, look at that. I see somebody back there shaking hands. Good for you. Introduce yourself. Say hello. All right, let's keep this momentum going. Next panel ready? Thumbs up. Fantastic. The mind, body, and spirit are one. Let's learn what that means and the wellness connection. Yes, you heard that right. This is going to be the topic of our next panel and our next discussion. We all want to feel healthy and happy. It's something we strive for in our everyday lives. But what does wellness really mean? And how can you achieve it? I'm especially excited about this conversation because we hear, the words health and wellness just thrown together simultaneously all the time these days. So let's get answers to such questions and more through this next discussion. I'd like to bring up now our moderator who will begin. Please help me in bringing up Tammy Chang, physician and co-founder of Pink Coat MD. Come on up. And there you are.
Hello, can everyone hear me okay? All right, everyone come on up and grab a seat. Oops, excuse me, get ready here. Okay. All right, I'm thrilled to be your moderator for today. So I am a practicing pediatric oncologist. Oh my God. I'm the medical director of Provider Wellness for Multicare Health System, and I'm also the co-founder of Pink Coat MD, a digital platform to help us retain our women physician workforce. So I'm also an author, speaker, leadership coach, podcast host, and I'm part of a global chief wellness officer community really dedicated to trying to help solve our healthcare burnout crisis, which we are experiencing as a global community. So I'm excited to introduce all of our wonderful panelists today. So our first is Krista Theos. Am I saying your name right? Yeah, perfect. And we had a wonderful breakfast this morning, so we're just going to have breakfast 2.0 this morning. Krista has a long-standing background in healthcare. She is the founder of Healing Purpose, a holistic empowerment group that aligns passion and purpose to transform lives. She is a credentialed change and project management expert, and as well as a certified master practitioner in NLP, neuro-linguistic programming, hypnotherapy, and mental and emotional release. She is a self-proclaimed wellness globalpreneur, and she absolutely strives to pay forward, really to serve others and to heal. When she is not with clients, she enjoys really great family adventures with her husband and children, as well as live music, painting, gardening, new dining experiences, and the occasional Netflix binge sesh. Welcome, Krista. And our next panelist is Eric Durek. So Eric, he is one of our nation's, I know you've actually heard from him already during this conference. He is one of the nation's leading exercise physiologists and health educators. He has over 35 years of experience in health promotion and has presented at over 200 national and international conferences in exercise medicine and health promotion, now 201. He has also logged thousands and thousands of hours in clinical care, wellness, and research. His career has been a series of firsts. He first produced the leading edge research in diabetes and exercise way back in the 1980s, and I won't say how old I was back then, just starting one of the nation's first exercise and cancer programs, which I'm very interested in, back in 1994. His latest venture is the production of Healthy Stats health outcome software, which hopefully he'll share a little bit more about on our discussion today. And it helps us capture wellness data on specific medical conditions using exercise over time for one to many and thousands of patients. He is the host of Med Health Fit Wellness Show on TV Santa Barbara, and he's been a guest on many national podcasts. Our next panelist is Winnie Chan Wang, who also is taken to the stage again during this conference, and she is a really exceptional, talented woman. She's a mindfulness and traditional medicine expert, an international speaker, best-selling author of Honoring Darkness, Embrace Shadow Work to Nourish and Grow Your Power, and a professor in acupuncture at Alhambra Medical University. She applies integrative practices to help her clients reduce fatigue, pain, anxiety, fear, and worry. And we'll be talking a lot more about that today. She holds many degrees. She holds a Master of Science degree in Oriental Medicine from Alhambra Medical University. And before starting her traditional medicine business, she also earned dual Bachelor of Science degrees in Computer Science and Finance from MIT, which you talked about this morning, and a Master of Science degree in Integrated Marketing from NYU, and has worked on Wall Street. So she has quite the background. And she is currently a doctoral candidate in integrative medicine and is based in the LA area. Mark Pugh, also taken to the stage. We have such a great panel today. So Mark He, and I love this line, he's a self-proclaimed passionate educator and agitator who has been addressing painkiller overprescribing since 2003. He's an award-winning international speaker, blogger, author, and jurisdictional advisor in workers' compensation, and the co-founder and provost at workcompcollege.com. He has presented his educational content more than 667 times in 42 states and counting. And his work is focused on the intersection of chronic pain and appropriate treatment. And he is also a vocal advocate of the biopsychosocial spiritual treatment model, which I know we will talk about today. And last but not least, Denise Leslie. She is the founder and CEO of Medical Sports and Massage. And we actually talked this morning, we both grew up in Portland, Oregon, so we go way back. So in 2010, she really had this vision to create a healing space to facilitate wellness through massage therapy. And then in 2012, she opened medical and sports massage in the Atlanta community. In addition to her thriving business, in 2018, she partnered with the East Georgia Cancer Coalition to offer oncology massage. And we talked about this morning too, because I'm also an oncologist and we offer massage in our clinic every day for our children. And that has become known as Hands to Heal, which is really powerful. She pours her heart and soul into clinical massage and is also a gifted facilitator. And she absolutely views herself as a small part of each person's healing process. She's a proud mother of two, a son and daughter, and both of whom are scientists. Did I leave anyone out? Okay, it's quite an esteemed panel, so we'll have a wonderful conversation today. And so we're gonna spend some time as a group discussing. We're gonna actually then also have dedicated time for each of them to talk a little bit more about their expertise, and we'll leave time at the end, of course, for questions. So my first question to you all, because we've got such great experts from such a variety of backgrounds. I'd love to start at the very beginning because this is a Health 2.0 conference, right? But this is the first session that's fully dedicated to this concept of wellness. So I'd love for each of these experts to share what wellness means to you. So we'll just start from Krista. We'll start here and head to the end. And if you want to give it a try, go first, and we'll just pass it along.
Thank you, Tammy. So I believe that wellness is the comprehensive awareness and the intentional actions towards whatever your optimal state of being is being. So this is being your best you. And this means looking at the...
Do we have a mic issue? We don't want to miss anything you're saying. We got to have one on every panel. There's always got to be a mic problem, right? Especially when we have like 6 mics going.
Testing. Okay. I will start over. There's always one in the group.
Start over, exactly.
Yeah, so I believe that...
It's like breaking a wine glass at a party. There's always gonna be one.
So wellness is the comprehensive awareness and the intentional actions towards your optimal state of being. It's your best you, authentic self coming forward. So this is looking at those internal and external energy exchanges that you have across all areas of your life, and then implementing improvement strategies, techniques in order to live your life to the fullest.
That's beautiful. Thank you. Eric.
So when I was younger, I I did a lot of reading about wellness, and the classic definition back in the 70s and 80s from Herb Benson and all these people was the physical, the psychological, and the spiritual well-being, and not just the absence of disease. But as I'm kind of going through my journey over the past 30, 40 years as a professional and also as a person, it really is the aspect of self-awareness and self-care, and what we talked about this morning was just this application of energy and love to other people. And when I was younger, I never, it was all the scientific basis, but now I'm really trying to pick up on this and spread this to other people. And that's how I think from a practitioner's standpoint, from an educator's standpoint, you have the biggest impact, is that you can understand to get people to, as we spoke about this morning, how they can help themselves, which is going to be one of the biggest things in healthcare. And that's where I think the mind-body aspect comes into play, because really mind-body is maybe the highest application of self-care that you can have.
Absolutely. We were also talking this morning about how we're really trying to we hope to empower individuals to do this for themselves, because ultimately it really comes down to each of us and what self-care means to each of us. Winnie.
In traditional Chinese medicine, wellness is like a river. Where there is stuck, there is pain. And where there is flow, there is wellness. And wellness includes the totality of a person, which includes also relationship and finances, right? If I'm still angry about the way I was dumped in my last marriage, or if I'm afraid of how I'm going to make enough money to put food on the table this month, my body is going to generate the stress hormones and negatively impact my nervous system. So when we talk about wellness, it's really about trust, love with joy, coming into the alignment of living our soul purpose and just waking up every day like light up and ready to go.
Thank you very much. I think you embody that too as well.
I try, I'm the hacker.
You do. You bring joy to all of us on this panel. We definitely love hanging out with you. Mark.
Well, one challenge being fourth on the panel, good luck, is they've taken all the words, but self-efficacy is what I've kind of wrapped my head around over the past 20 years in work comp, and we have not done a really good job from an insurance and healthcare standpoint. We've developed a codependence, oftentimes from a patient to somebody or something that's going to take care of their problem for them, and we've turned the patients into passive passengers in this journey. 80, 85, 90% of injured workers actually get back to work. Everything works perfectly, the system works well, but if it bleeds, it leads. And so we hear about the horror stories, and oftentimes those pertain to chronic pain. Some of those people should not have chronic pain given the scope and the kind of injury that they originally accumulated. It's because we failed, or because they have become codependent on the system, codependent upon an injection, codependent upon pills, codependent upon somebody laying hands on them or doing something for them. And the patient has just become this passive passenger, and they just expect everybody else to do stuff for them. In fact, in some cases, I've read tens of thousands of pages of medical records, looked at tens of thousands of drug transactions, and it's very, very clear that some people actually get secondary gain from pain. And pain has almost become their middle name because they get preferential treatment. You had mentioned in our panel yesterday, it's kind of playing the trump card a little bit that they've got that. And it's very difficult to do that. So I think wellness is really when you get to a point when you realize that there are things that you can do, like deep diaphragmatic breathing, mindfulness, proper hydration, proper nutrition, things that you don't need a prescription for, you don't need a doctor or any other clinician to do. It's just the motivation to get out and walk, to get out and run, do whatever. So that's where my head is, less from a I guess a squishy kind of feeling, and more of that insurance. How do we actually implement this? That makes sense.
Well, absolutely. I mean, we look at the way healthcare is today internationally, right? It's so dependent on pharmaceuticals. It's reality. Right?
Well, and the healthcare system is codependent upon the patients too. So there's this weird kind of conundrum. Are we doing the right things for the right reasons, or are there misaligned, incentives that are causing actually more harm than good?
Absolutely. Thank you, Mark.
If I were to add anything to everything that was just said, it would be educating ourselves on the daily choices that we make and how that impacts our bodies. So I think education is definitely a part of wellness, because that is going to impact and drive decisions and behaviors. And then there's so many wellness options out there, and what works for me may not work for my best friend or for the man that I love. So finding what brings you balance and do that. And as you grow and evolve, those things change, and that's okay. So I think education is definitely a piece of wellness that we should discuss today. Thank you.
No, absolutely. Thank you. I mean, that's what we're hoping to do, is to educate really the public, right, on the power that they have in their own well-being. So This next question we were discussing earlier is so pertinent, right? Because we're now at the tail end, 3 years of this pandemic. We've seen a world global crisis. We've all been a part of it. There's not a single human being who has not been touched by this, right? It doesn't matter who we are or what our background is, how much money we have, what part of the world, we have been touched by this. And so why is this topic today that we're talking about, this giant topic of wellness that we're trying to cover in 40, 50 minutes, why is it so relevant today? And feel free to just jump in, everyone.
Start off. I definitely think that this discussion is very timely. I'm not a doom and gloom type of person, but I definitely believe that we have not begun to see the peak impact from this global pandemic that we are currently recovering from. And I think it's very important for us to continue to have these conversations, to raise awareness, so that we can help to reduce the stigmas around having conversations about mind, body, spirit, mental health awareness. And it's also very important to help us to be able to raise concerns about the challenges of living in this current human experience and the challenges that we have around access to care that may prevent some people from getting the help that they really need. So we need to keep this conversation definitely going.
Yeah, take it.
I think that actually the pandemic did a lot of good in the wellness field, because during the lockdown, I don't know how many in the audience also had this experience, but they started gardening or they went on YouTube and started exercising.
Yeah.
I felt that we actually took a little bit back of the power of self-care, because guess what? We don't have to drive the kids to work. We don't have to cook breakfast and wake up at a certain hour or even change out of our pajamas. We can just relax. I felt like during the pandemic, a lot of us learned how to be, and that's so beautiful. And I just want to tell this one quick joke, which was, I actually got my yoga teacher training during the pandemic. And one of the homework was to take the coldest shower possible every morning. And as a traditional Chinese medicine doctor, we are all about hot bath. And part of my brain is like, oh, it does not compute, does not compute. I must drink my hot soup, take hot bath. And asking me to take the coldest shower possible, eating raw vegan food, was a really big stretch. And I really want to bring back to what Denise said, which is we need to listen to ourselves, right? Just because cold shower works for somebody, it doesn't work for everybody. And I think the message I really want to impart on everybody is that we are our own expert and we get to be empowering ourselves.
But, I'll add on to that and talk about hot, cold treatment and the education piece. So we know what heat does. It relaxes the muscle fibers. It brings blood to the area. But what does cold do? It reduces inflammation. It vasoconstricts. So educating yourself on when to use certain wellness modalities and why you want to use those and how you use those modalities, I think is going to be very impactful for your health and well-being.
And to add on to that, opening this Pandora's box of the behavioral issues in this country was a big deal. And even in the fitness world, there was a study that just came out the day before I left for this conference that said that exercise, third study, but it was the biggest one, had the biggest impact on the severity of COVID symptoms. But it's the behavioral aspect that I'm sort of shifting to, because these things are now so important, and whatever mind-body practices that you can do to help depression, loneliness, etc. There's so many things now that this is going to be a big thing. But because we have such big brain power here, we actually talked about this, in our Zoom call and this morning, and there are answers to all of these things that are simple. They can be done at home. They can be done regularly. Just the breathing. We talked about breathing and all of these things.
They're free.
They're free.
They don't cost anything.
Exactly.
Right? We're one of the most expensive, we do spend the most money per capita in the world on healthcare, and yet we're still not really, we're just scratching the surface of the mind, body, spirit connection, right? I'm hearing a real a theme here, which is that there's almost like the pandemic was a silver lining. There are some silver linings here. Yeah, Mark, what do you think?
Just to put a final bow on it, it was a resilience check for everybody. And I think there were a number of people who felt like they were resilient and realized that they actually weren't. And so it's a top of mind kind of conversation. You know, for example, my daughter-in-law had breast cancer. Fortunately, she was able to get through that. I lost my uncle, lost my job, I lost my gallbladder. My daughter got married. I got a new granddaughter, two new granddaughters. So, you know, life is kind of this ebb and flow. And I realized that I thought I was resilient, but when those gut punches kept coming, it's like maybe I wasn't as resilient as I thought. And as a parent, I loved that my son, who you try to instill values to, right? You do everything you can as they're raised. And it was amazing to see he and his wife and the resilience that they had when they were confronted with a newborn baby and then going through breast cancer, chemo, mastectomies, radiation, all that kind of stuff. So as a father, I was able to look at my son and his wife and say, you know, resilience, you don't really know, like Mike Tyson used to say, you got to plan until you get punched in the face. We all got punched in the face, some of us repeatedly for 3 years. And I think we have learned a lot about ourselves. And I think that is the silver lining is coming out of that. We know where our weaknesses are. We know where our strengths are. We can focus on our strengths, work on our weaknesses, and we're actually going to be better off for it.
It's the whole concept of post-traumatic growth, right?
Mm-hmm.
And how the depth of our resilience is so much more than we realize until we're tested. Thank you. It's very true, I think. It resonates for me. I don't know if it resonates for some of you in the audience too as well. Well, what I would love to do is then take us through a little deeper dive into each of your areas together, and then we'll do a group discussion, of course, at the end. And so my first question I'd love to ask Krista, this is, which I think is a great question coming from our just kind of bigger, broader overview. What does holistic wellness really look like? And is it achievable? What does that even look like?
I definitely think that it is achievable as an approach. So holistic, as we've all been saying, is taking into account the full whole person. So that's your financial, your social, your physical, your mental, your spiritual, your whole self into account. And if you have a particular goal that you have, you want to make sure that it's a SMART goal, you can have that goal and assess it against the feasibility of hitting the other areas of your life. So for instance, you know, I want to improve my physical health, I want to improve my muscle tone, and I've got a SMART goal that I'm going to work out for 3 days a week. So
could you tell us what a SMART goal is for those of us who might be watching, may not know or be familiar?
Yes. So
you and I are coaches, so we're like all about this.
I know, we're coaches.
It may not be everyone's language.
Absolutely. So a SMART is a way that it's an acronym for describing a goal, whether it's specific, measurable, whether it's attainable, realistic, and timely. So that's a way that you can make sure that you've got a complete goal that kind of takes all things into consideration so that you can be most successful. So in having my SMART goal of being very specific, of working out at the gym 3 times a week, I'm looking at that and I'm wondering, you know, how is that going to affect my relationships, my family relationships, my marriage, my career aspirations and getting things done at work? How is it going to affect how I think and feel about myself? Just kind of going through the list of all areas of my life to see if there's any conflicts or barriers, and then assessing how I feel about whatever responses I get to those questions. And if there's any conflicts or barriers, you can adjust your goal, adjust your plan, and kind of moving forward. So I think that being holistic in thought as an approach is definitely something that is achievable. It's simple and easy to do, and however you do it is perfect. There isn't a perfect science to it. So
it's almost like it could be as simple as going to the gym just 3 times a week, and that's your goal, right?
Absolutely.
But it's actually helping you in all those different areas of your life that you just talked about too. Yeah. So that I'm hearing that's the whole concept of holistic healthcare could really just being attentive to all these different important areas and spheres of our lives. When I work with a lot of physicians, and for the most part, their pie is like work and then personal life, right? And which I don't know if that's the case for many of you in the audience or those listening, but that resonates for me. And yet we are whole people,
Yes.
Yeah.
And just one more thing before we close on that, I think it's also important to look outside of the individual. So also taking this to an organization, system, community level as well. So when you're engaging with your customer, whoever your customer may be, to think of it from a holistic standpoint. You know, what are their families going through? Are there ways that you can meet with you know, to help their families? Are there any social economic pieces that you need to take into account? Are you speaking to them in the language that they prefer to be spoken to? How are you delivering the education? Just taking that holistic approach really makes such a difference when you're looking to make those meaningful and impactful connections.
That's really insightful too, because we could even think about it when we're partnering with an entire organization or a company. I know there's so many business owners here, and it's not just one person, it's like a whole community that we're really trying to reach and connect with. Would anyone like to add anything to, you look like you want to say something,
my
Eric.
holistic program now is to add ice cold showers. How many? 3 times a day,
Even if it doesn't
right?
feel right to us though.
That's my cryotherapy. Anyway,
Cryotherapy
one of the
sounds
things that I
pretty
wanted to add, and it was perfect what you said, but the element of growth and education in terms of this holistic mindset, because we now have this open door post-COVID to really change the health system, and Mark is really moving towards that direction, as I am, and to really educate people as to the opportunities to have this mind-body practice as part of their corporate structure, their health club structure, their clinic structure, etc. I mean, you talked about pediatric massage, you talked about massage. This has to be something that more and more people have to do. This is not like, well, maybe we'll do it someday. No, this has to be part of healthcare programs.
Yes, Winnie.
I want to say we're doing holistic medicine right here, because holistic is when we come together as a whole, when we listen to all of these experts, and I'm just feeling very nourished. You know, I'm learning about awareness and commitment and resiliency and being authentic and true to self. And I'm feeling like, yes, I want to download some of these vibes that I'm getting from all of my awesome panelists.
I see a theme of the integrative medicine here coming through. Yes, Mark.
There you go.
I do want to mention, you know, the statistics of utilization of EAP programs has really been poor. And I don't know why people are unwilling to reach out to free resources that are anonymized, that are not going to be used against you in your career. But I think one of the things that we really have to work on is people leaning into the fact that it's okay to ask for help. Yeah. You can have goals, and I love the SMART acronym. I'm gonna Google that when I get off here so I can remember that. But I love goals, but if you start with the goal of just being willing to ask for help. I think Americans, you know, we historically, you know, bootstrap, you know, we're rugged individualists, and we just don't like to ask for help. And I think, I don't know the specific statistics, but what I've heard is probably less than 5% of utilization of EAPs.
Yeah, it's about 10 to 12%.
10 to 12, still.
Of an entire organization.
Yeah, still really bad.
At
So,
best.
Mm-hmm.
You know, Mark, something that you said made me think of something, and I wanted to share with the audience. I share this with my children, and I've told them this growing up, and I talk to my employees about these things sometimes as well, but it's okay to be angry. It's okay to be upset and sad. It's normal, you know, and so you don't have to always feel like if I'm sad today and tomorrow, and then I'm sad again on Friday, that something is necessarily wrong with you. Feel that emotion and work through it, but think about the next best feeling. Okay, what's gonna get me back to joy? What's gonna get me back to myself? And what's the next best thing? Because I don't want people to think that because something frustrates them or something makes them angry or they're feeling grief, that they need to take a pill or they need to go have a drink or whatever that is to feel joy. It is okay to feel those lower emotions.
Well, they're part of the human experience.
Yes.
And so much of what we do to our bodies is to numb that, right? Because it's so uncomfortable. And yet we do more harm to our bodies and our minds and our souls, right? When we self-medicate in those ways.
And if your mind is bad, your body is as well.
Absolutely.
So anxiety, depression, anger, all those kind of things has a definite cause and you know, for other things that that connects the mind and body in a way that we don't want it to be connected.
We must work through those circumstances so that those circumstances and the trauma and the impact of those situations don't get stuck.
Absolutely.
And the use
Yes.
of the mind body, like educators like ourselves, to sort of elevate the status of helping people work through all that stuff, and to put mind body, I think part of this panel is to put it into a place within healthcare where it belongs.
Yes.
And to add on to Denise's point, it's okay to be not okay. It's okay to be angry. That, you know, you talk about integrative medicine. You know, I wrote this book called Honoring Darkness, Embrace Shadow Work to Nourish and Grow Our Power. It's playing on the resiliency. You know, we are actually all whole. You know, when we came as babies, when we're 3 years old, we all was whole and authentic, and somehow we disconnected from that. So when we sit with, you know, with the awareness, when we sit with being angry, then we actually learn, actually, we're very resilient, you know? And so, yeah, so what, as a hacker, I identified the 10 most difficult emotions, including anger, fear, shame, unworthiness, and creating conflict. You know, I have this inner drama queen. And I wanted to write a textbook with exercise where, you know, you just go through the book and you do the exercise and you can systematically remove these mind blockages, right? Mind blockages, so that you can go back to being whole.
It's wonderful. And I actually think that's a nice segue to the question I would love to ask Denise, if that's okay. We'll come back. So you had this question here, and I really like this. How does the mind, body, soul respond to anxiety? And what is the acute impact and the chronic impact? And I think that ties in very well to what we're talking about here together.
Wow.
Big question.
It's your own question. Come on.
A question you want me to ask you. So.
Don't act surprised.
Yeah, and I wrote that question, what, how many weeks ago? Well, our cortisol levels go up, our adrenals work, so our hormones in our bodies start producing or not producing. And so when we're in that acute state, but then it becomes chronic, we're going to see effects from that. And so the body responds to anxiety by turning off certain hormones and turning up others. And, you know, we don't want to be at a constant state of that because we're not meant to be in fight or flight all of the time. And what I'm seeing with the children that I'm working with, because I work with youth that have been diagnosed with stress, anxiety, and depression, is that their bodies are not producing the proper hormones to support them. And as a result, they're having irritable bowel issues, they're having circulatory issues, they're having mental issues as far as not being able to focus in their education. And as a result, it's impacting their relationships with not only their peers, but their parents and their educators. And it's sad. So that's how our bodies respond. And there's tons of modalities that we can do to reduce and reverse, which is the work that we do in Atlanta with our children. So thank you.
I wonder, thank you. And I'm curious how that ties in, Mark, to the biopsychosocial workers recovery model, because I wonder if there's some connection there. And I wonder if, could you share a little bit more about that for us all?
Well, the insurance industry is very adaptive. They're very innovative. They constantly lean in. No, they don't.
I was like, wait, are you joking?
So it's been a real challenge over the past 20 years to get out of that biomedical model where something is going to be done to you that's going to fix your problem, as opposed to taking into account the whole person. And so I coined this phrase about 15 years ago. What happens between your ears and what happens at home has as much to do with your willingness and ability to get better as what's physically wrong with you. In other words, the psychosocial baggage, and I had a mentor of mine that added the spiritual component, the biopsychosocial spiritual component to it as well. It's really taking into account that people bring, even to an occupational injury, they bring baggage. they bring psychosocial baggage, they bring adverse childhood experiences, they have social determinants of health concerns, just a lot of different things. They bring physical comorbidities associated with that. They have, back to the social determinants of health, they may have supportive family, they may have a family that's very negative and actually drags them down. They may have poor medical literacy, so when the doctor is using 75-cent words, they got a 10-cent dictionary and they don't quite figure out what's going on, so they can't actually implement what the doctor said. And so it's been a very, very slow process. There was a few of us John the Baptist out there that were kind of leading in the wilderness for that, but we're there now, and people are actually starting to talk about this and actually implementing it. And the new program I created at workcompcollege.com, we're actually creating a workers' recovery professional certification for those that go through our coursework, and it's raising the mindset that this is a human being, not a claimant, not ones and zeros in a database. And when they have a meniscal tear, yes, it may be a meniscal tear that needs a biomedical fix, but they may have distrust of authority figures. They may have poor medical literacy. They may have poor resilience. That was because of traumatic experiences, all that kind of stuff. So we don't want to own all that, but in reality we do, because substandard outcomes where they don't actually return to work on a timely basis, where they don't get full recovery, may not be due to doctor incompetence or the complicated work comp system. It may be due that they brought some stuff to the party that we ignored. And so it's been an interesting ride to see the industry kind of change its mindset and get out of that, I mean, we still have fax numbers on business cards, for God's sake. So,
We do too.
we're not necessarily the most innovative industry, but I think I have seen that change on the front lines, and it's been really fun to watch. Got a long way to go though.
That's very powerful. It's looking at the whole person, not just their knee, not just their back injury, right? And then the greater impact of what that has on the industry, regardless of where the injury happens, right? Whether that's in healthcare or outside of this industry, because then it could potentially be much more costly for those people to be out of work over time. I'm so curious too, because Eric, the question you wanted me to ask you, it kind of ties in a little bit too, because you asked, what is the link between the mind-body medicine in our future healthcare system? And I wonder what you see there for us in the future going forward.
I'm going to answer, but I want everyone else to jump in because my viewpoint of mind-body has changed over the last 30 years. But what I've seen with people who practice traditional Chinese medicine, with people who do massage therapy, with people who do Reiki work, and I spoke with somebody yesterday about NIA training, which is a specific type of exercise in mind-body movement patterning. And everybody thought that that was some woo-woo thing that the fitness profession did until MD Anderson Cancer Center implemented it with their survivors. Then it became the status, and that's where the integration occurs. And I see this, Mark said, step-by-step process. I've worked at the University of California in work comp recovery, and I saw that these small steps in the change in culture will have a big impact over time. And I think that the mind-body, if you can, and I don't want to get into data and all this, that's important, but the thing is that these small steps and these integrating of these different types of programs where you can change physiology, you can change the behavior, but you can also change the culture of the people who are on the job or doing whatever it is that they're doing, that they can have an acceptance of it. I think that there's nothing wrong with mind-body from its application status and its research and whatever. That there are thousands of studies, as you know, on massage and cancer, thousands of them. Yoga and cancer, thousands of them. That's not the issue. The issue is having be accepted with someone who's undergoing cancer treatment with their healthcare system. And
they get integrated into their healthcare without them having to ask for it.
And as a cancer professional, I know we've got a few here, I am privy to the American Cancer Society and the NCCN network. In 2023, we'll be implementing standards of professional care for exercise and recovery, which means that it will be part of the healthcare system in the next couple of years, which I find to be phenomenal.
Because you started that in the 90s.
I started 25 years ago, and 25 years ago, I said to people, exercise and cancer will be the new cardiac rehab, and now here we are.
I'd like to ask a question really, Krista, because you have change management in your bio. We're talking about change from a personal standpoint, a corporate standpoint, an industry standpoint, a societal standpoint. What are some tips from a change management that we can kind of overcome that inertia? Because it ain't easy.
That's a big
Well, I'll
question.
tell you, if I had that golden buzzer, I would be a billionaire right now. But some key things, and I'll touch on that, is that it's really exciting. I get really exciting thinking about the future of healthcare just through my own 20+ year journey in this space is, seeing wellness integrated with those technical business strategy type of goals is really exciting. And even in my local area, I've noticed that there are health systems that have a integrative medicine realm that's slowly starting to grow. So it's really exciting to see this kind of come to fruition. And I'm really excited for the communities to get a hold of this as well. So change management, it's all in just kind of assessing the pulse. As we've noticed, the silver lining of COVID is that there is, a greater sense of compassion for your fellow, peer, your fellow person on this planet. There isn't one person that wasn't impacted in one way or another by the pandemic. So just being aware of that, being aware of the needs as a global community is the first step. And then just in looking at areas that are doing it well. So you mentioned MD Anderson is doing it well. There's other spaces even outside of the healthcare industry that are doing wellness well, taking those learnings and bringing them forward. But I'll tell you, being someone on the inside from a health system perspective, the patient, the community has lots of power that they rarely tap into. You rarely see that empowerment coming forward. The more that you ask, the more that you will receive. So the demand will drive the growth of programs and the appetite for that, and not just the health system, but in other industries as well.
Oh, absolutely, because in healthcare, we like to have this phrase that the most important person in the organization is the patient, right? And the patient really does have the largest voice when we come together. Thank you for sharing that. And Winnie, I'm going to ask you the one question before we open it up for more Q&A and just general discussion. I know you love to look for the golden nugget in everything and everyone around you. So what's your takeaway from our discussion today?
Yeah, I want to bring a point that Mark said, which is, as a society, we really suck at asking for help. It's true. And like you guys said, it's like the patient asking for the help is what is actually going to drive change in the healthcare system, right? So bringing this and this together is we get better at asking for help. And, of course, as a practitioner of integrative medicine, I'm actually writing a second book called Unlocking Light. Receive help to unlock your original wholeness. Right? Because my goal is to showcase as many different types of modality so that the end user can ask the right question. Hey, I think I heard that this is really working. Yeah, so I just really want to educate the public about the options that are out there.
Absolutely. Anyone have anything you want to add to that? Mark
summary.
Looks like he's stunned. Well, we actually have about 10 minutes left, and so I'd love to leave a little, I see someone who's coming up for a question, so we'll have some time for Q&A. What we would love for everyone in the audience to be thinking about today is, what is your one take-home message from our conversation today? Because I think our brains can handle like one thing at a time. We're unitaskers, right? We always think we can multitask, but actually we are unitaskers. And it really helps us to put it all together to think about what is our one takeaway from each session that we attend. And so we'll answer a couple questions, and then I also want each of our wonderful panelists and experts to share their one takeaway for you all too as well today. So if you want to ask your question, go for it.
Yeah, thank you. My name is Toni Gittles, and I work with family caregivers. I've never been much of a visionary, but I've really stumbled across some information that I think really relates to mind, body, to wellness, and that is the principles of positive psychology and teaching people about happiness, because it's really practical application in their everyday life. And I've started using this with family caregivers because it's a negative journey for the most part, but looking at the positive impact. So I just want to throw that out as an option, or if any of you have looked at that or studied it, it's incredibly powerful. But also, I didn't really connect with spirit during the panel discussion. So my question is more around that, and how does that integrate with
Anyone like
mind-body?
to answer?
Well, two times on this panel at the beginning, the word love came up. And that is something you never hear in healthcare, that I love my, some people say I love my job. A lot of people say they love their jobs, but a lot of people don't understand the integration of love. And happiness, love, self-awareness, all of these things are part of mind body. And I think that that's the kind of thing that needs to sort of be pushed here. And I told the panel this morning that I did my first breathwork class just couple months ago, and it was an amazing experience. And so that growth, the happiness, the things that I'm actually trying to share, that there's this whole element of growth in there, and that's part of the happiness, the love, and the success. The success has to be part of this too. A person has to succeed with their therapy, otherwise they're not going to do it anymore.
Well, even that word is judgment, but spirit is, for me, and I tell my patients, slow down, take some time, sit in silence, and listen. Listen to your breath pattern, listen to your thoughts, listen to your heart, and you'll get dynamic downloads. And for me, that's what the spirit connection is to your mind body. And I mean, we can go on and on about that, but I definitely wanted to share that with the woman who just asked. Thank you.
Thank you so much. Next question.
My takeaway from what I heard from you all is that, frankly, you don't understand how managed care people's minds work. Okay? And
is that Barry?
Okay, so I did that for 26 years, but coming from the clinical space. And so if you work for one of these nationally traded places that trades on your attention span is 3 months, because that's when you have to do the quarterly payment. So nothing that you can sell them that does not have some financial benefit over 3 months or outcome benefit matters. If you get into the space of the provider-owned HMOs, it's often 1 to 3 years, so it's a better place to go. And building outcomes is good, but you've got to make the case that the outcomes link to financial. I knew a lot of other medical directors, and most of them were not in there to say no. They were in there to say yes if you could prove the point to them, but they were pretty tough about what's your evidence base. So doing what you have, and I hear people trying to do that by building the evidence base, because we're talking about stuff that's not out of the usual realm. It's not a pill that you can do the test on. And it's complicated by all the other factors you've talked about that come in. And then the last point to your point is, I find that music inspires me. And when I get in the car in the morning to drive someplace, my phone starts playing music. And when Pete Seeger comes on singing "We Shall Overcome," I'm inspired for the day.
Yes.
I'm going to make a quick answer to your question. Mark and I have a lot in common because I spent 17 years at the University of California, which is the second largest employer in the state of California. And my mind, body, spirit wellness program in facilities management over 17 years, we were able to reduce back injuries to about 2.4 per year, over 350 employees. And in 17 years, I had 0 back surgeries, 0.
That's the kind of evidence.
Absolutely. I got a ton more for you too. We're going to talk.
Yes, that's a whole nother talk.
That's
yes,
a whole nother talk.
That's actually a big focus of what I do, is making the financial ROI argument for everything we do.
And one other comment real quick, work comp is different than MCOs because we own the care for the life of that claim or the life of that person. So it's been interesting when I've dabbled in the MCO group health standpoint. It's going to be somebody else's problem potentially on January 1st because they're going to be chasing a lower rate. And so now they're not worried about the long-term benefits and efficacy. They're really focused. And that's why I think work comp did a really good job in addressing the opioid overprescribing, because we were paying for naloxone, we were paying for, all the other cocktails of drugs that came from the symptoms. And so not all payers from an insurance standpoint are definitely are built the same for sure. So I feel your pain.
No pun intended.
Right.
Yep.
Yes.
We have time for 2 questions.
My question is, I'm a healthcare provider, and we all talked about helping other people, which is great. But if our battery is really low, our selves of mind, body, and spirit. So my question is like, what tool do you use to keep that battery filled so that you can provide?
Yeah, I'll take that one. Okay, so first of all, there's a concept of energetic protection as a healthcare practitioner. And our other audience talk about, you didn't talk about spirit. Okay, that's like a whole separate panel for me. Just like COVID is contagious, our patients' anxiety and fear and anger is also contagious. And that's why during COVID, so many of our talk therapists, they had burned out, because guess what? As a society, when we have an excess of anxiety and depression, our talk therapists, they are actually also breathing in this anxiety and depression. And so the most important thing that all of us can do in healthcare is to start with self-care. Self-care means knowing when to say no, knowing when to take a break, make a bubble bath, go get a massage, go hit the gym, So protection is knowing. It's like if I'm driving from Las Vegas to California, I gotta check how much is in my gas tank, right? If my gas tank is down to the last 8, you know what? It doesn't matter how much I want to go home and see my kids, I gotta hit the gas station. So as practitioners, we gotta check our gas tank, and maybe we shouldn't run down to the last 8 of the gas tank before we fill up.
No, thank you so much. Yeah.
I just want to add.
I know we only have 1 minute left,
Yeah,
so
I'll
hopefully
make it
get to
quick.
you.
So I would say also, as a healthcare provider, you have it as a part of your leadership to incorporate it within your operations, wellness principles and those sorts of things. Some things that I used to do with my teams is we would have a positive pause. The first 5 minutes of every team meeting is talking about all the great things that we've experienced over the last month or so, and being grateful for certain things. And we would take that intentional time to include that in. It's also in how you set up your meetings, or you got meeting running from one to the other, or 10 minutes between Zooms, so people have a time to kind of digest what they just experienced, take a quick breath, take a bio break, and all of those sorts of things. So there's very simple things that you can incorporate within your operations for wellness.
Thank you so much. And I think we're out of time, but all of us will be available afterward to touch base and ask a question. Oh, we can do one more. We can do one more.
Come on back up.
All right, come on back.
Yay.
Hey everyone, you're all leaders up there. Thank you for putting yourself out here and changing the conversation. I wanted to ask, because we've been at the body element of health for a while, and you're all today here to contribute to the mind, body, and spirit. What do you say to people who maybe doubt that they can recover from a health challenge, if you will? That maybe their mind or body is already, like I said, they doubt. They're worried even that this is a problem that's beyond help.
Yeah. Focus only on what you want, and that's it. So the doubts, the fears, the stats, the science, that's real. But every single day, purposefully only focus on what you want, and use your mind as a powerful tool that it is, and send light to those areas that need attention. And that's how I would say to help you override the doubt. Just focus only on what you want.
Anybody else?
I like to say that trust is like riding a bike. It's actually something that we can learn how to do. And with the big word here today being resiliency, when we have this anxiety, when we have this chronic illness, we can feel like we're in a very dark place. But when we receive help, we get to see the other side. And of course, we don't have infinite money, so sometimes we can't, be with our talk therapist 24/7. So then we'll go back to the bottom, and we're in the dark again. And it's the resiliency and repeated patterns of seeing glimpses of hope and holding on. So what I want to say is trust is earned. It's a commitment. It's something that I'm committed to trusting myself, and I'm going to show up for myself every day. You know, I'm going to just end with a Brené Brown quote. You know, it's the people who show up in the arena every day that counts, right? So thank you so much, everybody, for listening.
Yes, thank you all.
Thank you for that question too as well. And thank you so much to all of our panelists today for a wonderful discussion. And we'll be available afterward to discuss further if you have other questions. Thank you.
Awesome.
Guys, we are going to be starting our recognition session in just a minute. Before we get to that, friendly reminder, today, of course, is the final day of our conference. If you have not had the chance to go get your interview done by one of our roving reporters, please do so. We want to learn about you, your brand, your mission, your team, anything you'd love to share. So all of our reporters are located with the camera set up in the backdrop. You'll see them right across from registration in the far corner. So definitely make your way over there if you haven't done so yet. And we'll be right back, and we'll be starting our recognition session in just a minute. It is my favorite time of the day. We get to start our recognition and award session. So let's take a moment. Let's do it to it. We are going to honor the incredible achievements of healthcare leaders and organizations that have played an important role in enhancing healthcare access, patient outcomes, and population health through their selfless endeavors, aka all of you. I'd like to please welcome on the stage. She is going to be our great assistant, our Vanna White, as I like to call it, Peggy Sullivan, founder of She Can. There she is. So guys, I'm going to call your name up. When you hear your name, please do a quick prance over to the stage. We will take a photo right here with Peggy. Photographer sitting right there looking at you. And if you'd like to say a couple of quick words, you definitely can. I'll gladly hand you over the mic. All right, let's start. Our first award for outstanding leadership goes to Lance Wright. Lance.
I appreciated everyone earlier for listening to the panel I was on, and I had some very insightful conversations with some folks afterwards. You know, what we do is about the people, and I don't think we should ever forget that. I know we need all the technology and all the other stuff, but we're people. And I know that everybody in this room at some point in their lives has been touched by addiction, whether directly or indirectly. And even if you haven't, you've been touched financially. So hopefully, you know, my name's Lance Wright. My company is Life Over Addiction. Feel free to talk to me and let's start a conversation about help your communities wherever they're at, because it's about us, about helping them. Thank you very much.
Well said. Our next award for outstanding leadership goes to Mehek Moen. Mehek, here she comes. And I want to give a quick shout out, guys, to Peggy here, who's stepping in as our Vanna White. Make sure you stop by and see her booth. She has an amazing company that's all about empowering women, you know, working with different organizations. So definitely stop by and see her booth in the exhibitors hall.
Thank you all at this conference. It's been lovely. Thank you for having me and for the panel that I got to participate on yesterday. And then I want to thank my team at Genentech for having such a supportive and innovative mindset to really bring forward these solutions for data interoperability that really improve our clinical trials and ultimately the way we develop medicines for our patients.
Our next award for outstanding leadership goes to Alana Bensvengo. Alana, look at her run. Love it. High five. You obviously work in healthcare, right?
Hi, I just wanted to thank Health 2.0 for having this conference. I haven't been to one before, and I have met all the exact right people that I needed to meet to take my next steps on my path. And I also wanted to thank all those people for the inspiring and lovely conversation. And I wanted to thank my new buddy, Jordan, for spending the whole time with me. So thank you.
Our next award for outstanding leadership goes to Barry Lockman of Barry S. Lockman, MD, MPH. Hey, we've heard from you a few times. All right. Our VIP questionnaire. I know you want to say a few words.
Of course, one of my mentors, Ron Anderson, who was the CEO of Parkland Hospital for many years, said in a meeting of himself, "I am not a man of few words," and my response was, "I resemble that remark." At any rate, I really want to thank Health Point 2.0. I want to thank my family and all of the people in the communities I work with who have supported me and taught me about their lives that helped me be more effective. But I also want to, and I hope I've been doing this, challenge you all, because the battle's not over. We've just begun, and we need to keep going to make a better world for the people we serve.
Thank you, Barry. Our next award for outstanding leadership goes to Dr. Deshawn Taylor. She was standing up. Keep on standing.
So I just want to say this has been an amazing conference. I appreciate the opportunity to be here in community with such wonderful leaders. What I do want to say, though, is I'm an OBGYN, and I have to mark the moment that we're in this country right now, where there are 14 states without an abortion provider. And so I hope that if you all care about reproductive rights, that you will make your voices heard and hold the people in your states accountable for expanding healthcare access and not taking it away. Thank you very much.
Our next award for outstanding leadership goes to Dr. Lisa Icole. Dr. Lisa. Thank you to our second row of cheerleaders. I like it.
It is really a providential privilege for me to be here today. I'd like to thank Conference Healthcare 2.0 for putting together this conference and for acknowledging my work in leadership and healthcare. I'd like to extend my gratitude to my husband, who is my greatest cheerleader, our 3 kids, Ndiale, Hannah, and Abigail. I wish my dad was here to see this day. He said all these things about me, and here am I in 2022 seeing everything that he said I would be come to pass. I want to appreciate each and every one of you here. And as Samuel Smile, a Scottish author, puts it, when you sow a thought, you reap an act. When you sow an act, you reap a habit. When you sow a habit, you reap a character. When you sow a character, you change destinies. My hope for myself and you all is that as we live here today, may we all continue to grow, glow, and go in the things we do to transform healthcare in America. Thank you all.
Thank you. Our next award for outstanding leadership goes to Dr. Edward D. Williams.
I want everyone to realize in this Health 2.2 that we all have an obligation is to protect the brain of our families and children and those engaged in sports. And that is my primary interest. We've got to reassess how the energy gets into the base of the brain and create the forward movement that we have to protect that energy and protect the brain. Thank you.
So intriguing. Thank you. Our next award for outstanding leadership goes to Dr. Tanisha M. Ranger.
I did not plan to say anything. I'm really grateful for this award and this opportunity that was given to me. I don't have any big, huge business. I'm just here trying to be the pond that makes a ripple effect in my community. And I really appreciate this honor. Thank you.
That is fantastic. Our next award for outstanding leadership goes to Fabiola Brugger-Daddies. Please come on up. We will send it to her. Our next award for outstanding visionary, this is for the Health 2.0 Conference Visionaries Award, is for Garrett Temple. All right.
I would just like to say it is an honor and a privilege to be here, to be recognized, and to have spoken at this conference, and I could not have asked for a better coming out opportunity for my business and what we do. If we are able to accomplish what I hope we can, 2020 will never happen again.
Our next award for outstanding leadership goes to John Thomas. There he is.
I'll say 2 words. Thanks so much for this. And it's great to meet all of you. And it's wonderful to see so many healthcare leaders that care about our industry to take time to show up. So thank you so much.
It was a few words, but all the right ones. Our next award for outstanding leadership goes to Justin Chase. Here he comes.
I just want to say thank you to Health 2.0 and for all the esteemed individuals here at the conference. It's great to make the connections, and please continue to keep up all the amazing work.
Keeping in the theme of outstanding leadership, our next award goes to Kevin Carey. Kevin. Going once, going twice, I'm keeping it. Our next award for outstanding leadership goes to Kristalina Thus. Krista.
words. I just want to say thank you to Health 2.0 for this opportunity, privilege, and recognition. Also thanking my peers, my clients, my mentors for their continued support. And just to acknowledge, for everyone within this industry, whether you're a physician or whether you work in environmental services, we've had a rough few years. And just to remember to take care, fill your own cups as well, so that you can continue to fill those that we care for in our communities. So thank you.
Our next award for outstanding leadership goes to Marianne Sita. Marianne.
I just want to thank Health 2.0 for this opportunity. I really appreciate it, and it's been very fun and also exciting to know this group of people, this diversity, and I encourage you to keep going and keep doing this because it's really, really important. It's really necessary. And also want to thank my husband for being here. He's my support. Without him, we can't even start doing this. So, and my son and my mom, they are my inspiration. So thank you.
Our next award for outstanding leadership goes to Michael Wolf. Michael. Moving on to our next. The award for outstanding leadership goes to Mike Procello. Mike. I like that you raised your hand because for a second there you were just kind of a dot in front of the light. So thank you.
Not a lot to say, but thank you very much for the award. This has been a great conference. I've learned a lot. I've met a lot of really interesting people. I'm pleased to be part of this group. You guys are amazing, so give yourselves a hand. But also, to be on stage with superhero music is awesome. So I'm coming back. I'm coming next time. Thanks.
Our next award for outstanding leadership goes to Prabha Dina Rajupita. Please come on up. Our next award for outstanding leadership goes to Rebecca Johnson Osei. Rebecca.
Say thank you so much for this recognition. It means a lot. I am really proud of concierge psychology and all we've built. I want to thank my team because nobody leads by themselves and we're all supported. And speaking of support, I appreciate that of everyone here and of my family who've supported very long hours and mommy missing in action at times. So thank you to everyone involved.
Our next award for outstanding organization. Here to accept it, Roslyn Haldane for Tender Loving Home Care. Roslyn, please come on up. All right, we're putting it in the mail. FedEx for her. Our next award for outstanding organization goes to Ruth Rapaza, PharmaScript. Ruth. Our next award, moving right along back to outstanding leadership. This goes to Sapna Ravula. Sapna. Are you Sapna? The one before? Okay, come on up.
So Dr. Sapna couldn't be here today. We work together at Altus ACE in Houston, and I know that she was and probably watching it online, but she was sorry that she missed it and wanted to certainly attend the conference. And I also want to thank Health 2.0 and all the people in the background that have put this together. You guys have been wonderful in accommodating everyone. And Amit, also from the people in India as well that have helped everybody, and the audience as well. So thank you guys very much. Thank you.
Our next award for outstanding leadership goes to Michelle Shah. Michelle.
First, I want to just say thank you to Health 2.0. This was a great experience. It's my first time coming, and I plan to come back for more. So thank you for all of your experience, all the feedback that you guys gave. Thank you for your participation. Also, just want to say thank you to my mom, my family, my friends, my partners, my partner in Leb as well, and my friends and my family, of course, just for your support in building compassionate solutions. We are a healthcare staffing company, and our focus is securing the best healthcare staff for those hard to fill positions, because healers need help too. So thank you.
Our next award for outstanding leadership goes to Sasi Naga. Sasi, please come on up.
Hey, this is Sasi Naga from Club 6. At this time, I would like to thank all the great doctors, nurses, and nurse practitioners that worked and working for Club 6 across USA. Mainly during the COVID pandemic time, we had 3,000 healthcare staff at work. So they did great service. At this time, I would like to thank and dedicate to them. Thank you.
All right, getting down to our last handful of awards here. Our next award for outstanding leadership goes to Sharonda Jamerson. One of our cheerleaders from the second row. Guys, let's give her another round of applause. She's been cheering for everybody so much. It's been so nice.
First, I want to give honor to God for every door He's opened that led me here, and everybody who's behind those doors who got me here. H2.0 and all the relationships that I created here. The hospital in which I worked for, they hired me as a mental health and addiction therapist, but I seen some crack in their system, so I decided to step into that crack and fill that crack to help them with their biases and their discrimination. And they're grateful I didn't get fired. I'm still here. And this has been a great year. I started off with an award, the Martin Luther King Community Award, and I'm ending with a leadership award. So this is a great year for me, y'all. Thank you.
Our next award for outstanding leadership goes to Susan Wood. Susan. Our next award for outstanding leadership. Hey, we just saw her. Tammy Chang, MD. Tammy. And what a great job you did as moderator, by the way.
Thank you all so much. It's such an honor to be here with you all. Take care.
Thank you. Our next award for outstanding leadership goes to Tanweer Hassan, MBBS MPH.
Thank you so much, Health 2.0 conference, for providing us this opportunity. And one thing came to my mind that all the beautiful minds I met here, it's a great opportunity. And for us, what I believe that when you work, you are partly fulfilling the Earth's furthest dream, right? Assigned to you when the dream was born. And today, together, all of us, we can make a difference. And definitely, it's like everybody, like one step at a time, but we will reach the Earth's furthest dream. I want to thank all the team members of ICON in different parts of the world, working day and night and believing in me and believing in the vision of bringing healthcare at your fingertips. And I hope whoever watching, thank you for your hard work. And at the last but not the least, I want to thank my family and definitely my beautiful wife there, who believes in me and tolerating me with all this craziness and sleepless nights. And thank you for being there for me. And thank you all.
Wonderful. Thank you. Our next award for outstanding organization goes to Vinicio Vargas from Innova Tech. Oh, and I was so proud of myself for not butchering that. Shucks. He's not here. Okay. Our last but definitely not least award goes to, for outstanding leadership, Young June. Young June, please come on up. All right. Well, it looks like that is going to wrap up our first award session. Another round of applause for each and every one of you for your time, energy, participation. Thank you. Thank you. Please go enjoy some lunch, and we will meet back here at 1:30. Bon appetit. And thank you, Peggy.
Check, 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 1, 2. Check, 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 1, 2. Sounds pretty good, yeah? Check, check, check. Check, check, check. Nothing?
Hello. There we go. Good afternoon, everybody. Thank you for coming back after lunch. We are going to go ahead and get started. We are going to continue to have more people kind of floating back in, especially as we get closer to the afternoon. So definitely take your seats. Thank you for being here. And we're going to keep this momentum going in all of these great conversations. Now, let's just jump right back in where we left off. Experts in our upcoming fireside chat are going to talk about how age doesn't have to be a limiting factor when it comes to staying healthy and active. Age ain't nothing but a number, right? There are lots of ways that you can tweak your routine depending on what works best for you, whether it's adding more weights or decreasing the number of repetitions. All that matters is that you're having fun while getting the results you want and, of course, staying consistent. The chat is going to be about age is just a number, adapting your fitness routine for a healthier life. And to welcome on stage for this fireside chat, please welcome Marlise White, founder of Soma Life, and Eric Durack, president and founder of Medical Health and Fitness. Please give them a nice round of applause.
Good afternoon, all of our senior brethren here. So you're going to talk about nutrition, and you're going to talk about nutrition through sort of the lifespan, and you're going to talk about where nutrition and supplements are. And I want to stay with really what my professional life and passion has been. I started exercising when I was 11. I started lifting weights when I was 11. I'm 61 right now, so that's a half a century for you people. Isn't that amazing? I was in the gym this morning, and I have not lost my love of weight training. And I always felt there was something very special about lifting weights because when I was younger, my father not only had Prevention magazine, but he had Muscle Builder Power, which was all the Arnold Schwarzenegger and all that stuff. So I sort of grew up watching these guys bodybuild in Southern California in the 60s, late 60s, early 70s. And I just got this affinity for weight training. And then when I got into high school athletics, I felt that the strength training was important just to be strong. So I continue to do that. I have long since stopped running and track and field and all that stuff, but I just still love lifting the weights. And now I think it's so important to keep some sort of a routine together. And so you started a nutrition company. And you did it, why?
Well, for a number of reasons. Initially, first of all, let's just cover age is just a number. That's what this fireside chat is all about. When I turned 50, I said to my husband, he was a medical doctor, I said to him, could you keep me younger longer? Because I was feeling kind of age creeping up on me. Mm-hmm. And at the same time, we had a relative that was very ill. He had cancer, so he came over from England to Canada, which I'm a Canadian, and he came to see us there so that my husband could get him into clinical trials. And the whole idea of starting the company was to prolong life, to help people have a healthier life longer. And so that's how the company was born. He did a lot of research and created our products. And our flagship product actually was an amino acid stack that triggers your pituitary to release your own growth hormone.
Interesting.
Because your pituitary is always creating the growth hormone, which does the cell repair, gives your immunity system a boost. And with this, he had found with his research that at age 20, you're maxed out with your growth hormone. And from there, it's a decline, so that by age 60, you've probably got about a third of what you had when you were 20. In your case, it probably isn't true because you're exercising.
Right, but you have to strength train. This research was done 30 years ago. You have to strength train at a high level, like 70–80% of your maximum lift. And what I find as I get older, it's a lot harder on the joints to leg press heavy weights, to chest press heavy weights. I don't even do overhead presses anymore because of my shoulders. So I have to weigh getting a good workout in. And like I say, I may not have as much growth hormone that I stimulate because I don't lift the heavy weights as often because it's you know, I'm older. So that's part of the thing is, yeah, age is a number. I still get my workouts in, but as I'm older, I have to find out that internally, I have the days that I have to back off, the days that I can do a little bit harder. It's more of a balancing. When I was a kid, I'd go 100% all the time. I guess that's why you get older. You have to get. That's where wisdom comes in.
Well, when I was 50, I figured that I needed to keep active, and I had worked in the bank for 25 years, retired from banking, and at that point, I thought, what should I do now? So I joined a dragon boat team. And with the dragon boat team, there's 20 paddlers, a steerer, and the coach on the front who directs the travel of the boat while you're racing. And so I found that was a really good way for me to keep my upper body strength going, because as a steerer, you've got to maneuver this big boat. It weighs about 4,500 pounds, fully loaded with
I'm familiar with dragon boat. Yeah.
And so, you know, to turn it and do your maneuvers, you need upper body strength.
Did you take a specific supplement? With your trial and error with the company, did you think that there's a specific supplement that you took or needed to take in order to prolong endurance or to help with recovery?
Well, actually, the flagship product, which we called Youth Formula, is what did it for me. And I just combined that with our own vitamin and antioxidant combination. And the way Philip had formulated everything, he did it so that it worked synergistically, that like if you took all 3 products or 4 products with the omegas, it just did the job really well. And so the product was actually so good that we went and talked to NSF, and he got it approved through WADA and NSF that same product is safe for pro athletes to take. So a lot of them.
And WADA is the World Anti-Doping League, right?
Yeah.
Okay, association. Yeah.
Because the athletes have to be so careful about what they take for supplementation. And anyway, so we found that we introduced this to the world of the Major League Baseball teams, and their pitchers actually are the ones that mostly use the product because they have to have recovery for their pitching arm, and it really makes a difference for them that way.
Right, but then it translates to the aging factor, because as people take it, they have more energy, they, you know, et cetera, right?
Yes, and recovery, stamina recovery, everything.
So in general, and you notice that I'm asking questions because I told the production guys that I have a TV show back home, so I'm familiar with asking the questions. But I love the nutrition aspect. You know, when we spoke before the program, I said that, you know, I'm looking into a brain health formula, and the new company that is going to become a sponsor of myself. And there are some really interesting things on the market, but one of the things we spoke about was differentiating good quality nutrition supplements versus the Krogers and the Trader Joe's and the stuff that has lots of fillers and lots of synthetic type vitamins, which may or may not actually interact in the body the way that a natural supplement would.
Yes, I think supplementation is very important, and knowing what's in it is really important. Like with our products, they're all natural, there's no fillers, and we even have got the same product for pets to take. And I always like to say that the product for the pets was tested on humans. So,
as it should be.
yeah. So yeah, with proper supplementation, you just don't know what you're getting in these cheaper stores, or you're paying less for your vitamins, get 3 for the price of 1, that type of thing.
Right.
And I think it's worthwhile to do the research and get
well,
supplements.
I think doctors historically have not been fans of supplements, and that's fine. They have their opinion, but coming from my area of education and research, which is in exercise physiology, supplements were part of just everybody's routine. If you're an athlete, whatever, you just took supplements. But the learning process was, like I say, what are the best ones? And now, as I'm getting older, the brain health formula is something that I can really sort of stand behind, because I can see how it's actually, it's one of the first vitamins that I've ever taken where I can actually see the impact on what they call executive function, cognition, memory, all this other kind of stuff. And I thought, well, this is very interesting. I can actually have some level of proof as to how over time this thing is actually affecting the way that I do things. So it's important. And I want to drill down to a couple other things, but I want to switch back to the exercise. I was trained in the era of Jane Fonda and Tony Little and the aerobics craze, and Frank Shorter running my father ran marathons. He had no business running marathons. He was short and stocky. But everyone wanted to be an aerobic athlete. And along with that was the high carb diets and all this kind of stuff. But I stayed true to my roots with strength training, because I just like to lift weights. I like to be strong. And now that I'm in my 60s, I say to myself, man, I'm really glad that I did this, because more than half of my friends who are long distance runners in their 20s have hip and knee replacements in their 60s now. And they like it, but they ran 80 miles a week in high school and never thought there'd be any repercussions, but there were. So, when they got to be 50, they were bone on bone. So that's one of the things that I like about strength training. And what we'd like to do is, we've got our countdown clock here. I don't know if you guys know this, but we got 19 and a half minutes. When we get to about 10 minutes, 8 minutes or so, we want to have a Q&A, almost like a little forum that people can sort of ask, because there's only about, 15, 20 people in the audience. And if anyone has a specific question, we should just handle it, because that's sort of what the fireside chat is here. We got our hot cocoa, we've got, it's, anyway. But I've always, and what's happening in the health and fitness industry is that the strength training companies have much more of a presence than they did 25 years ago. It was stationary bicycles, it was spinning, it was, step classes, it was everything had to do with all these aerobic programs. And now strength training is king. As a matter of fact, there's a company in the US out of Dallas, Texas called OsteoStrong, which is a strength training program for seniors, but it concentrates on bone health as opposed to muscle strength. You go in and you do isometric pushes. And it's a very interesting concept, and they are growing like wildfire. They probably have 75 to 100 locations already in the US after just 8 years. But senior citizens can go in there and they can train just a couple days a week and get this bone health benefit that they never knew that they could have. So there's a shifting of the industry from the body beautiful, from the young and the fit, to the almost middle age and seniors who go into health clubs, do a very, very moderate routine, feel good, and then go the rest of their day.
Well, I think that's all you need to do, is you need to keep moving. And I was just going to mention, you're 61, you're just a baby.
Yes, Mom.
I'm 74, I'll be 75 in May.
You look great, by the way.
Thanks. But the whole point of age is just a number, is just keep moving. And I noticed that now maybe weightlifting was a big thing, and it still is, but now I notice that a lot of advertising on my phone and on YouTube and whatever, it's gentler exercise for people just to keep their muscles moving. And I like the idea of the bone strength.
Yeah.
And a big focus is get your 10,000 steps in every day. And I just got an Apple Watch, and I've probably got close to 10,000 steps in already, just
Yeah,
wondering.
because just getting from your room to the conference center is a mile and a half. It's
I know,
crazy.
it was like 10 minutes of solid walking
Yeah,
to
yeah,
get
it was
here.
it was big. So I wanted to ask a question of the audience, just a show of hands. How many people play pickleball? We got sort of one, just one? Okay. It's a thing now, folks. It's a thing. I was in Mesa, Arizona for a conference in August, and I had the opportunity to go to this really, really large recreation facility, and pickleball is the fastest growing sport in America. And who plays pickleball? Seniors, mostly. Some, they have youth leagues and stuff. A lot of high school kids are sort of getting into pickleball because it's easier than tennis. But for the seniors, on television on ESPN, last week they had the senior pickleball championship somewhere. I don't know where it was at, but I'm like, oh my God, this is a thing. So I love the fact that as one thing, I mean, how many people do their Jane Fonda stuff? But as one thing sort of goes down, like spinning classes, another thing will go up, like pickleball. And I think pickleball will double in size in the next 3 to 5 years.
Well, you know, the thing with pickleball, I just actually moved to Mexico. I got tired of Canada.
That's all right.
No politics here. But anyway, I moved to Mexico, and they've got a Facebook group there called Loco La Paz. And it's expats. And you see them advertising every day, looking for pickleball places to play that game. I have never even seen that played. I was too busy dragon boating.
Yeah, but I'm telling you and what everyone, from what I hear from the people who worked in this facility in Mesa, it's fun. Yeah. It's really fun. And I think the biggest thing about exercising over your lifetime is I've always enjoyed the weight room, the health clubs, I love it. I ride a bike, I ride my bike up mountains, I do all kinds of things living in California. But my roots are in the weight training, and I'll just do it until I die. And the thing is but like with pickleball, I'll probably do it someday because it looks like it's fun.
When you get old, eh?
When I get old. When I lose my hearing, already losing my hair, but anyway. But that's, that's kind of where, like I say, this age is a number. And pickleball is one of those things that I see, it's a national, probably an international trend, where people in their 70s who really didn't do anything for a few years, see something that they can sort of, I played tennis in high school in 1962. Now you can play pickleball, and you don't have to like run for the ball, whatever. It's very interesting. So I like these kinds of trends, and now as we're moving into this next phase post-COVID, I see that people are going to be wanting to do other types of exercise programs as well. And and this is the only science thing that I'm going to quote. Back in 1989, Stanford University did a report called Health Promotion and the Compression of Morbidity. And what they said was back in the 80s, people were living a little bit longer, but they were still spending a lot of time in the hospital. And he said, if you want to really impact a person's health, if they're going to live longer, you have to compress the morbidity time. So they're not sick for a long period of time. And that's where health comes in, nutrition and exercise. You folks may disagree or have a comment on something, but I think that if you get the nutrition, supplement, and exercise programs right, you got 80% of the battle.
Yes, I totally agree. And when my husband was doing all this research and everything, he said the idea was to live as old as possible and die young as old as possible.
Yeah, and that's what that compression of morbidity is. Enjoy yourself, and then just don't wake up one day. And who I was just talking about, oh, the gentleman from Prevention Magazine. We were talking about, my father used to read Prevention Magazine, and he gave me 25 years worth. In college, I did a lot of reading about some of the old studies on diabetes and nutrition and health and all this other kind of stuff. And I met a woman in Santa Barbara, and I said to her one day, I was a little cocky, I said, well, you know, my father gave me 25 years of prevention. And she goes, well, my husband has 57 years of Prevention Magazine. I said, who's your husband? She goes, Marshall Ackerman. He founded the magazine with Bob Rodale. And I said, I got to meet this guy. And it was great to meet him. And he just passed away about 4 or 5 years ago. He was 106 years old. What a life he had. He was one of these founders of the health movement. I loved Prevention Magazine when I was a kid because they really talked about the science of health and longevity and stuff. They quoted good studies. They didn't have a political agenda. They laid it out there. It was really during its day, the heyday. And even Marshall said to me, he goes, and now it's just a women's magazine and whatever. But they had their time, and I think that this is maybe the next time. And so, what other formulas do you have?
We've got brain health product.
Okay.
And it has cognizant in it, which my husband used to say that it's geared for older people. It helps though with ADHD.
Mm-hmm.
It keeps kids calm. And also if you're a student in school, it will help you with clarity, focus, attention, that kind of thing. And I found when I was taking the IQ 150, which is probably a low number for a lot of people, but the IQ, it really, if you take it in the afternoon when you're sort of slowing down mentally, if you take a couple of caps or pills in the afternoon, it just sharpens you right up.
Mm-hmm.
It's really good. It really functions well.
And that leads me to another question. Timing of vitamins. I take most of mine in the morning, but I know that there are certain formulas that, like you just said, work better in the afternoon. Is there any nighttime formulas that you're either recommend or familiar with?
Yeah, like the youth formula, the one for the pituitary. We originally said that women should take it in the morning because women release their own growth hormone different times throughout the day. And men should take it at night before they go to bed, both taking it on an empty stomach, because then it takes about 20 minutes for it to kick in and just do what it does.
Mm-hmm.
But for the men at night, 90 minutes after you fall asleep, you're releasing your own growth hormone, and so that really amps it up.
Right.
So we figured that would be good for men. But we found that now you can really basically take it anytime as long as you take it on an empty stomach. Mm-hmm. And give yourself 20 minutes to half an hour before you start eating anything. So most of the supplement, like I take everything in the morning, get it over with.
I want to do another thing with the audience here. There's another big thing. I mean, pickleball's a big thing, but does anybody in the audience ever done vitamin IVs? Vitamin intravenous? Nobody? Okay, it's a thing now. Yeah. Vitamin IVs are a big thing. And as a matter of fact, there's a company in Arizona that's called the Doctor Shot. And instead of going to the doctors and getting an IV for your vitamins, like liquid vitamins or what they say that you can actually go to your doctor, they can recommend vitamins, you can order online with the doctorshot.com or something, and you can get your own vial and syringe with the vitamins and you give yourself a shot. I mean, we're moving into a whole new era here. I think it's interesting that people are going to be, they're not diagnosing themselves, but the therapeutics is something that, first it was the home glucose monitors. You could get your blood sugar during the day. And now we've got lactate meters and cholesterol things that you can order all the stuff on Amazon. And now you can do the doctor shot where you get, I don't know about giving, but it's a microneedle. But you can give yourself your own intravenous or intermuscular, I guess, vitamin injections. And I just think it's like this whole new world. And I don't know if it's going to change. I do think that people, and I want to get the audience, we're going to come right after your next thing. I've always felt that supplementation was a very important part of total nutrition. Most doctors will say, just eat right. And I say to them, what does that mean? So if you know what your deficiencies are by having a good blood panel, that's where you need to have that medical thing. They need to steer you in the right direction, that you can get the right type of formula for what you need. And the whole thing about aging is what I took when I was in my 30s. is not anything like I take now. I take N-acetylcysteine, I take my own brain health formula, I take my omegas, I take all these types of things. I do my biohack in the morning with my coffee and whatever. And I think I found a good slot. I can always be better, but I think that I'm good. So do you have any last thing before we open up? Because I know that we've got a couple folks that want to ask some questions.
Not really.
Okay, well then let's do, we got 7 minutes to go. We'll do a few questions and then we're going to do push-ups. Everyone's doing, no, I'm just kidding. 50.
Hi. How do you help people overcome the fear of getting hurt when they do exercise? So for example, you know, some of your friends, maybe they have had a hip replacement surgery, maybe they've had some, you know, knee repair surgery. From, let's say, the time they just came out of the hospital, how do you recommend they go about starting an exercise program and not hurting themselves
Right.
in the process?
It's a two-part answer for me. Number one is find a good trainer. And they say, well, you know, are there trainers who are versed in this area? Yes. There are senior fitness trainers who understand the application of exercise for people over 50 and medical conditions. And then there's also people who work in medical fitness in hospitals and clinics who do this every day. So that's number one. And number two is to sort of think out of the box, because a lot of people, I've seen this for 50 years, people still don't lift weights correctly. But we have now rubber tubing. We have now isometric exercises like OsteoStrong. You don't really get hurt because you're only pressing as much as you can. They're isometric machines. So that there are different ways of doing it, and the trainer would guide you. As if I were your trainer, I would say that, well, let's start you out with rubber tubing so you understand the movement and you get the movement correctly, and we can, you know, work around pain or through, you know, hopefully no pain, and then figure out the right choice of exercises as well too, because people have a tendency just to do things that they see someone else do. So find a good trainer and think out of the box.
Hi. Interestingly, that was really close to the question that I was going to ask. I have two, actually. The first one being, how do you excite people to, especially the aged, right, for whom exercise and maybe even strength training might not even be on their radar, you know, or, you know, like she said, maybe they have doubts. So like, how do you generate that excitement about strength training in this subject? And then the second question is, do you have thoughts or philosophies on, the aged population, right, and progressive incrementation of weights, or just holding a stable weight capacity?
I'm going to answer the first question first. Results. A person who's 75, if they can go to a program, not just a gym, but they can be involved with a program like OsteoStrong, whereby you can actually see results in literally a matter of weeks, because you're exciting the muscles, you're working on posture, and your movement seems to be a little better because you're doing something. And also, you know, so that's the thing. And like I say, weight training is one of those things, if you start at zero, and I worked with cancer patients, and a lot of these folks started at zero, they had no strength. And in 10 weeks, they were doing an entire routine. So their improvement was 1,000%. Because they started at nothing. So the results are really going to excite people. And that's where I think, as we're moving into this mindset where more people would like to become active or choose nutrition or something, then, you know, and we'll talk a little bit more about it, because I want to get a couple of questions and still make sure we get our time. Are you going to talk about HMOs?
No. I'm going to ask you to opine on several different factors.
Okay, we got 3 minutes to go.
Okay, first one is a supplement is a medication. It's a drug. I mean, digoxin, which we use all the time, is for the digitalis. So the idea of deriving things from plants or those sources is not foreign to us. We've been doing it for hundreds of years. But one of the emerging problems that I'd like to hear how you would overcome is that for those of us who are on medications, We're adding another medication when we add a supplement and increasing the chance of interactions. How do we get around that? The second question that I have has to do with the purity issue. Supplements are not adequately regulated by the FDA. So the problem that you talked about with, and we've had problems with cyanide in supplements and things. How do we get around that in order to have confidence that our supplements are as good as the ones you're talking
You want
about?
to take that one?
And then the third one is the science. And my example is fish oil. Fish oil raises your chance of having a heart attack unless you take the right omega-3. And we didn't know that for years, and lots of competent medical authorities were recommending it until we did the studies right. How do we get the studies right so that we can have confidence that these products really work?
Do you want to answer the purity question?
Yeah, the purity question, actually, the question was, how do you know about interactions with other medications?
Just how pure the vitamins are.
Oh,
Yeah.
well, the vitamins are very pure. They're just amino acids. And
Your vitamins.
yeah.
Your vitamins. Right.
Right.
The Krogers and the Trader Joe's and a lot of those vitamins are mass produced. A lot of them are produced in China, but a lot of drugs are produced in China. So I want to get into the science of the things is that I think that the industry is doing a much better job in regulating itself now than it did even 5 years ago, because there have been so many folks like yourself that have had this outcry that, you know, just taking these generic synthetic is almost like taking nothing at all. But I'm seeing in the last few years, your company, SOS company, the Brain Health Formula companies, all of these companies that are sourcing products that are at a very high level. We just have to sort of figure them out. You know, the science of nutrition, you know, you had mentioned the fish oils. But also, the problem with nutrition is that there is a confounding variable. Is it fish oil versus exercise, fish oil of this, fish oil? You know, you'll never really know. We said at the beginning that I felt, and you'd agreed with me, that taking supplements is better than not taking them, but we just have to figure out what the best ones are. Agreed?
Yeah, absolutely. And from my end of things, Health Canada are so strict about what we can do. We've got to get numbers, and we jump through hoops to get the products out there. And for my own product, I've got a database where we've had our customers phone in or write in questions of how our products would interact with their medications and their own personal health problems. And my husband, the medical doctor, he would respond to each one. And so I've created a database with all of the questions and all of his answers, so I'm able to now that my husband is no longer here, I can answer them for him.
Electronic vitamin records. That's $1 million idea right there. Last question.
Yeah, I have a question and a complaint. The question is it enough to buy organic versus non-organic vitamins? And the complaint is...
I'm a huge proponent of organic foods because I live in Southern California and almost all of my fruits and vegetables are organic. And we hear about the phthalates and all this kind of stuff that are in foods. And I mean, it's almost like the poisoning of everything. It is important, I think, that vitamins are organic. And I don't think, like I say, you look at Trader Joe's, Kroger's, giant food stores that just get these mass-produced vitamins, that the synergistic effect is probably not nearly as good. I'd rather spend more money on food and exercise than spend more money on medications later. By the way, I'm 61, I've never been on a medication in my life. So for me, you know, Winnie would tell me, you've got to pat yourself on the back, because there's a lifestyle that I now can say to people, I got 50 years in on this thing. So there's something that's going on. So, and we'll talk a little bit later, our time is up here. I appreciate all 300 of you for being in our afternoon conference today. Thank you.
You were awesome.
Well, you need to, I'm going to turn this off here.
Guys, for that fireside chat, a lot of perspectives, a lot of insight. Round of applause for them. And for the 5 people still in here, thank you for being in here. We appreciate each and every one of you. So we're just going to keep it on. Our next panel discussion focuses on the topic, lessons learned from the pandemic, leading in a time of crisis. Yes, I'm going to say the C word. The COVID-19 pandemic was not only a global health crisis, but also a catalyst for rethinking how we want to live going forward. So true. This opportunity included economic systems, sustainable development decisions, and a few shifts in the healthcare space, which have gone on to benefit all of humankind. The panelists next will provide a rundown of the lessons they learned while leading their organizations during such challenging times. Again, from my heart to yours, shout out to each and every one of you. I cannot imagine all of the challenges you guys have had to overcome the last couple of years. Let's hear it next for our moderator, Michelle Shaw, founder and CEO of Compassionate Solutions, LLC, who will introduce us to our panelists. Michelle? Oh, no, Michelle. Okay. Well, thank you. Well, yes. Hi there. Hi, Dennis. Guys, round of applause for Dennis, my buddy. My new buddy. Thank you, Dennis, for taking over.
Yes, I'm standing in for Michelle. She wasn't able to be with us this afternoon. And want to bring up our panelists for this session. So if you would please come onto the stage and take a seat. And I know that the introduction itself has said that everyone here has been affected by the pandemic. Those here are now in survival mode. Well, hopefully we're beyond survival mode and we're into a mode where we'll take the lessons we learned and apply them to improve our organizations, improve our lifestyle, and for the betterment of everyone here. And so I'm Dennis Dolniak, standing in again for Michelle Shaw, but I am the president of the Nana's Books Foundation and happy to be here to moderate this session. And I'm going to have each one of our esteemed panelists here introduce themselves.
Would you like me to start, Dennis?
Please, if you would.
I'm Jack Doty, CEO of Inocom Bioequities. We are an investment manager who brings money into the health world, life sciences more generally spoken. We do three things. We work as CEO advisors, we work as infrastructure developers and maintenance, and we also bring in capital. We're in the middle of raising a $250 million fund right now to invest in our now 12, probably 15 in the next month, portfolio companies. One of the points of distinction of our firm is that we spread the risk over those 15 by using a fund. Thanks, Dennis.
Very good, Jack. Thank you. Rebecca?
Hi, hello. I am Dr. Rebecca Johnson-Osei. I am the founder and CEO of Concierge Psychology, which is a concierge mental health practice with a home base in Atlanta, an office in LA, and we also provide telehealth and concierge services across 33 states and growing. We were actually one of the very first concierge mental health practices in the country, although it has really caught on. It's a bit of a trend now, I think, which makes me very happy. But our focus is really on quality of care, so we limit the number of patients we take on to make sure that we can really focus on individuals and give them a little bit more of our attention than a typical therapist is often able to give, just because of the demands that come with people who take a more managed care model.
Julio, please.
Yeah. Hi, my name is Julio Briones, and I am the CEO of the Briones Consulting Group. And we focus on strategic implementation for senior care industries, such as home care, home health, hospice, assisted living. We work with our clients to create custom solutions for strategic solutions to improve their marketing, operations, recruitment and retention, and to increase their overall business. We're currently based out of Indiana.
Thank you. Marcel?
Right, yeah, thanks, Michelle. Just kidding. Yeah, my name is Marcel. I've been 20 years in the healthcare industry. I'm in finance. I'm the chief financial officer of a rare disease company. We've got about 16 products on the market. And before that, I was working for an organ transplant company. So during the pandemic, working with organ transplant recipients. So that was during most of the COVID time, my professional experience, and yeah, excited to be here.
Great. As you can hear, we have rather diversity in terms of their background on platform here. And I actually represent a different aspect of the lessons learned through the pandemic. My wife passed away during the pandemic. She had early onset Alzheimer's disease. Before the pandemic hit, I placed her in a memory care community after suffering way too much stresses on dealing with her as a caregiver. That worked out really fine until March the 14th. That day is for me very important because from that day I was closed off from seeing her for 28 weeks. She was not able to communicate by telephone nor iPad, and so the difficulty was extreme for me. For her, it was the isolation and separation from me that brought her disease even farther down. And I actually participated in many advocacy roles, which is something I want to talk about during my little discussion here, on being able to bring the information out that isolation does kill. I was featured in the USA Today article, interviewed several times, because it was important to get back into that assisted living center, memory care community, long-term care, whatever. In my wife's case, it was memory care, but I was not allowed to. Fortunately, our governor at that point identified and created an essential caregiver title. And our community where she was in allowed me to see her a limit of 1 to 2 hours a week. Again, that isolation, I saw the deterioration in her. Then COVID hit, she was placed in another unit and unfortunately was not able to survive that. She died from early onset, not COVID. But COVID itself and the pandemic is what really hit hard. And from that, I actually created the Nana's Books Foundation that now supplies books on Alzheimer's, dementia, and other disabilities to students in Title I schools, to their classroom libraries, to their school libraries, and the communities in which they are. This year, we're targeting 5 schools in 4 different states. Over 2,600 students will receive these books. And I'm here to really energize people on the fact that we have services now that can help families understand what dementia is like, because they're the ones impacted with their grandparents, their aunts, their uncles, not understanding as kids what this disease is doing. So I'm very, very proud to be able to honor my wife, who was a career lifelong librarian. And that is just something that is very, very dear to my heart, because after she died, it gave me purpose. And those of you who've experienced deep grief understand the nature of what a purpose can do for you. One of my soul lessons learned from the pandemic: have a keen purpose like this that focuses my energies and talents to be able to make the world better, make our communities better. And so I'm very, very proud of doing that. The other piece I learned was the fact that I actually attended a national caregivers conference where I became an advocate. That advocacy role is something that I do every single day. And one of the pieces I want to share with you today is an advocacy role you could help me with and help your community with. And that is being able to reach out to your congressperson. There is now legislation called HR 3733. It is the Essential Caregiver Act. The Essential Caregiver Act is an act that will actually allow the person in a facility to designate up to 2 essential caregivers that would be given access of up to 12 hours a day. 12 hours a day would be guaranteed unless they are in a terminal mode, which then they get 24-hour access. And that would happen during a public health emergency. Right now, all of those long-term care facilities, rehab facilities, memory care, assisted living can have their own rules and regulations. We need to remove that isolation that affects hundreds of thousands of people who are in these units and allow them to have access to family members who can give them compassionate care, who can be there to assist them on a daily basis. And so I urge you to reach out to your congressperson. That act was submitted back in 2021. It is a bipartisan act with actually more Republican co-sponsors than Democratic co-sponsors. But I have a list here if anybody's interested. I can see whether or not your congressperson has signed on. But those in the audience, please reach out to your congressperson. HR 3733, one of the pieces that I want to advocate very strongly for. Those are my lessons. I probably will share more. But Jack, what have you done with your company during the pandemic, and what has happened since?
Well, thank you, Dennis, and thank you for the advocacy you took on the House bill. My company was founded just as COVID occurred. That actually was not a crisis then, it was the opposite. Up until that time, I had recommended, I worked as an advisor to the California Life Science Association. One of the recommendations I made as there was a dispersal of the senior management was that they no longer use the telephone, but rather they would use Teams or Zoom or other alternatives. That was beginning to happen in life science, at least in Northern California. Because of that, we had access to Zoom and were able then to build the organization around the communications possible with video as well as voice. Three things are kind of our mantra: is empowerment, alignment, and then responsibility. You cannot give empowerment, you cannot give alignment, you can't expect people to be responsible if you're not communicating. So communications became the challenge during the COVID epidemic. We were able to do that through the Zoom techniques. We were gross amateurs, like everybody else, embarrassed to see our faces on the screen, embarrassed to hear our voices in that context. And gradually over these years, we've learned to live with the video alignment. That has enabled us to build our company around that. Interestingly, I have never shaken the hands of my partners. It's all been done by COVID. I'm sorry, all been done by Zoom. Because of COVID, it was possible then to expand, to have partners in Australia, partners in Virginia, as well as here in California. So that's the lesson that we learned, and we were able to maximize that. I'll go one more if I might, Dennis, and that is to say the opposite of those, something I'm very concerned about right now. That is, we don't have the personal contact. All we have is a picture of our coworkers as just a vision on the screen. The old days of getting together, I think it was recommended by one of the panelists, of getting together and seeing cohorts. In my case, it was a regular table at Lowe's in downtown San Francisco for a glass of wine that I kept busy 3 nights a week, which was really very pleasant. That died. In fact, Lowe's died during that period and removed their brand from the hotel. They're back as Four Seasons now, I'm proud to say. And we're beginning to reestablish that. But without the contact, personal contact, and the body language that you're able to read, the depth of the personal contact, I'm afraid that maybe there's going to be a real loneliness issue developing amongst all of us out there. Getting back to the office is probably what human beings need to do. Thanks, Dennis.
Very good, Jack. I'm going to go over to the end of the stage there because I think this is a great segue for Marcel to talk about what has happened in his company.
Yeah, certainly. So maybe I'll take it from a business perspective and then also from a work environment perspective. Yeah, since I have a sort of a back office role there. So we have developed tests for organ recipients. Yeah, so a test that will basically tell an organ recipient, heart, kidney mainly, if the organ is rejected or not, or if it's in the stage of being rejected. And those patients have to be monitored very, very carefully, very closely, and very frequently. Also, people immunosuppressed and have to take a lot of medication. Yeah, if you have an organ transplant. So what we had to do was, because those people couldn't leave their houses anymore, essentially, they were not allowed to go to hospitals. They were not like they wouldn't leave their home. So we had to shift our business model, and as opposed to them going to the hospital, we actually delivered the test to them. Yeah. So we sent phlebotomists to their houses. So we basically sort of catered to their needs during COVID, and just because we could not allow interruption of this type of service, and we had to suddenly work with things that we had never worked before. You know, how do you deliver a test, a whole lab basically to somebody's home? Yeah. So it worked actually very well. It was very successful. The company grew, where we went from 100 people to 300-400 people worldwide during COVID. Revenue up 100 million, 200, 300 million. So everything actually was an accelerated during COVID, and that posed a challenge for myself and my team. I've had about 30 people worldwide, finance department, and we became an accelerated filer from an SEC perspective, public disclosures. So everything had to be done faster during COVID, better quality, and then produce a 200-page report to basically tell our financials. Yeah, so that was a challenge already pre-COVID, and we had to adapt ourselves. We had to work, pull this through, and I would never ever have believed that it's possible to do all that in a remote setting. I made a conscious choice to go to the office every day. We were considered essential workers, and so we had to. Some of them had to, but we did not have anybody sort of forced to come to the office. We said just stay home if you want. So people appreciate the flexibility. But I made the choice to be there, just to be there if somebody needs me. But I think that was also a good decision, because people felt like whatever is working for them, they can work with it around. So there was a couple of years quite challenging, but we pulled it through, and you do things you never thought it were possible. Yeah.
So has any of the employees come back to the office, and what issues did you face there?
Yeah, and this is a little bit of a lesson learned, I think for me, and maybe also for the company. And we've a little bit too early asked, so to speak, to come back, the people to come back. And in California, we had these waves, so we had to pull back again, say don't come to the office, then we had go to the office, come to the office. So the long-term model is now still a bit in under sort of under review, and people have come back, yeah, part-time, so to speak, yeah, can still work from home maybe 2 days a week or so. So we've got a bit of a hybrid thing that will continue beyond the pandemic, I'm pretty sure. And the model works. People appreciate the flexibility, and I personally now work from home too, much more, and I save a lot of time with commutes, spending more time with family and all these things. So there's a positive that came out of that, I think, overall.
Thank you. Rebecca, why don't you share your story, because you actually had teleprocessing or teleservices before COVID.
Yeah, and I actually want to touch on a couple of things you guys said. So we were lucky, I guess you could say, because as a concierge practice, it's important we be available when and where clients need us, which means you have a last minute executive meeting, you can't make it in, but you don't want to cancel. I need to be able to do video or phone. But it was, a tiny percentage of the time. It was maybe once a week or so, we'd shift, and it was always intended to be in person. But thankfully we had that, and then we've been paperless for 7 years or something. So we already had all of those processes online already. You could sign your consent forms. So for us, it wasn't hard to shift from an administrative perspective, which I know a lot of mental health companies actually struggled significantly to make that change. But clients were still hesitant, especially in the beginning. People wanted to say, well, we'll just wait until the pandemic's over in a month or two, because we all thought this was only going to last 2 or 3 months. And so there was sort of a convincing people. I imagine this is most of the healthcare industry, saying to people, no, it's still effective. I can still help, I promise. And people have become much more comfortable with telehealth over the last 2 or so years. And more people actually reach out now asking for that, for the flexibility piece. You know, it's hard for me to get away because, you know, commuting is a thing. For most people, it could be an hour total, 30 minutes or more each way to get to the therapist's office, or if you have kids but you have a quiet place. At the same time, with the proliferation of telehealth, you have people who maybe aren't getting out of their stressful environment. So, you know, I've had people where they really need to talk about their spouse, but they both work from home. So, you know, they're like I literally have had somebody sit in the closet and talk to me, and that sounds super unhealthy, and it's not as bad as it sounds, but just to feel like they had privacy, or away from their kids, you know, same thing. Just getting away, you know, you talked about the cost of sort of always being on with people and being able to literally get away from the rest of your life and the chaos and be in a place that's grounded and calming, which of course we aim for in a therapy office, in of itself can be really healthy. So I think it's pros and cons. We've seen more access for people. You were talking about legislation. There's legislation on the books in a number of states at the moment for something called PSYPACT. Nevada, I think, is amongst that group. But 33 states have signed on. And so if you're in any of those, a therapist in that state can essentially get an additional credential, allowing them to do telehealth in any of the other 33 states. So this also helps with people in business, for example, who travel for work. 'Cause technically, if you live in Nevada and you go to like Ohio for work, you can't talk to your therapist because they're not licensed in Ohio, most likely. But if both states are part of PSYPACT, now you can. It's not so rigid. And there's, you know, ways we handle crises, but as a general rule, you wouldn't have that support. So there's been a lot of growth, a lot of people have added to it. The one other component, and it was interesting to hear both of you give your perspectives, you mentioned isolation. And I think as there's that for therapists in addition, and for the patients who are not necessarily getting the same kind of interpersonal connection. I think therapy can be very effective, but it can feel different to not sit there with somebody. But we also see a little bit more burnout for the therapists. So they've done some studies, and really empathic people, we read body language. I think you had mentioned not being able to see body language. And you take all of that in, and most therapists are very empathic. With a little screen, I can't see if you're doing this, tapping your foot, shifting uncomfortably. Am I triggering you? You know, I have to just read your face. And that's hard, and it's exhausting. We don't realize we're doing it, but we're very focused. And so yes, therapy is very effective for the patient, but for the therapist, it's like twice the amount of work. So you're seeing mental health people actually, I think, burning out a little bit more. And again, same thing. Sure, we can work from home. That's convenient. That's great. But then what are we doing? Just like everybody else, then we're going downstairs and helping the kids or what have you, and also not getting that, because again, going into the office, like you mentioned, going into the office itself can actually be sort of if you have a healthy office environment, it can be an escape itself, right? So it's very interesting. You kind of get both sides of it on our end.
Great. Thank you for sharing. Julio, your situation is a lot different from discussing this with you. Would you please share?
Well, in the senior care space, especially when we're talking about field workers, you know, home care, home health, hospice, you know, even some of the more independent, like wound care clinics that have to send people out to go visit people at the home. One of the biggest challenges in that industry has been the need to have people work from home because they're not considered essential field employees. So you have an entire workforce going out to visit these people that desperately need their help. I mean, you know, these caregivers, these nurses, they're amazing. You know, they serve a very vital function, but now they lose connection with their internal office because now you have nobody there to come to. When you need to find PPP, when you have to just vent about your client, when you have all of these other normal issues operationally, there's no one to come back to, nobody to discuss these issues, and it's creating a big problem in the labor force within these industries. Everybody has heard of the caregiver shortage out in the field. There's not a caregiver shortage, okay? What's actually going on is that caregivers feel disconnected from their home office. So they're finding it more lucrative to go out and work on their own, even at a higher risk to themselves. So they're no longer covered by the workman's comp. They no longer have anyone to manage the schedule. There's nobody to protect them from an abusive client. and there's no one to protect the client from an abusive caregiver. So this is becoming just a massive problem, and trying to rein this all back in is the biggest challenge that's actually going on now. There was a lot of deregulation in a lot of states. Like, I'll give a good example. In New Jersey, for example, there was 2 distinct licenses for caregivers. You had CNAs that could only work in facilities, and you had certified home health aides that could only work in the home, right? Person can go and get both, but they had their own functions. So during the pandemic, because of this artificially created caregiver shortage, they relaxed the rules, and now CNAs were able to go to work in the homes, and home health aides were able to work in the facilities and perform the same functions. And this is causing a lot of burnout because there was nobody to come back to, no structure, no order, and people were out getting the clients privately. So there's a lot of inherent dangers with that, both to the client and to the caregiver. What happens when you have no coverage? So what happens now when you also have an office team that has spent almost 3 years, that they've gotten accustomed to I call it the fallacy of underperforming, okay? The expectation when you work from home, for many, not in all industries, but in this industry in particular, it's a lot of just being on the phone. So they're used to taking the phone, they'll work from 10 to 2 instead of 9 to 5. All of a sudden, everything becomes on call, and they think they're working just as hard and being equally productive, and now they're being asked to come back into the office, and people are having meltdowns. They're not able to get back to that normal productivity level. I mean, at best, we can look at 60-70% productivity from most of your office staff, about 80 to 90% productivity from your field staff, and these numbers are dramatically dropping. And this is one of the biggest challenges that this industry, especially with the field workers, is facing.
Great, thank you for sharing. I know that we learn from making our own mistakes, or correcting our mistakes. And so one of the questions I'll have each of the panelists respond to is, what mistakes did you make and what did you learn from them after the pandemic?
None.
Thank you, Rebecca. Exactly my point. Yes.
Absolutely.
Would you like me to comment to that?
Sure.
Okay. The not understanding how difficult the communication is on video, and not being patient with it. Also getting tired and not realizing that's part of what we have to tolerate. So basically being forgiving, one of those great admonitions of the process of communicating in spite of its difficulty.
I'll piggyback on that, and I'll add even a component of that, but boundaries actually I think became a little bit harder, and actually kind of speaking what you just said, because we're all kind of feel like we're on call, I think, to a degree, and so you're more flexible, but what does that really mean? Now it somehow means you're answering the phone till 7. That's what, my schedule's more flexible. And I think that's everybody. I think that's kind of across the board. And again, back to burnout potentially. I mean, sure, it's easier for me to run to the store at 2 o'clock in the afternoon, maybe if I have a hole in my schedule, because we really couldn't do that when we were in the office in a lot of cases. But now you're working late, and how do you say no? And a lot of employers expecting that. There seemed to be this shift of, you don't have to drive from 7:30 to 8:30 anymore, so you can be on meetings at 7:30. And again, less so for me, but I hear it with clients. A lot of people I work with are executives, and they're burning out because they're actually working, I don't even know if it's more hours, but it's stranger hours. There's no boundary to box in, I'm home and I'm off versus I'm on. And so we're just all on all the time, regardless of how many hours you're actually spending in front of a camera. And I think that is very hard to just yourself. And of course, when you mentioned productivity, and this is not to say that it's the truth of your company, but in the United States, we have some toxic productivity stuff going on. And so we all tend to think, what's a good day? A productive day, right? Look at all I got done today. And so without concrete boundaries, a lot of us will actually overwork. We'll do more as opposed to less, and that's not good either. And then we probably end up netting worse, because we all know if you burn yourself out, now you're actually less productive. but I'm a therapist.
Julio,
All right,
Marcel?
Yeah. So one of the biggest mistakes I made when COVID first started, it was the way I was interacting with the CEOs and the owners of these companies, right? So we tried to take the same approach of pre-COVID and how to manage and structure the internal team and apply it to a work from home environment or from a skeleton crew environment. And what we figured out, and my team figured out when we started learning this, and thank God we were able to fail quickly at this, okay? Because we had to learn that you cannot address an office environment with the same values as you will when you're dealing with the individuals outside of the environment, right? So you have to take a more customized and a more personal approach in order to maintain that retention of your office staff. Because look, at the end of the day, especially if you're running a field team of 50, 60, 70 employees that you have to run 24 hours a day, 7 days a week, if your internal staff, your scheduling staff, your nursing staff, your administrative staff is not with you, they're not seeing that vision the way they're supposed to with you, then you're going to lose control of the entire process. We've seen throughout this process companies that pre-COVID were doing $30-40 million in billing, all right, drop down to below 8, just because their staff internally, they lost control. So they lost control. All of a sudden, they can't keep the internal operations on track, and those people lost control of the field staff. And at the end of the day, and this is something that's very personal to me, they started providing poor care to those that desperately needed it. And so learning how to teach these CEOs, these owners, how to take that top-down approach, no matter what you're doing, instill your values, understand your core values, what made your company great in the first place, and make sure that it gets translated properly to all of these individuals, all these moving parts working out of their house. It made for a better work environment for the caregivers and better outcomes for their patients.
Great. Marcel, any mistakes there?
Yeah, I mean, along those lines, from a people management perspective, other than communication, the challenge was at the beginning to maybe almost a little bit over-communicate, having one-on-ones, another one-on-one, another phone call, and then where do you draw the line between micromanaging somebody versus communicating with them or over-communicating? So to sort of adjust that and customize the communication style to everybody is very important, that you address the needs of every individual. One thing I didn't pay attention too much at the beginning, but I thought would have been better to do is, it's tough for people who are already in the company. It's even harder for somebody who gets onboarded. So the whole onboarding process, somebody we've never met, somebody you've never seen. So also to customize that, because there's a big difference. Somebody who's a bit more senior, a senior person who has decades of experience, he can onboard almost a little bit himself. It's like him or herself. It's more like to say that person doesn't need a lot of guidance. But for somebody who's junior, for a senior analyst or somebody who's just joining a company after university, for example, it's really difficult for somebody who is getting into a COVID environment, into a company. How do you onboard somebody like that? So to customize the onboarding procedure depending on the level or depending on the needs, to make him productivity, get him up to speed, her up to speed very quickly. So that is something that we should have paid attention to a little bit earlier, and not when it's too late, when somebody just leaves again after 6 months because they just didn't know how to operate in a company like that.
When it comes to management, conflict enters into it among your employees or staff. Any unusual circumstances or different procedures you would have to employ, either during the pandemic or thereafter? Jack?
Thank you. It's one of my favorite topics. Our partners are all strong-willed previous CEO advisors themselves. All of us have been CEOs. So you can imagine who wants to be in charge at any given transaction. Fortunately, in our case, the attribute of grace has been shared amongst the three of us. But that conflict is really a difficult thing to handle. And you can't walk back and say, hey, I'm sorry, Jules. Here's a cup of coffee and can I patch up? I mean, in Jules' case, he's in Australia, and I talked to him at 4 o'clock my time, which is 8 o'clock in the morning his time, and you can imagine how that amplifies. What we learned was, though, good Grace itself could then come in and with the little patients come back and apologize for each of our part of that transaction. So that was a lesson learned, but if not, it would have just completely destroyed the organization. Very important lesson, and only because we could have all the tools called Zoom and email, which I didn't mention email in my earlier comments. I guess I'll avoid that subject.
How about texting? Was that an option too?
I just deny texting. I don't respond. There's a word called stop. You just
Any other conflict resolution procedures that were employed among the other group?
Yeah, actually, one of the big challenges that I found in my industry in particular was you had office managers that worked under the CEOs that now felt lost in the space because they had nobody there to manage. Right, so a lot of times people ended up leaving because a big problem, especially when you're dealing with a lot of field work and multiple schedules, is you have to deal with a lot of in-group, out-group behavior, right? Otherwise known as cliques. You know, like remember back in high school when you had the jocks and the nerds and this and the other. That happens a lot, especially when you're managing large groups of low to medium skilled labor that has to go out and report to somebody else. Everybody has their favorite. Oh, this person will always respond. That person, they're a great worker, but I don't really like them, and people get lost in the shuffle. And one of the organizational structures that needs to happen is this manager who's taking the one rung lower from the CEO has to be able to control that with the scheduling staff internally. And without that physical presence, a lot of them fell apart. They just didn't know how to manage that, and it led to a lot of, again, loss of control and a loss of the mitigation of that in-group, out-group behavior.
Very good. We're going to be getting into question and answers from our audience out here. So if you'd queue yourselves up, we'll be able to address any of these wonderful, talented people up here with your questions, perhaps sharing a lesson you learned from the pandemic as well, because those are as diverse as the panel itself.
Hi.
Hello.
This question is for Dr. Rebecca. I was curious within your particular market, how you mentioned the demand across the board going up for more flexibility, right? So I'm wondering how available you or your staff or your offices have made your schedules to this rise in demand. Is it 9 to 5 officially, or are you being more flexible along? What has your decision been, and how has that? What have the results been?
I gotcha. Well, this is another thing where I'd say we actually didn't change that much. So the way my practice is scheduled, each of my therapists essentially manages their own calendar, and I do give them the flexibility within reason. So relatively 9 to 5. We've kind of always been more of like a 9 to 6 or 7, depending on the person. We've always been available after hours. I've occasionally taken a call at like 2 in the morning or on a Saturday, but thankfully those are very rare for existing clients with emergencies. We're not an emergency line, but pseudo crisis level. Don't need to go to the hospital, but could really use some support. But for the most part, we've stuck with a relatively 8 to 6 Monday through Friday as our standard. But modality being super flexible that way. We also, and again, we had this before anyway, but we have effectively a 25-minute cushion between appointments. So if people are running late, so if you guys have ever been late to a massage appointment, they don't make up that time, right? You have a 60-minute massage, now it's a 50-minute massage, and now you're stressed going into your massage appointment, and it's horrible. That's what I envisioned when I made my practice. So I always, you don't need to show up 25 minutes early to sit in the waiting room and wait for your doctor who's then going to be late. I say, hey, I can wait for you. You don't need to wait for me. So we encourage people to be as on time as possible, but not stress if you're a few minutes late, because we can always make up 10 minutes. And I think that allows the flexibility. We try to, even if we need to reschedule within the same day, back to my example of we have a lot of executives, meetings, emergencies come up, things you can't avoid. And You know, if I can nudge the appointment an hour and still see you, that's what I'm going to do. But a lot of that honestly was already in effect. So again, it's actually worked out nicely for us. But you know, just trying to also be really flexible. You know, we have three different backups for our video system. So if one isn't working, we're on to the next one. Because I have found that's really where a lot of the issues come up, is somebody signs on to what I use and they can't hear me. And of course they can't hear me because God forbid things worked properly, right? So just having that flexibility to find, okay, if this doesn't work, we're gonna try this. And worst case scenario, we're gonna get on the phone, but one way or another, I got you. Does that answer your question? Okay.
Very good.
How have you guys managed burnout for your employees during COVID?
Start here, Jack.
Good question, and poorly, I think, was the original answer. You didn't understand exactly what Rebecca was talking about earlier, that we could be getting calls anywhere from 5 in the morning out of New York, which is 8 for them, that was fine in San Francisco. But at the same time from Australia, you could come in at 10 o'clock that same day and call or emails, and each of those have a sense of urgency. So how we handle that was, in fact, one of those conflicts I described earlier. Jules, don't send out emails on your Sunday or your Monday night, which is my Sunday night, at 7 o'clock, because I do scan to make sure there's any emergencies. It took a lot of effort to get an appreciation for each other's need to rest and have that compassion.
I've had to sort of institutionalize breaks, actually. We have it in our contract. I don't know if that's normal at all, but because people, I think, again, there's like this pressure we have to be available all the time. And with therapists, I mean, I truly believe we only have so much space. And anybody in here who works in mental health, you know, it's whatever reason, everybody has a breakdown like the same day. Everybody can be doing great, and then you get like 6 in a row, and you're like, what? I swear there's a text chain. I don't understand. And so I actually mandate that my staff take, I call it a lunch break. I'm like, I don't care what you do with it, but you have to take this 1 hour break, because in truth, you're not going to be an effective therapist either if you're, you know, if you just met with 5 people who are all breaking down in a row. Number 6 is not going to get a great version of you. So I use it as we provide better service by doing this effectively. And I think this is true across fields. I think when you are healthier, you provide better service. You're a better worker. So it's a win-win in my mind. But I have had to tell, especially people with those overachieving personalities, and I have to be like, you have to slow down. But I used to do 12 clients a day. I don't care. You can't.
Well, I actually do something similar to what she does. I have it in all my employment agreements that they must take 2 weeks vacation every year. There's no ifs, ands, or buts about that. And also because I work more on the business side than anything clinical, and I do see clients around different parts of the different countries. So I have a simple philosophy in my business. You know, your lack of planning does not constitute an emergency for me. So, you know, if you have something that needs urgent attention in your mind, we'll look at it and we'll figure out what the solution needs to be. And then we decide if it's really an emergency or not. And any calls that do come in, my staff knows, if it comes in on a Saturday at 6 o'clock in the morning, send it to me. I'll decide if it's an emergency. If not, the client can wait. And that's really what it comes down to.
Yeah, so Mike, I have a good friend of mine. He's a psychologist, and he's treating burnout patients. Yeah, and his own workload during the last 2-3 years just exceeded his own capacity as well, and he actually ended up in a burnout clinic himself. And what he said is it's a new form of burnout also. So it's not like easy detectable. It's not like we know how to a burnout really like progresses now. The pandemic has just shown it's really hard, specifically in a remote environment. Yeah, so you have to almost be a psychologist yourself to really understand every person, how they feel about it. But yeah, it really comes back to giving buffer zones, not again emails. Email can be like a stressful thing if people just send an email less, yeah, make a phone call less, don't call over lunchtime. So just respect people's time. Essentially, at the end of the day, respect people's time. ask them to take a vacation, yeah, and obviously never deny any of this. So there's no silver bullet. I think it's more like being sensitive to everybody's own situation. Yeah.
Thank you.
Hi. First, Julio, you were singing my language back there. I was so excited. I thought I was the only post-acute care person in the room. So, so my first question is directly to you.
Okay.
How do we gain the productivity back? Because I run home health and hospice, and it has been a dramatic decline. Like, again, it's like everybody's, I mean, what a team of 4 were able to accomplish 3 years ago, now it takes, 6 people or 7 people. And the numbers aren't increasing. It's not the visits. It's just, again, it's that productivity that just got so bad, with all of us just trying to figure it out. I mean, at one point in time, we threw out our emergency preparedness plan and just replaced it with a Stephen King novel, because we're like, well, the rules are changing every day. What's the point? And then for the entire panel, my second question is, do you think the pandemic was enough to start actually openly having conversations, program development, to start addressing global burnout? Was it enough, or are we going to need more before this little dirty healthcare secret, gets addressed? Because we're seeing global burnout, and for the people in the room that don't know what global burnout is, that's when our practitioners, our clinicians, they throw up their hands and they're like, screw it, I'm gonna go work at McDonald's. And they do, they don't just leave for a little bit, they leave forever. So those are my 2 questions.
All right. So let me ask you.
I'll pass it to you in a second.
Okay.
If I just might. Well, that question was about health workers. My world is not in the health work. And so I don't have that issue. In fact, it's the opposite. We have geniuses who have cures for cancer and for long-term COVID and for all these other stem cell problems and so forth. And they are dedicated to do it in spite of, and they're not responsive. They are in fact proactive. And I think that might be the solution here. Thank you, Julio, for letting me say that.
I actually have a clarifying question for you so I can answer you properly. When you're talking about returning to productivity, you mean office staff or field staff?
It's really cool, because it has been a combo, right? Because, you let people out in the wilderness unsupervised for long enough.
Right.
They become feral, they make their choices.
Yes. So
feral is what they are.
In the interest of time, I'm going to address this as quickly. The second part is actually very easy. The field staff, you answered your own question. Set up a position in your company for a field supervisor and implement something that we can talk about it after. It's called quality assurance. Okay, but not state mandated quality assurance. It's a very specific kind that I will happily discuss with you after. All right, now as far as your office staff productivity, create a bonus system, because I deal with this a lot. I have about a dozen clients that I was actually, since 4 this morning, sitting out there waiting to have a meeting with the panel, discussing this very issue. You tie performance to a bonus, okay? So as long as you make their pay based on their ability to produce, then you create and structure it in such a way that they can be the only ones to take it away from themselves. So let's say, for example, you set up a KPI for your recruiter, okay? Let's say you need to recruit, hire, and onboard 10 caregivers and 5 nurses, okay? That's your minimum standard. If you don't meet it, you lost your bonus. If you meet it, great, you've got it. And now if you exceed it, let's take a look and let's prorate it accordingly. Okay, so they have their base pay that doesn't change, but if you tie it to a quarterly bonus structure, some sort of incentive program, now it becomes merit-based, and it'll bring back that motivation. And I've had a tremendous amount of success with this, implementing this in a lot of my clients, everything from small home care agencies up to larger skilled nursing facilities.
Very good. David, I'm sorry, we are out of time. All the questions that came for the panel has really exceeded the time allowed for this session. So all panelists will be available outside the booth here, the stage. But I want to have you share appreciation for them, their responses, and their preparations. Thank you.
Thank you, Dennis.
Thank you, everybody.
Good job, Dennis.
Thank you.
Good job.
All right, guys, as our next keynote gets mic'd up, has anybody posted a picture yet while they were here about the conference? Yay! And did you hashtag it? Health number 2 conf, yay! Both of you, high five. Throwing money, Monopoly money, of course. Both your ways, wonderful. Anybody have any fun plans for tonight, or is everybody flying back? Party, there you go. Says the mom over there. Very good, very good. Well, whatever you do tonight, I hope it's wonderful. And if you are gonna get your chance at the slots, may all the luck be with you. It is that time of the year, right? Magic happens. And it looks like our next keynote is ready, so I can stop my small talk and continue on. Thank you so much again for that last panel and everybody's questions and insight. Moving on, in an ideal world, gender would never stand in the way of quality healthcare. However, even today, transgender and gender non-conforming patients can face many obstacles to healthcare because of stigma and discrimination. In this session, our physician will learn how to understand TGNC communities better while ensuring that their treatment is comprehensive and they are treated in a welcoming setting. This has become a keynote as our panel, for different reasons, they all had to get back home quickly. So let's please welcome our keynote speaker on this topic, Dr. Deshawn Taylor, owner and CEO of Desert Star Family Planning. Please come on up.
Hello. Well, I am very excited to talk about this topic by myself today. There is just so much that physicians can do to help transgender and gender non-conforming people have a better healthcare experience. And so I am a gender-affirming hormone therapy provider. I am the CEO and founder of Desert Star Family Planning in Phoenix, Arizona. And as part of my practice, I provide hormone therapy to transgender adults who are interested in transitioning from female to male or male to female. And during the process of this work, I've also learned so much about how even with transgender care, we think of it on a binary. We think that people want to go directly from being female to male, and that people want to go directly from being male to female, but there are so many variations in between. And so it's so important that we are able to meet people where they are and help them live the best life that they see fit for themselves. There's an estimated 1.4 million transgender adults in the United States, and they're living and experiencing hurdles in trying to access healthcare. Many transgender individuals are traumatized by their interactions with healthcare providers. There is real discrimination that they're experiencing. Some of it, unfortunately, is intentional, but a lot of it is unintentional, because there is just a lack of understanding about what it means to be transgender. And I think a lot of the times people are grappling with their own understanding of these things. But one of the things that's really important that we learn, especially in medical school, and I'm sure this is the case for many other healthcare professions,
is that we are not supposed to bring our own belief system and biases into the interaction that we have with our patients. Our job is to put those things at the door, so to speak, and be present and in the moment and providing the patient in front of us, the person in front of us, with the care that they're asking us for. So whether or not we understand what transgender is or why someone would want to transition, ultimately should not have any bearing on the excellent care that they are expected to receive. The healthcare needs of transgender people are both widely stigmatized and misunderstood. And so what we want to be able to do as providers is create safe environments for people to not only come to us when they absolutely are in dire need of care, but also feel comfortable enough to get their preventive health services provided. So as a gynecologist, I was strongly inspired to provide female to male transgender care. We hear a lot about transgender women. There are a lot of celebrities who are transgender women, but we don't hear very much about trans men. And so I felt that this is probably a really underserved community that I, as a gynecologist, have a sweet spot that I can take care of. Because most people who are female to male transgender are not undergoing surgery. They still have their reproductive organs that still need care and screening. And so what I have found during the time that I've been providing gender-affirming hormone therapy is that there are people who are providing trans people with hormones, but sometimes some of the preventive health pieces are not being adequately addressed. So for example, a trans man still needs to have their first pap smear for cervical cancer screening at the age of 21. Trans men still need human papillomavirus vaccinations. All of the things that we would do for a cisgender female, we need to be doing for our trans men. Another important aspect of this is that now that it starts to become more acceptable for people to be out, where you're going to learn that more of your patients are actually, at minimum, non-binary. And what does that mean? That means that they are not considering themselves necessarily male or female. Some may lean more masculine or feminine. Others may feel different, when they wake up in the morning day by day. And so what's really important is that we respect and ask for their pronouns and use them. Every single patient, whether you suspect that they are LGBTQ+ or not. What I did in my practice is that once I started providing gender-affirming hormone therapy, I wasn't going to say, okay, is this a gender-affirming care patient or not? All patients, all of the forms got updated. Everything asked for pronouns and preferred name. That's the minimum thing that we can do to make gender non-conforming people feel comfortable in our practices. Another important thing, especially as a gynecologist, it's really women-centered, right? And so really, even prior to providing gender-affirming hormone therapy, I had already created an environment where males felt comfortable being in the OBGYN's office. And so trans men then, by extension, had a level of comfort when they were coming into my office for care because it wasn't overly feminine. Definitely, I've created an environment where it's pretty gender neutral. The colors, the photos on the walls, art, and things of that nature reflect all various types of populations of patients that I see. So for example, I have a nice rainbow sunset in the hallway. So that's a nod to my LGBTQ+ people that I'm an ally. I have a trans flag in one of my intake rooms. So that lets my transgender people know that, I'm here for them. And once it became widespread by word of mouth that I was a family provider, now I see an increasing number of people in my practice who are specifically seeking me out because I'm a safe provider for LGBTQ plus people. And so, and then people are now starting to be comfortable having these conversations about, well, I'm lesbian, my partner is a transgender female, and I think I might be transgender. And this is not something that this 40-year-old woman had ever spoken to her gynecologist about previously. And she was having some level of dysphoria around trying to figure out exactly how she was feeling. That became a bit more in top of mind once her partner started to transition. And so I want you guys to understand that in 2021, the Williams Institute School of Law conducted a study and released information about 1.2 million LGBTQ plus adults. And, well, actually, to correct myself, they surveyed LGBTQ plus adults, and 1.2 million of them stated that they were non-binary. So a lot of times when we think about LGBTQ plus people, we think about, okay, someone's gay, someone's lesbian, someone's bisexual. But the important thing is someone's gender identity, who they feel that they are on the inside of them, has nothing to do with what their sexual preference and sexual orientation is. They are completely unrelated. So someone can be a transgender male and be a gay man. And it doesn't mean that that person was a heterosexual female when they were walking through the world as a female. They were still a gay man in their own identity. And now, as an adult, being able to then have their expression match on the outside what they've been feeling in the inside, now they are outwardly male, and they have a sexual preference for men. And now on the outside to the rest of the world, they're a gay man. And so that's a nuance that it's really difficult for people to understand. But if you remember anything from what I'm saying to you today, is that someone's gender identity is who they feel that they are and how they want to express themselves to the world. Some people would like to present masculine, some people would like to present feminine, but some people want to be ambiguous. So sometimes you'll see an individual with a full, nice shaved, shadowed beard and nails and a little bit of lipstick. That's their expression. That's who they're wanting to be. It's really not our business. When we're having a conversation with them, we respect what they want themselves to be called, and we respect their pronouns. And then we share ours. I get misgendered all the time. My name is Deshawn. And I've only met 2 other females named Deshawn. So on email, on telephone messages, on letters, I'm Mr. Taylor. But we don't think twice about that, right? But this happens all the time. Why do we feel so bad or feel some strong emotion about it when it's a transgender person or someone who's gender nonconforming? What is so deeply rooted in us that we have a problem with this? And we have a problem being corrected by it. When people say Mr. Taylor on text message, I say I'm a female. Oh, I'm sorry, it's okay. Now you know when you refer to me, I'm a female, right? And it's the same for our transgender brother and sister. Based on this study that was conducted by Williams Institute School of Law, 11% of LGBTQ people were adults, 78% of them between the ages of 18 to 29. 68% of them said they did not have enough financial resources to make ends meet. 41% reported that their health is in poor or fair condition. And so these are people who are walking among us, and they're struggling, and they're struggling on multiple levels because of the stigmatization of who they are by society. And then that internalized stigma that's not allowing them to seek the care they need for fear of further traumatization by people who may mistreat them because of their lack of understanding of who they are and that they even exist. And so some of the things that I would like for providers to consider in making their spaces safer for gender nonconforming people is think about the messages that your space is putting out to all of the people that you serve. Do your spaces make all types of people feel welcome? If you are a space that sees men and women, are there images that show single women, not just couples? Do you have LGBTQ imagery in your office? Like, do you have 2 men in a picture or 2 women in a picture? Are you furthering heteronormative values in the space that you're providing? There's a growing number of young adults who are identifying as LGBTQ+. And so that is a significant population that we're turning off and not serving excellently and not culturally appropriately when we're not showing them, when they don't see themselves represented in the medical space. It's really important now more than ever that we have things like very obvious and visible non-discrimination policies that all of our patients can see, so they understand that this is a space where we're not tolerating discrimination based on age, race, ability status, anything of those nature, because there are so many different marginalized groups who are having negative interactions in the healthcare setting and they're being harmed and they don't feel empowered enough to let you know. So starting off with something as simple as a visible statement that lets people know that you are not going to tolerate their mistreatment based on their identity, whichever type of identity that their body is holding when they walk into your clinic or your health center, is a good direction to take. Another important thing is to know about your LGBTQ+ resources in the community so that you can also refer your patients to resources. You don't have to be well versed on what everything is, but definitely know what the major organization or chapter is so that your LGBTQ+ patients can get plugged into community, where they can also receive additional resources that you may not be privy to or be able to refer them directly to from your clinic. The social and economic marginalization of transgender and gender nonconforming folks is widespread and only exacerbated by a lot of the anti-trans policies that are going around politically. And so it's specifically around youth, but they have widespread impacts about how we practice medicine for gender nonconforming people overall. It has impacts that span way beyond healthcare into education and some other areas. And so, those of us who feel like feel really strongly that we want to have a positive impact in this space, definitely make your voices heard with your state legislators or organizations that work with legislators, like your local AMA and other professional organizations, so that the community knows that physicians are there for them and are holding the mantle for them. And so I did expect to have another person with me to do a chat, so I didn't prepare 50 minutes worth of remarks, but I would love to share a couple of stories about my experience, and then I can also take questions to round out time. And so some of the things that I have learned being a gender-affirming hormone therapy provider is, again, that I was thinking of transgender care on a binary, and most adults who are LGBTQ are not binary. And so there was so much to learn about, okay, you just want, for example, a female to male, you just want a little testosterone, you want to be a little bit more masculine. You don't mind having your period, where the other female to male person is like really distressed when the period comes and they want their period to go away. Another, honestly, thing that I wasn't aware of and had a bias about is, female to male transgender people are still using their vagina for sex, and I was so surprised. And so testosterone is not birth control, and testosterone is also teratogenic. And so it's really important to know wherever your patients fall on the spectrum is if they have female pelvic organs and they're having sex that involves sperm, then a discussion about birth control and their intention or not to be pregnant is part of every encounter. And I just recently placed an intrauterine device for my female to male transgender patient. And I wasn't sure how he was going to do because of all the things you hear about dysphoria and people's concern with pelvic exams and those type of things. And what I found is all they want from us is compassion and honesty and patience. And so once they've developed that trust and bond with you as their provider, then you will get through the exam that's necessary. You will do the things that you need to do for them to keep them healthy, and you get through it together. And they learn from me and I learn from them. And so it is an extreme honor and privilege to be trusted with the care of LGBTQ plus people. And I hope that many more physicians will become comfortable with being an intentional ally to transgender and non-binary people in your practices. You don't have to have special training to provide gender-affirming care. You just have to have an interest and really care. There are a lot of resources available where you can download the information that you need. And as physicians, we have the tools in our toolbox to be able to understand. As an OBGYN, I understand the hormones. And I know the side effects. And I know how to take care of people. So it wasn't a huge leap to decide to do the care. It was really just a matter of making sure the space is safe and that my staff are not misgendering people and upsetting people at the front desk before they even get to me. That's a huge thing. You have to bring your staff along. They have to have education and understand how to interact with people. And sometimes you have to work through some biases and misgivings that the staff have. So some intentional training there, because you as a provider, we have so much knowledge and understanding, but our staff have to be brought along oftentimes, so we want to make sure we're doing the work there. And so with that, I'll take questions if anybody has any. Okay. So I want to just go ahead and close and give some people some additional networking time or whatever, because these sessions go back to back to back to back. And just share one more story before I go. I've learned that there are some hiccups along the way that I'd like to share. A big one is insurance. Insurance is supposed to cover gender-affirming care, but there are still some insurers that are a bit problematic, and so sometimes will require some additional work to get claims paid, especially for female to male transgender patients who have changed their gender markers. And that is something that I'm still working through as a gynecologist in terms of coding these claims to actually get paid. But if there is some type of lobbying or education or whatever supposed to happen to get insurers to do better, we definitely, physicians providing gender affirming care, need to be working toward that. Because as long as someone still has female pelvic organs, those female pelvic organs still can become diseased, and we still have to do screening, and we should be paid for that care. And so that was that's been a huge thing that I've been working through in my provision of gender affirming hormone therapy. Yes, there's a question.
Yeah, I have a question about, I guess, cancer rates. Are they different? Should physicians be more cognizant of what to screen for in this population?
So at this point, there isn't any data that suggests that there is any difference in cancer rates. The recommendation is to do the routine screening as based on the reproductive organs that people have based on current guidelines. There is a paucity of research, though, on transgender people in general. And so a lot of the data that we're working on is based on studies in cisgendered population. But right now, there hasn't been anything that's come out to say that we need to do anything differently. There is something related to male to female transition, and that we do want to have male to females having mammograms because of the growth of breast tissue there.
Thank you.
So I'm a physician in Texas, which is a real hotbed of bigotry against transgender people in general. And we've had a recent decision by the courts that allowed, we have our Attorney General, our Lieutenant Governor, and our Governor campaigning very vigorously against allowing gender-affirming surgery or treatment, but a recent court decision that allowed the physician at Dallas Children's to continue doing that. One of the things I'm hearing from people that I know who are parents of kids in the age group, in younger age groups, preteen and teenagers who are expressing ambivalence, is that this is just a fad. These kids, my kid really isn't transgender. I've heard that from several. And I'd like to hear a little bit about how you respond to that when you hear that. And then a personal vignette. I have a 9-year-old grandchild. My grandchild is an out-of-the-box thinker and has been since she's about 4. And so we visited her in California recently, and she was dressing very masculine, let's put it that way, the stereotype of male dressing, and rejecting dresses. And my wife was making a big deal of it, and I said, wait a minute, figure out where she is and who she is. She's really figuring out right now who she is and what she wants to be. Let her be that, let's see where it leads. So 2 weeks later, she went to an event and dressed up in a fancy dress. So, in her case, it really was, she was figuring it out. But I do feel for those parents who are in that stage, and somebody like you who has the experience probably can help us all with understanding how to deal with parents or our own kids and grandkids when they go through that. Thank you.
Thank you for that, and thank you for sharing that story, because I was having a conversation with someone recently about that. I was a tomboy, so I rejected dresses, but I love them now as an adult woman. So, so I specifically chose to provide gender-affirming hormone therapy to adults who, through an informed consent process, because it is very challenging, mainly to address parents and their concerns around their children and their gender identities. What I can share from my experience as taking care of adults who are transitioning is that they knew when they were in elementary school that they were transgender. And they spent the majority of their childhood in distress, about not being able to express who they were, constantly being misgendered because they didn't feel like they were in the correct body. And so now as an adult, they're in therapy, they're on multiple medications for their emotional and mental health. And when they start the hormone therapy and they start to feel like they're taking control over their identity and their expression in the world, and that especially once the secondary changes start to occur and that outward expression when people are look at them and say that they're who they believe they are, their mental and emotional health improves. And I've seen it in my own practice. And you know, it's hard when you're looking at your child, and there's a lot of discussion around when is it too early to do surgery? Is it too early to start hormones? And it really is a matter of if you create the relationship of open communication where your child can tell you who they are. I will say that as an adult gender affirming care provider, many adults do not have surgery. So I don't know how, you know, I haven't formed an opinion about minors or people who are not adults having surgery to change who they are. That might be something that's probably a better idea once they're adult and they can, you know, do full informed consent about that. But I can say that people, adults who are very distressed, have been distressed for most of their childhood.
I sort of have an answer on that. It really does depend on the maturity and the ability to abstract. Kohlberg, part of my training is in adolescent medicine. And so Kohlberg, years ago, surveyed large samples of people internationally about the ability to think abstractly. And there are instruments available where you can assess the ability of a person to abstract and to understand the consequences of their action. And in our society, the mean age for doing that, and it's probably a bit younger now, was 16 when Kohlberg did his work. It's probably younger now, but you can do that sort of assessment, which helps you guide you on whether this child is ready, or this person who is still a child by our rules is actually mature enough to make that decision on their own. And this is a case where I think the science can drive where we go with that. The pushback that we're seeing, frankly, from the politicians is completely irrational. Yeah. It's totally unethical because it interferes with the ability of physicians to deliver compassionate medicine. And unfortunately, those idiots all got reelected.
Yes, everywhere. Thank you so much for that. I will say that I think that is, I love that, because currently for gender affirming hormone therapy for youth, there is a required psychological assessment before hormone therapy is even started, and especially before surgery to transition with surgery. And so hopefully, you know, that type of assessment is happening. And, you know, I hear this contrasting statement about how, you know, we have young teenagers, females, who are allowed to get breast augmentations. And how is that any different than someone of the same age wanting affirmative gender surgery? And so we have to ask ourselves, why is one different than the other? And it really is underlying biases about who deserves to live their outward expression and who doesn't. Thanks.
I just wanted to say I've personally a lot of empathy for people who are looking for a community where they fit in with and they thrive in. I believe that everyone should seek those communities where they belong. And I do want to say, as a parent, I've never met an adult who didn't look upwards to their parents and think like, well, they did, everything perfectly. And I've never met a parent that I've looked at and thought, oh, they are the perfect parents. So I just want to say thank you for electing to serve the adult community on this matter, especially within the pharmaceutical realm, because I think that there's enough challenges between parents and children alone without an external force trying to place a wedge between them. So just I from the bottom of my heart, thank you for electing that decision that you made.
Yeah, and to speak to that comment, it's a fine line to walk as a provider in the middle of relationships between children and their parents. I mean, as a gynecologist, I take care of young women, and they confide in me things that they haven't talked to their parents about. And my job is to be a trusted adult that they can have these conversations with, and also try to move them toward a place where they can actually have these conversations with their parents. And so I personally have, been the constant female influence in a few of my young patients' life, as there have been different women divorced from mom, new girlfriend, now no new girlfriend, and so I think that we don't want to raise that practitioner-patient relationship above someone's parent-child relationship, but I also want people to understand how important that relationship is when youth really look to us as a source of safety, and we can use that relationship to empower them, to advocate for themselves, and also hopefully help bridge the gap between their communication with their parents. Well, on that note, thank you guys so much. I really appreciated the comments and questions, and I hope that you found this information useful.
Thank you. Thank you so much, Doctor, for that unique conversation and clarifying so much. And thank you for all of your perspectives and questions. Moving right along for our last panel of the day. And then, of course, we are going to get to our final awards and recognition session. I can't believe it's already been 3 days connecting with you all. How many of you have learned like 20,000 new things? Raise your hand. Yay, knowledge is power. Wonderful, me as well. So our next and final panel discussion asks the question, healthcare employers as agents of change, can they lead the way in achieving equity? The healthcare industry is known as one of the largest employers in the United States, no surprise there. And with that comes several ethical dilemmas. Right now, there's an urgent call to make the healthcare system more equitable by eliminating racial, ethnic, and gender disparities. But how is this going to happen is the question. To combat persistent biases in the healthcare sector and find answers to these questions, a panel of forward-thinking business executives will present their suggestions. Let's hear it for our moderator, David Nagian, CEO, BrainScanology, Inc. Take it away, David. Making you run. Sorry about that from the back. There we go. Nice to see you back up here, David.
All right, we are here, and it's going to be a great panel, as the panelists have been discussing this topic over the past few days. And I mean, there's a lot of wisdom and insight to be gained and to be replicated, in wherever you are. And so the panelists are on the way up here, but each will introduce themselves and their background. But let me just say that, there's two ways to interpret the prompt or the topic, right, of this discussion session. And that is one, what can employers do to increase equity in the patient population? But another interpretation is, how can employers improve equity in the hiring process of their own institutions. And turns out these two things go hand in hand, because if the people you hire understand your clientele better, then your clientele will receive better service. So we'll be talking about both, because we think both are important. So panelists, if you're ready, please come on.
Let's see, we got 4.
Okay, and since you've naturally picked the order of seats, why don't we just go from starting with Andy,
All right.
and then each person can introduce themselves and their background. It looks like you're all mic'd, so go ahead.
I'm Andy Plumley. I'm an operations efficiency expert. My most recent position, I was the operations director for Island and LaConner Drug in Oak Harbor.
My name is Dr. Lisa Ekole. I am with Dr. Lisa Ekole Inc., doing business as collaborative relational intelligence. I was previously the senior clinical consultant for physician engagement covering the state of Michigan. I was put there by Cigna. But now what I do is I train medical doctors without residency on how to provide value-based care services under the supervision of physicians. I'm also a speaker and a philanthropist.
Wonderful. Carly?
Carly Applegate, founder of Evelyn Elaine. I also I have 75 employees between Wyoming and Montana agencies, and currently serve around 400 clients. So this subject is, I'm excited about this subject.
Hi, I'm Barry Lackman. I'm an independent consultant. I have a company, Lackman Community Development Consulting. In that business, about some part of my business is consulting to managed care companies and providers, particularly, and vendors, particularly in the government-sponsored space, Medicaid, and the marketplace. And the major part of my business now has been working on equity in community organization and building out creative programs to address social determinants of health. I had 26 years as a medical director in managed care organizations. Early on in my career, I organized a mentoring program to increase enrollments in medical school and health professions. And so throughout my career, the whole question of how we increase people from minorities and disadvantaged populations has been part of my focus.
Wonderful. Okay, well, let me ask some questions, leading questions, because I've talked to our panelists, and so there's certain things that there's in their experience I'd like them to highlight. Well, first off, Dr. Ekole, so you spoke at Harvard a number of times, right? And you also, can you tell us about that? And also, you know, the specific clientele that you work with in terms of helping them transition, right, into finding, you know, work and things like that.
Thank you. So yes, I've spoken at the Global Health Summit at Harvard a few times, especially before the pandemic. It was like every year. And basically, I go there to talk about how healthcare professionals can communicate with each other. So I found that there was a big gap in the healthcare industry. So I started off as a pharmacist, and while working as a clinical pharmacist, I noticed that the lack of collaboration among healthcare professionals was costing the healthcare system millions, well, billions in dollars. And coming from a third world country, that really talked to the string of my heart, because that could be a budget for a whole nation. So I wanted to figure out how to solve that problem. As you all know, practitioner-based education does not really focus on interpersonal skills, yet it is an industry where you have to talk to people. So I went on this journey, pursued a PhD in leadership, and from there I developed 2 leadership framework, collaborative relational intelligence and the double rhythm role. From there, I was able to take that knowledge and start teaching pharmacists, nurses, and other healthcare professionals how to effectively communicate with physicians. Physicians have a language, and if you are in the healthcare field, a lot of times they will say, oh, the doctors are not following through with this, they are not doing this. But I realized that when you start speaking the language of physicians, you get their buy-in, everything changes in the hospital. So I've done that, put that into practice, saved millions for hospitals, and that is what I do, and that language has actually transformed a lot of healthcare professionals and organizations. So I get called to speak on this interpersonal and interprofessional leadership techniques that also helps to bring that burnout, because a lot of burnout issues as a result of poor collaboration and communication. So I also use that to train a lot of students in medical school and pharmacy school, and the one thing I hear is, how come nobody told us about this? This should have been the first lesson we learned day one. I also speak to medical residency programs on how to speak to each patient based on the way that they would like to be communicated to. And it's really very simple. And the feedback from those workshops are just so eye-opening. So I think that in this relational age where success, career success is really not, it's just 4 to 10% IQ, but the other 85 is how we relate to each other, because people are looking for good experiences. There are many doctors, we have the internet, and so I think this is the new competitive edge. Thank you.
Wonderful, thank you. And next I'd like to ask Andy. So Andy is an expert in operations and efficiency. He's also a champion in getting people vaccinated. And he had really brilliant ideas that are, I think, out of the box. So Andy, why don't you share a bit about that?
Sure, thank you. Well, you know, Whidbey Island is a rural area. As you can imagine, it's difficult to get healthcare providers in such an area. And when the pandemic happened, what you saw was anyone with any type of healthcare experience went to the larger hospitals where they were needed. So this left a challenge for a small community of about 20,000 people. How do we take care of our community? How do we vaccinate our own? Well, healthcare is very regimented. It's got a lot of gatekeep. Keep a lot of very qualified people out of the industry because they don't have credentials or they don't have specific training. But in this situation, we couldn't do that. So turns out people with really good customer service and really good skills at dealing with patients who may be nervous or worried, such as in a pandemic, they're working as bartenders, they're working as retail associates. People who are really good at following a process and getting something from A to B, they're working as line cooks, they're working as sous chefs. And people who are really good at noticing when something's not right, even when someone's trying to hide all of that, your mothers, right? They know when something's wrong. And they have these skills that are being overlooked. Well, it turns out that you don't need a physician or a pharmacist or a nurse practitioner to do anything when it comes to a vaccine other than put the needle into your arm. The healthcare questionnaires, the monitoring of you after your vaccine, the recording of your medical history, the reporting of it to the state, all of that can be done by people that don't carry credentials. So we created an assembly line. And my team of 7 people in an 11-hour span on their best day vaccinated 1,608 people. We caught the attention of Seattle's mayor, former mayor Janie Durkin, and the Housing and Urban Development Department, Northwest Region. When it was reported that Lumen Field and the National Guard, Washington National Guard, over a 7-day span vaccinated 25,000 people at one of their mass vaccination clinics. But when the reports came out, my same team of 7 in that same time span had vaccinated more than 31,000 people. So healthcare does not have to be a big drawn out process. And it does not require years and years of experience to find qualified, competent, and very capable practitioners in some unique places where we might not be thinking to look.
And let me ask you that. So, I mean, that it requires a certain degree of leadership, right? I mean, you noticed, that talent pool, it was untapped, and so did you by yourself activate them, or did you have to train sort of middle managers to also relay the message?
Well, I think what we did was we trained them for the specific task. And it's important to remember that these are individuals who may have been kept out of the healthcare industry. Maybe they applied to a dentist office or a doctor's office at some point. The leadership didn't take a lot to motivate them because for once they were given an opportunity that maybe in the past they'd have been told you don't qualify for. So they really had a strong desire to prove that they could achieve something that everybody was saying was impossible. And good teams make leaders look better than they really are. And if I'm being honest, I had one of the best teams you'll ever find. So
Awesome. Okay, next, I'd like to ask Carly to share in her experience in terms of hiring the staff and equity and just capitalizing on the talent that comes from her practice.
I think one of the biggest challenges that you see in post-acute care versus maybe acute care is you see a lot of nurses who are really good nurses, right? They're dependable, they come to work on time, and that at times qualifies them for a leadership or management experience. And then they fail at that, and the cycle just repeats. And so, that puts that doesn't just put those clinicians at a disadvantage. It puts everybody underneath them at a disadvantage. The turnover is a disadvantage for that agency or that facility. And so, looking for those leaders that have been hidden, I think is really, really important. It's challenging though too, because providers want to see vetted individuals, right? They want to see the credentials, they want to see the license on the wall, and I found that that's not what you necessarily need. Just because somebody has come out of nursing school with a degree does not mean that they've received any amount of management skill or business acumen. I mean, when it all is said and done, each one of these is a business, and there are some basic standards that need to be met. You need to meet payroll and keep the lights on and keep your vendors paid. And so, really identifying people with just a good foundation in which to build those leadership skills on, but you gotta build them, right? They don't come innately to anyone. And when you do find those people, it's the onboarding process that I think really makes a huge difference, because again, most of my experience being in post-acute care, you bring these employers on, I guess, expecting that your competitor trained them well. And so these individuals, they're getting maybe 4 hours of onboarding, and that includes, the I-9s and W-2s and maybe the background check, but nothing about vision, mission, leadership, expectations, standards, right? They're thrown to the floor, and then again, we wonder why they fail. And I don't think that you can have an equity program without having equity for your staff, right? If you're not taking care of your staff, it doesn't matter, really. I mean, client care isn't going to matter, because if you don't want to make your staff a priority. And so one of the things I always challenge my management team with is, How much time would you spend training, say, a physician? Oh, well, we would have to do this and this and this and this and this. How much time are you spending on training a CNA? Oh, well, you know, maybe a couple hours. We show them where the bathroom is. We show them where to clock in. No, it should be, I mean, we should be really spending the most amount of time with, as far as training, development, leadership, with the people who have the most contact with the clients. And if you do that, then you can start talking about equity. But if that's not your process, having that conversation, having that equity, going to a training, having the policies, you're just wasting your time.
Wonderful. And so let me do a little bit of summary in terms of themes that I picked up before we get to Dr. Lackman. I know you have a lot of valuable things to share. So the theme I'm hearing here is that in order to have equity in terms of your workforce, right? One, you have to allow them to grow into their roles. You say, right? You can't expect them to come in fully trained, never making a mistake. That's just, it's not gonna, first of all, that doesn't even happen even if they're fully trained, right? And so allowing people to grow into the role, okay? And the second thing I'm hearing is that culture has to be intentional, right? Including the culture of allowing people to grow into their roles, training them to deal with, or to interface with clients. And that's something that has to come from the top, right? It has to be defined by the leadership, as opposed to expecting that your competitors have fully trained, your new employee, even though now they're in your company culture, right? So those are the themes that I'm hearing. Anything that I'm missing there in terms of what first three panelists have shared?
Well, I think it's important to recognize when you're talking about the leadership fail cycle, there's a certain protectiveness and resistance to liability with that, right? If I hire that person that has those letters behind their name, then if it goes bad, I at least can stand in front of my boss and say, but they were qualified, right? Whereas, and one of the challenges, like for me, when I talk to healthcare facilities and I show them all of my success, they'll look at it and go, yeah, I mean, yeah, you did all of this in food, you did this in military, but what do you know about running a healthcare? Well, I don't know anything directly about healthcare, but I know how to get the results that you're looking for. I know how to cut out the waste. I know how to find good leaders. I know how to train candidates. And that's what you're missing. Yeah, we really need a clinician that's gonna, keep us liable.
Yeah, and I think that's where people get, one of my best home health administrators is a retired teacher, right? My best clinical director at the moment, and she is a goddess. She's an occupational therapist, and so I again, yes, there's some minimal credentials that you have to have per regulation or state statute, but when we keep those positions in a box for liability, you just
create that cycle.
Yeah, you just create, you perpetuate.
All right, Dr. Lockman, please.
One of the things that I've learned from my community organizer training is that change and positive change is fueled by anger. It is people who are angry who want to make change. There's a large difference between anger and rage. Rage just provokes reactions and it doesn't lead to progress. But anger is good in people because they can use the energy from that to produce change. And so as I've been reflecting on my career, early on I would have the reaction, oh, this person's not measuring up, and forcing them out. But when I forced people out, I let them know why, and several of those people came back to me and told me how much it changed their career and made them successful in the next place. Later in the career, I would identify those individuals with that anger that bordered on rage early, and I would sit down with them and say, I love your energy, I love your desire to produce change, but here's how your rage is getting in the way. Let's work collectively to use your anger to produce the change that you want, without the rage. And that for me was enormously successful. The people I've worked with in that are, you know, quality director for a major healthcare system now, progressed up through the works, the compliance director for a large HMO, because they were able to take what they were learning and build on it. And those are still the people I'm connected with on Facebook and LinkedIn and all, and because we have that mutual development of the team. The other thing is that one of my staff members in my previous job told me that I was not an out-of-the-box thinker. She said, because there is no box. And I think a part of it with people who are creative is encouraging their creativity with keeping them within the bounds of the possible. And to do that, you have to help people build. So to your point, you need to have a training program that encourages individuals to follow their passions in the job, to promote the kind of growth that brings your company and yourself forward.
Wonderful. So all that takes me back to what Dr. Eckley talks about, what she does in terms of training, right? So the theme I'm hearing across these panels is that you have to be attentive in seeing what that person's anger is, not what their rage. And that quote unquote anger could be that they're great caretakers, right? You're a top caretaker, right? Or that they might have skills that aren't credentialed, but they're great at getting people to access medical care.
I want to follow up on the anger rage thing with an example from people we all know, okay? The two people who some of you may not know. Everybody knows Malcolm X. Malcolm X was able to translate his youthful rage into anger to produce change, okay? At the same time that Malcolm X was prominent, there was an author by the name of Eldridge Cleaver. Eldridge Cleaver wrote a book called Soul on Ice that was very popular. Cleaver never went beyond his rage. Everybody knows who Malcolm X was. Does anybody here besides me, know who Eldridge Cleaver was? There's your example.
All right, and so we recognize someone's potential and we grow that potential. But I think that the recognition process itself is a skill that needs to be developed, right? I think it's part of leadership skill, right? And of course, Dr. Eckley, is that part of what you train people to do in terms of, interpersonal communication?
Yeah, absolutely. And just to piggyback on the feedback, studies shows that a lot of managers, directors don't take time to give feedback to their employee. So imagine the feedback that, your employee got, right? And if we have an institution where this feedback is given regularly, in CRQ, Collaborative Relational Intelligence, we call it care fronting, where you provide accountability in a caring manner. And the example that he gave, he never attacked the person. He talked about the issue. And if you do that consistently with everybody in a just way, and you do that by asking open-ended questions, everything begins to change in your organization. But the key is you have to, first of all, realize that it has to be done. You have to make sure that you're doing it in a caring way. The other important aspect of providing feedback is understanding the personality of each person. So for example, there are 4 different types of personality that generally I would train on. And there is the one that when you're talking to them, you talk to them in terms of what is in there for them. If you do this, what is in there for them? There are some that you want to talk about who will be there with them if they do it right. And then the other one, you're talking in terms of, how they can come in and support an issue. And then the 4th one is you are speaking to them in terms of why. The reason why a lot of leadership and teamwork has just become something like, how do I call it? It's just like basically nonsense, because you hear teamwork, collaboration, and it doesn't really mean anything to employees anymore. It's because nobody really understands what that is. But when you start working with people from an interpersonal level, everything else falls in place.
Wonderful. Yeah, and that, the story Andy told about how, he was able to train up people who weren't credentialed, but who were great at, getting people to access vaccinations. And essentially, you said a lot of it is they have skills in the service industry, right? They're the bartenders, and I also mentor a number of students. Before I was a computational biologist, I was also an education consultant, and I once worked with this, female student, high school student, and we were working on her resume, and I asked her, what internships do you have? And she just turns to me and says, I just serve coffee at a cafe. See? And so I looked at her and said, have you ever heard of the person called the Secretary of State of the United States? She says, yes. I said, well, that person, when the president is busy, the president sends that person to negotiate a ceasefire to prevent nuclear war, right? And so the skill set that is required to prevent nuclear war, you're not going to learn in calculus. Do not send an engineer to negotiate a ceasefire, right? You send somebody who knows how to receive demands and yet smile, right? Like a coffee barista. Somebody walks in and says, I want my coffee super hot, but I don't want it to burn my lips. And as the barista, you're thinking, this person's out of their mind. But you smile. This is, how's your day going, sir? I'll get right to you, right? So it turns out it's the service industry, customer service, is what makes for great leadership, right? Great managers, right? And also great interpersonal skills.
Can I just add one last thing? And that is also very important. You see, right now, patient satisfaction surveys, part of the question will be, did the doctor speak to you in a way that you understood? They're asking those questions about nurses too. So a way to actually help take patient satisfaction surveys up in the hospital is to be able to teach doctors these skills, nurses these skills, that your patients are not going to be the same. There are some that you give them the facts, some that you speak to them in terms of why, who, and how. If you don't do it, you are creating conflict, because the way you talk to one person and they appreciate it, if you do it to another person, you'll be causing conflict. And so when we get to the nitty-gritty of things like that, everything changes, even in acknowledgement. Acknowledging people, there are people that will not want the public kind of acknowledgement. So all of these dynamics are really important in this relational age, in making healthcare more competitive, not just for our patients, but even as healthcare professionals.
I think what you're saying about conflict is really important when we're talking about management and leadership, and when you talk about those skills, right? Because as managers, we like to think that managers and leaders they always make the right decision. They always have the right information. They always know what to do. But human beings all have bias. We all have our own preconceived notions of things, and we tend, even as managers and leaders, to hire people that look like us, that act like us, that think the way we do, because it validates who we are. And one of the hardest things for managers to do, especially when talking about equity and talking about avoid that conflict that comes from, is looking at ourselves and saying, I need to hire for my weakness, not for my strength. I don't need somebody that does the things I do well, right? I'm a very good solutions person. I'm a very good person at coming up with ideas. I am horrible when it comes to mathematics. I am horrible when it comes to organization. And I will overbook myself 3 times in the same hour. So when I hire somebody, it needs to be somebody that is very task-driven, very organized, very good with numbers, remembers dates, remembers who I met when and what I talked to. And if I don't hire that way, then all I'm doing is setting myself up for failure. But so many managers fail to do that because they worry about the conflict that comes from having someone like that.
I need that detail. Oh, go ahead.
Oh, I just wanted to challenge that just a little bit, just because in healthcare, when we're talking about healthcare and equity, right? We have yet to establish equity across the healthcare workers, right? We had the pandemic, and you had, people going out and hanging flags, and nurses and physicians are our heroes and everything like that. And some people have talked about this, and I talked about it in one of the earlier panels too. For every nurse or doctor that you see, there are 10 people in back rooms. They're in the laundry room, they're in the cafeteria, they're cleaning, they're running central supply, they're managing the data. And you know, we've gotten, you know, and I don't know if we've gotten to that place. I can't remember in my entire career when we haven't been to this place where, you know, you may approach somebody at a hospital or a nursing home or a facility and, you know, ask a question like, I'm sorry, I'm just right? I'm just a janitor, I'm just a nurse, I'm just a rad tech, right? Again, there's not a single person in the facility that isn't absolutely needed. Budgets dictate that, right? But, you know, we want to, you know, we want to talk about equity and we want to talk about leadership and we want to talk about these things, but we haven't even established that everyone in a hospital is equally needed. You know, and that's despite race or creed or anything like that. Just by job description, you know, we have, again, and that's all of our faults. It's not one person, it's not one industry, but, and again, this is, you know, post-acute care and such. Oh, you just work at a nursing home. Well, you know, you just work at a law firm or whatever. Like, you know, we've created this internal hierarchy that depletes the opportunity for equity because we don't even recognize all of the different disciplines as equal.
Dr. Lackman.
Yeah, I want to shift it a little bit because one of the things we've not talked about is we've touched on the workforce and the people who are out there who have skills, but a large part of, I got into community health by spending time in North Philadelphia on the playgrounds playing basketball with teenagers, who many of whom were in gangs, who blew my stereotypes as a suburban kid coming from the suburbs. And I saw a tremendous amount of talent that really went to waste because the people were not offered a pathway to achieve more and they lost hope. And a part of what I do now, one of the pillars of our work on social determinants of health is around workforce development. And it's identifying people. We're trying to identify people, as has been said, who have interpersonal skills, because so much of healthcare is interpersonal skills. And our entry pathway in healthcare is community health worker. Community health workers have a very robust evidence that they improve outcomes. But in order to be successful at that, you have to have a lot of people skills. And we are partnering with Dallas College, which is our community college system, and with a program called SkillQuest Dallas. And SkillQuest Dallas has state funding from the JET Fund, they call it, to offer the wraparound services that people need to succeed in middle and higher level education. And we have developed several career pathways that we're trying to develop. One is in healthcare. An example might be that you come in as a community health worker, you become interested in asthma, you pass the asthma educator test, which you don't even need a high school degree, you just need to know your facts and pass it. And then you can go into being a respiratory therapist. You can do the same thing into nursing, into nutrition. And so by doing that, we're creating career pathways through that combination. We have a similar pathway that we've identified with one of the people that I work with who's a developer. And there we're building into the skilled business trades and things like specialized drywall. There are tremendous shortages of people, and these jobs pay $30 an hour. So we can identify people, train them up through the program, and bring them into that. And our last area is urban agriculture, and there we're working with the Texas A&M Ag Institute to train master gardeners out of communities. Those pathways exist for us in so many different places, and this is a way of identifying people in communities, giving them hope, and giving them a way out of their circumstances. One of my key partners in this development, in this work, is a developer who did it himself. Not everybody has the skills that Alonzo Harris has. Alonzo Harris made it out because he was skilled in basketball, played for TCU and got his degree. And then he began building houses. He is now building $250,000 houses across from the housing project in South Dallas he grew up with. We need to create the mechanisms that make it possible for our children who have talents, regardless of their racial and ethnic status, to achieve in American society. And to do that, we have to confront the racism that's part of all of our training. I've spent 50 years confronting mine. I hope I've come much beyond it, but I still learn every day. And we all need to be honest enough to understand what our upbringing and our society did to us so we can be better and so our children and grandchildren can continue the work.
Well, thank you for that vulnerability, Dr. Eckerle.
Yes, what an important point. So let me backtrack a little bit and go back into healthcare shortages. Right now, the Association of American Medical Colleges has projected that by 2030, we'll have about 125,000 shortages in physicians. We have a problem of getting doctors that are qualified, trained, getting into residency. You have international medical graduates that are surgeons, cardiologists from Europe and other African countries that the ECFMG have verified that they have medical degrees. But because, first of all, the way the standard is set, they go through a filtration process where the computer can pick and say you're an IMG, so you don't fit this program. So more than 50% of them are out there without any opportunity to get into medical school. Imagine spending your entire life going to medical school. And I know for a third world country, that is a saving for a whole family. Now, healthcare has opened up to the point where we're going towards value-based care services, whether we like it or not, which means doctors now need extenders to help them capture all of these services. Our doctors are burned out. We all know that. And we have qualified individuals out there that don't even know that there are opportunities for them in the healthcare field. So with that knowledge, I put together a program called the CRQ, 4-Step Value-Based Program. It is an advanced program that trains these medical doctors on 7 skills or value-based care services that are reimbursed by Medicare. And by so doing, they help these physicians capture all these services that they are not capturing. And wow, this has been life transforming. Some of these doctors have been doing Uber, working in gas station. I'm not saying doing Uber or working in gas station is a bad thing if that is what you want to do, because they didn't know that there are opportunities out there for them. By so doing, they are gaining the experience that they need to get into residency. They are able to make money because they are depending on their family members, taking money, applying for residency program after residency program. So when we talk about workplace equity, I think this is an area that we need to look at because access to healthcare in rural areas is a problem. Yet we have very qualified professionals that have been trained to be problem solvers, doing things that we have other professionals that do this here and there. But we have a program in place where we teach them, we go through the process with them, have them use computers that are audit ready, and they are doing a tremendous, tremendous job with the doctors that they are working with right now. My hope is that healthcare professionals, the healthcare industry will start looking at these professionals and making room for them. As a matter of fact, the COVID bill, they passed a law after 20 years to open up 1,000 more residency spots in America, after 20 years. So my hope is that they'll be looking at these international medical graduates, these graduate physicians that have not had opportunities to give them some kind of priority. So I'll end right there so my other colleagues can talk, but this is really a hot topic, and I think that if we're talking about workplace equity, we should also look at areas like that. They are not licensed, but they are qualified.
Wonderful. Okay, so
I
yeah, go
actually,
ahead.
it's an issue not just with physicians too. I mean,
Yes.
I had CNAs who in other countries, they were a nurse or a midwife. and then they come to the US and I mean, I think it's more of a regulatory issue than anything else, absolutely, because, you know, again, they're qualified, but not,
No, it's not.
right, they don't meet the whatever rule that is for that state for their practitioner or, but I'm sorry, I was saying, I've seen other disciplines come from other countries and not be able to practice because of that disparity.
I think it's not just a regulation. Let me clarify that. It's more like the understanding that they can do that. Because some medical assistant can do that. There's no law that says if you have a qualified individual in your office, they cannot help you with chronic care management. So it's not a regulatory issue. It's an issue of education and information in this instance.
I think to add on to that, I mean, you see that across the entire spectrum, right? Because when you talk about socioeconomic standing, you see very intelligent people. The first wave of the pandemic was people that were 75, 80, 90 years old, people that are not necessarily tech savvy. And you had to have everything done through tech portals. So our solution was hire high schoolers. Now, they're not medical professionals, but there's nobody out there better with technology than a high school kid.
That's brilliant.
But when you go and talk to them, when you go to the lower socioeconomic communities where high school kids are going to want to get a job, let's just look at the reality of this. You know, it's kids that are hungry that are willing to go to work after school. They don't even believe they can be in healthcare. Well, I can't work in a pharmacy. I don't know anything about that. I'm going to go get this job at McDonald's because my buddy says that's where I belong. You see the same thing when you bring someone from another country. We've got to change the mindset that healthcare is something that you aspire to be in, and it's something you can grow in. I think that's
wonderful. Oh, sure.
One of the first things I did in community health, we had a effort where I see it's picking up again, interesting because nothing's changed. The percentages have not changed in the last 40 years. But the medical student community in the late 60s took on the issue of minority enrollment in medical schools. And we began confronting the medical schools. We seized the platform of the American Public Health Association to condemn them for not doing it in public health. But we along with it, we had to develop programs. So I developed a mentoring program. And what my mentoring program did is I recruited 50 of my colleagues at Temple Medical School, and they were paired with a student from a local high school. And we then compiled a list of everybody who we could find in who were minority, and there weren't that many, in various different positions. So there was an adult surgeon who was African American. There was a radiology technician, a lab technician. And the job of this student was to sit with their high school student, take them around to see what those jobs were, because to the point that you made, they don't even know those jobs are out there. Everybody thinks they have to go through 4 years of college, 4 years of medical school, 3 to 5 years of residency training to have a career where you earn a decent job in healthcare and to do good, and you don't.
That's true.
Wonderful. Okay, we're reaching the last 9 minutes, and I want to close the last question. I want to take this to another level of realness. So we've talked a lot about leadership and what to do. The thing is that we're human. And I myself many times have said the wrong thing and stuck my foot in my mouth, right? And a previous panelist talked about how he had to learn to forgive his coworkers, and that saved the company from tearing each other apart because they were all CEOs. So can you tell us stories about what are opportunities? Say you make a mistake. How do you make up for that? I'm sure we've each stuck our foot in our mouths plenty of times.
I would say that you can't make up for a mistake. You can acknowledge it. You can say that wasn't the intended outcome, or that didn't go the way I thought it was, or just I was wrong. And I think that carries a lot more weight than trying to fix the past. And if you operate with positive intent, if you invest in your team, if you give them the space to make mistakes, a young teenage kid working in a pharmacy for the first time may say something to an elderly patient in a, when it's rushed and not realize how that came across or how they felt disrespected. Well, you don't fire them, you don't belittle them, you don't say, you don't belong here, this isn't right. You say, as your leader, I failed somewhere because I gave you a platform that allowed this to unfold. So let's sit down together and let's figure out going forward what our game plan is going to be. And you give them that space to take that same ownership. I made a mistake. I said this. Okay, wonderful. And now let's move on.
Wonderful.
Very important question. So in the collaborative relational intelligence leadership framework, the 10th branch, the 10th leadership branch is self-introspection. So what I teach and what I practice that has been really effective is at the end of the day, I just make time to self-reflect on my day. When somebody lies to you is one thing. When you start lying to yourself, it's self-indictment. And I just kind of replay myself and I ask myself the honest question. In this conversation, did I relate to this person the way they would have liked to be related? Because sometimes you don't make a mistake, you don't think that you've made a mistake because you feel that you've treated people the way you would like to be treated. In this age, if you treat people the way you would like to be treated, you will feel cataclysmically. Are you really relating to them? Did you respond to them the way that they would have loved you? And if honestly, I realized that maybe I did things in a way that needed adjustment, if it is something that I can apologize, the next day I'll have a game plan. There are some things that I just pray about it and then I plan about what to do tomorrow, not to repeat that mistake. And I just baggage it and put, as you said, you cannot undo a mistake, but what do? I try not to take it forward the next day or apologize or have a conversation. And that regular habit of just having self-introspection and going back and thinking through things has been transformational. And I get a lot of feedback from people that put this into practice, how well it has transformed them and how it's made them more self-aware, put them in the presence.
There's a running joke in my company. It's been 45 minutes. Carly must have made a mistake, because I don't know. There's a day I don't screw up, and it's just one of those things that you just kind of embrace, right? Perfection doesn't happen, and it shouldn't be expected. And if I screw up, I fall on my sword. I go to the person I screwed up with, whatever it may be. But that also has to be coupled with love, too. You don't have to like your employees sometimes, but you do need to love them. There is a difference, right? They need to know
That's deep. Yeah.
that you are, a safe space. People make mistakes all the time. I would rather have 100 employees that make 100 mistakes every day than somebody who's hiding it. Somebody who's pushing it under the rug, or, I want to have 100 employees that learn from 100 mistakes every day, and really embrace it. So, again, I make mistakes every dang day. I mean, it would be a miracle if I gone through 24 hours without screwing something up. But I think just, again, not just being the expectation that everybody's going to screw up, everything's fixable. As long as you didn't lie, everything's fixable.
Flexibility.
You can look as a mistake as an opportunity to do better. And I think that acknowledging that mistake and moving on, and I think the point that faith teaches us a lot, and my faith, Jewish faith, we have the concept of repentance. The whole idea of our most important holiday is acknowledging your mistakes and even the ones you don't recognize, and seeking forgiveness of them and seeking forgiveness from the person that you wronged. And then most important of all, committing yourself to trying to do better the next time. Another thing that's important to realize is God's the only perfect thing. I'm not perfect. And if I am not making mistakes, that probably means I'm not trying hard enough to make change and make things positive happen.
Yeah.
Wonderful. Any questions, please line up with the mic. We have a few minutes left, but Oh, we have a lot of time. Okay, never mind. Don't line up. Sit back down.
Yes, it's 3 minutes.
Yeah, we got the ticker coming at us.
Yeah, that's right. That's
so
very
14
misleading. EV team. That's very misleading. Okay.
So we have, okay. I was going to piggyback on an important point that you made about we are prone to hiring people that are like us. So, and then you added, what you did, you added another reason how, why bias can come in workplace. So it's true, it's really very true that we have to be careful not to just always want to go for people that are like us, but look for people that are different from us that can help us be a better team. Because, there's something called unconscious bias and we all have it. People like people that are like them or people that they want to be like. So even if somebody was to hire maybe somebody that cleans the floor, if they have that outgoing personality, they'll be drawn to them more. But if you are conscious and you challenge that unconscious bias in you, you are looking for somebody that is different, that would do that task the way it is. So this is what happens. When you see somebody, there are filters in your brain that will either delete, distort, or exaggerate information. And you will do that based on how you were raised, based on your personality, based on so many different things. So those challenges are there. So I like it when you said, be careful not to just go with who is like you, because it means you are being conscious to challenge that unconscious bias that is there. And that's also really very important.
Well, and to clarify, with the unconscious bias, again, in healthcare, we have that unconscious bias with just the roles or the departments. You may have a CEO in the laundry room, but if that staff is not equal to anyone else, then you'll never find them,
Are you saying in healthcare that is what is being practiced, or that is what unconscious bias should be?
No. I'm saying that that's what's practiced.
Oh, this practice,
There's
okay.
this untold hierarchy of who is important in healthcare, right? And we spend a lot of time on clinicians. We spend a lot of time on physicians, but there's a whole bunch of people that make a hospital work. And that's what I'm saying. We don't even have equity in our own industry.
And without those people, the physicians, we can't function.
No, absolutely
they
not.
are
But we
absolutely.
don't recognize that. And until we recognize that there is equity in the jobs, in the importance of those jobs, it's really going to be hard to have equity for our patients.
I want to tell a story that's the opposite side of that.
And me too.
So Ron Anderson, the late Ron Anderson, hired me at Parkland in 2001. And right after I got into the job, Ron called me up and said, let's go out to lunch. I want to know how it's going. I'd been on the job like a week and a half, 2 weeks. And I go over to the executive suite at Parkland, and Ron and I head out to have lunch at the local Mexican restaurant where the people who owned it were his patients, it turned out. And as we head out the door, there's a guy there sweeping the floor. Ron turns to the guy and says, Jorge, how is your mother doing? Is she doing better? What's going on with her? And he sits there and talks to Jorge about his mother and the situation. And right away, I was transformed. I gained so much respect for this man because he cares about the people around him and has that connection with people. And, this is the guy who is the CEO of a billion-dollar hospital. And he takes the time to know about the people he works with, about their lives, and to support them. That is the kind of humanity to me. That's the kind of human being I want to be. That's the kind of human being we need to make us propel forward and to create those teams that we need to move the health industry forward.
So I'd like to offer a different perspective when we talk about finding the CEO in the laundry room, right? My father was a janitor, worked in a hospital, worked in courthouses. One of the challenges I think you're facing is you've got to expand what the definition of healthcare is. Because in the 40 years that my father worked as a janitor and pushed around a cart and picked up trash, he was never in the law profession, he was never in the healthcare profession, he was in environmental services. He was a janitor, he was, a sanitary specialist. So he could move up in that realm and he could move to different industries, but he was never considered. So that moving up, when we look at that perspective, if you went to my father, who's a very smart man, probably one of the smartest men I knew, he never would have seen himself moving up a healthcare chain, because I'm an environmental services specialist. That's what I do. I clean your office. And so yes, we need to recognize that there's talent everywhere. But we also have to expand the definition of the industry, not only for ourselves, but also for the people in those industries. He took a lot of pride in what he did, right? When shortly before he retired, because he was sick, he was awarded a golden squeegee, which was a little pin. I didn't understand it, but to a man working in sanitation for 40 years, that meant something. And that meant something to more than ever us being an office manager in a dentist office or anything. He wasn't healthcare. And many of those people may not ever see themselves as healthcare as we look to them to try to create this diversity.
Leadership should, though, right? They're part of the team. They're essential. We need them. Again, it's a kind of a top-down.
Dr. Eckley, go ahead.
Yeah, and I like the word perspective. So we have to look at workplace equity from the standpoint of, acknowledging everybody's role. So we also have to look at it from the nurse's standpoint, the pharmacist standpoint, and the physician standpoint. So I will talk about physician because I've worked with them a lot, and I've done published a scholarly research on how to engage physician and how it changes the dynamics of things. There's a doctor that everybody knew in this hospital I was working when I started working as a clinical pharmacist. Once he calls, they announce everybody in the pharmacy, and we start laughing. Because we know that when he comes, he'll be like, what? He will hang up the phone on you. He will yell. He was this angry doctor. But the only reason why he was like that is because we didn't understand him. So after I went back, pursued a PhD in leadership, and I learned this technique, this doctor started rounding at another hospital. I started literally implementing this technique. He changed completely with me. I had another female doctor pull me to the side and said, what is it you are doing to this doctor? You are literally the only person that you can see he's calm when he talks to, even the CEO. But I was just applying this technique. But in that moment, you will see everything you want from him, you will get. You get it? And so when you start speaking the language of people from an interpersonal standpoint, they change, and they change with not just you, with everybody around them. And then you talked about acknowledgement. One last important point. Even with the doctors too, I realized that when I was running the P&T committee, I started writing thank you letters every quarter. I would thank them for the little things they have done, working with the pharmacy department to help with antibiotic stewardship, and I'll give them a pen that said thank you from pharmacy. And what happened was every doctor wanted a pen, and by so doing, they looked for opportunities to collaborate with the pharmacy, and the medical director asked me, what are you doing in this hospital? We started saving money, relationship change. So there are just some little leadership things that we can do to really transform healthcare that we might not know or we are ignoring.
Do we have somebody who has a question over here?
Oh, is there somebody with a question?
Okay.
No, okay, well, that's it. That's all the time we have. Thank you so much, panelists, for the great contribution. And thank you for the audience. Yeah.
Thank you for moderating, Dave.
Yeah, thank you.
Thank you so much, guys. Way to end our last panel discussion, Health 2.0 Conference 2022 with a bang. Great job. Now it is time to recognize the visionaries in healthcare. You. By means of this special session, we will honor the outstanding achievements of experts and organizations on our global platform. To assist me in this process and help hand out and present the awards, I'd like to bring up to the stage Dr. Amir Mohsen, PhD. Round of applause for him. Would you like to say a few words, Doctor?
Yes, I'm really honored to present on behalf of Health 2.0 with the inspiring slogan of advancing healthcare for a better tomorrow, the next honoree for their accomplishment and outstanding leadership. Go ahead.
Thank you. You are our Vanna White, as I like to say, so we're glad to have you here. Guys, I'm going to call up your name, and please come on up, strut on up. You will take a picture here with Dr. Amir, and you will have some time to chat as well if you'd like to thank the Academy, thank your family, say hello to the live stream, all that good stuff. Also, we are going to have a handful of recipients who were not able to be here, so we will take a moment and honor them, as well as a couple that have sent in videos. And for those, we'll just look right up to the screen and recognize them that way as well. Our first award, without further ado, for outstanding leadership goes to Isaiah Coles, MBA, LAT, ATC, CEAS, NASM, PES, and CES. Are you here? Come on up. Okay, we'll keep on moving on. We honored them. Our next award for outstanding leadership goes to, hey, we just saw him, Marcel Conrad. Marcel, round of applause. He's here. Let's get some of that snazzy award music going too. There we go. Wonderful. Would you like to say a few words?
I just want to say thank you for there's so many people organizing these events. It's a lot in the background happening. It's just not forget those people who actually work to make this all happen. Yeah, thanks a lot.
Thank you. Thank you for being here. Our next award for outstanding leadership goes to Professor Dr. Robert H. Seistel. Robert, here he comes. All right, round of applause, guys. He's here.
Actually, just a small correction. My name is Schistel. And I would like to do something different today. I want to thank all the patients who gave me the honor to cure them and to heal them, and other future patients that I will have the honor to cure and heal them, and maybe I saved some lives. And I would also like to thank all the healthy people who trusted me and used all my products and procedures for them to stay healthy. And I would also like to thank all the future healthy people who will trust my products and procedures to stay healthy. And I would like to thank Health 2.0 for giving me the award. And I would like to wish all of you Merry Christmas and a Happy New Year. And please be kind to each other and to all animals. All creatures in the world really need our love. Thank you.
Thank you. Our next award for outstanding leadership goes to Tracy Oser. Tracy? There she is. All right. Our lady rocking the front row.
I just want to thank Health 2.0 for the recognition of this award. And I want to thank my family and my friends and my colleagues back home in Spokane Valley, Washington. My company, Journey Through Grief, was born out of losing my daughter to suicide 16 years ago. And so we are growing to be a leading company for suicide bereavement support and training for others to provide support as well. Thank you.
Round of applause, guys. Thank you so much, Tracy. Our next award for outstanding leadership goes to Adi Linger. Adi, if you're here, please come on up. Our next award for outstanding leadership goes to Akil Tar, and we have a video that we'd like to play for him as he recognizes his award. Please look up to the screen.
I would like to thank the Health 2.0 conference for this award. My heart is full of gratitude for the recognition of my work and my message about heart disease being the leading cause of death worldwide for 104 years in a row. But there is a solution to eradicate the suffering from heart disease and chronic illnesses like high blood pressure, cholesterol, diabetes, obesity, and certain cancers. When we start eating a whole food, plant-based vegan diet, we are not only preventing and treating the cause of the above illnesses, but also reversing these diseases and on our way to healing. Thank you all who have supported me, including my lovely wife, Nafi, and our family. I'm grateful to the Conference Awards Committee, the support of my book buyers, and for every opportunity ahead of me to share the hope of making a bigger difference, seeing people live healthier and longer lives with purpose, passion, and positivity. Thank you.
Wonderful. Our next award for outstanding leadership, she is not able to make it today, but of course we want to honor her, Anna Paula Gomez. Congratulations, Anna. Our next award for outstanding leadership goes to Badal Shah, and we have a video. Please join me in looking up to the big screens.
I hope you're enjoying the conference. I really apologize. I'm not able to attend this conference in person due to some personal reasons. But thank you so much, Health 2.0 conference, for honoring Neolitica and Q Pharma for their contribution to the healthcare community, especially the pharmaceutical industry. It has been absolute pleasure serving this community, especially during the COVID times, where we came up with some innovative solutions and also played a pivotal role in coming up with the entire launch strategy for one of the COVID treatments that impacted millions and millions of patients throughout the globe. As they say, no leader is good without its team. And I have been blessed with one of the best team that one can get. So I dedicate this award to my team at Neolitica and Q Pharma, who have been instrumental in helping Neolitica and Q Pharma serve this community and the patients throughout the globe. And we are hoping to do the same in coming years. Thank you so much. See you. Bye.
Wonderful. Congratulations. Gotta love technology. Our next couple of awardees are also not here, but of course we'd like to mention them and congratulate them. Our award for outstanding leadership goes to Chelsea Ross Wilkerson, as well as Chitra Subramaniam, PhD. And our next award for outstanding leadership goes to Dana Kellerman. And we have a video for Dana right up on our big screen. So please join me in looking up.
Hello, everyone. I'm truly honored to receive the Outstanding Leadership Award from Health 2.0. Special thank you to my amazing family, my husband David and our daughter Deidre. Your support and encouragement is truly instrumental to me. I also want to thank my colleagues at Frontier Psychiatry who are making a difference every day in the healthcare profession. And I'd be remiss to not thank the lousy leaders I worked for over the years, since they taught me how not to lead. And trust me, they know who they are. But on a serious note, we know that leaders are rarely born. They're made. Each of us has a duty to teach and help form impactful leaders who are full of empathy, fortitude, and the willingness to listen. Kevin Hall said, "Your gifts, leadership, purpose, none of it's about you. Instead, a life with significance is about serving others. It's about guiding those who need your talents, your gifts, your leadership, and show them their purpose." So I challenge each of you to share your gifts of leadership and purpose and help develop our leaders of tomorrow. So like many of you here today, they too may continue to positively impact our world. Thank you to the Health 2.0 team, especially Tan Mei and Sarika, and congratulations to all the award recipients. May you continue to do amazing things. Stay healthy, stay safe, and have a lovely holiday season. Thank you.
Wonderful, just lovely. It's like she was right here with us, but she had trees in back of her. Our next award, our next handful of awards, guys, we're going to be, of course, honoring. However, they are not going to be here in person. We will be sending their awards to them. We'd like to mention for outstanding leadership goes to Devin Deitch, as well as Farida Abjani, Huma Kwamar, MD, MPH, CMI, Isa Kabir, and next, Outstanding Leadership Award goes to Eric Rizubi from Frontier Psychiatry, and we have a video we'd like to play for him.
Thank you so much. We are extremely honored to be receiving the 2022 Outstanding Organization Award. Thank you so much. We are extremely honored to be receiving the 2022 Outstanding Organization Award. Frontier Psychiatry was founded on the idea that everyone should have access to quality psychiatric care no matter where they live. Too often, rural areas are left behind or forgotten when it comes to mental health care, leading to long waiting lists to see a provider, having to travel long distances, and overcrowding emergency rooms when there's nowhere else to go. We are so proud to continue working to ensure that everyone in rural America has timely access to quality care, and want to thank Health 2.0 for recognizing the importance of this work with this award. Thank you.
Congratulations to him. Our next award is also a virtual award. We will be sending it to them in the mail. And congratulating them is Isa Kabir for outstanding leadership, as well as Karthika Parmeswaran, also for outstanding leadership. Now, our next award for outstanding leadership, please join me in looking up to the screen. Jason A. Corning, he's our recipient. He has a video for us.
Amazing opportunity. I wanted to share a little bit about myself. I think this has become more accessible. Thank you so much for this amazing opportunity with this award. I wanted to share a little bit about myself. I think this is an amazing honor. I grew up deafblind, and I was able to get a master's degree studying information systems with a goal of being to help the community become more accessible, to have the community have more access to information and communication, and to feel more included. If you are interested in learning how your services can become more accessible or inclusive, please let me know. I'm more than willing to provide training. I also have developed an app, a mobile app called Mizuru. It's a web app that you can download where people, if they need to go to the doctor or do anything that requires access to information, they can log on, request a time and day, and we will handle trying to find interpreting services within their area. Our goal is to make their lives easier and to have them also feel more included within their community. So again, thank you so much for this amazing opportunity and everything involved with this award. Thank you so much. Have a wonderful holiday.
Thank you, Jason. Round of applause for him. Our next couple of awards are not here in person. However, we are definitely going to honor them. For outstanding leadership, our next few awards go to Matthew Tucker, Sam Perry, Winston Wong, Farm D, and Michael Wolf. And to wrap up our conference with just a few more awards, next award for Best Organization goes to Dr. Alan Preston. I'm told you're here. Here he comes. Yes, round of applause. Coming up strong from the back.
Thank you, guys. I just want to thank again Health 2.0, and I also want to thank Altus Ace for being supportive, allowing me to come here during these last 3 days as opposed to being with my team. We manage about 100,000 patients in Houston, Texas, population health management. So I have to say a warm thank you to my team for being so supportive. Thank you.
Thank you. Thank you for being here. Our next award for outstanding leadership goes to Kevin Carey. Kevin. Going once, going twice. He started the celebrations early. Okay. And our last award for this conference, outstanding leadership, going to Susan Wood. Susan, are you here? Nope. Okay, well, on that note, a huge round of applause for all of our recipients, to all of you guys for being here. Thank you so much. Thank you, Doctor, for helping out and presenting those. Guys, just a couple of quick announcements, and then, of course, we will let you go so you can continue your Las Vegas adventure and time here. Okay. These past 3 days, we've explored groundbreaking solutions to some of the world's most pressing health issues. We've had speakers from leading health institutions around the world and engaged in many thought-provoking conversations and debates. We sure hope that you feel the same way as well. All of this would have not been possible without the support of our sponsors, Outcome MD and Lytic, our fantastic exhibitors, and of course, our notable delegates who attended our event, all of you. So thank you, thank you, thank you. We're thrilled that you enjoyed your time with us and hope you have valuable takeaways to bring back to your team. It has been my honor to host this event, and it was just so great to talk and connect with so many of you. So thank you for that. Wishing you a wonderful holiday and a safe travel back to home, wherever that is. And again, if you have any interest in coming back, which of course we know you do, please feel free to reach out to whoever you've been in contact with or see me after. We are bringing this conference back to Dubai in May, and we'll be back in Vegas in July. So on that note, have a wonderful evening. Thank you, and keep doing the great work that all of you do, truly. Thanks.